speeches fueled inspiration and growth, made us explore, learn, and conquer with new horizons. Without much ado, let's start today's session.
I now request Dr. Annadurai sir, Consultant Psychiatrist, Mercy Hospital, Trichy, and Dr. Nitya ma'am, Head of the Department of Obstetrics and Gynecology, GKNMH, Coimbatore, to chair the session on Diagnosis and Pharmacological Management of Postpartum Disorders. Welcome to the stage, ma'am. Welcome to the stage, sir. We invite our jubilant Dr. John Xavier Sugadev, sir, Associate Professor and HOD of Department of Psychiatry, Government Medical College, Sivagangai, to share his insight on the topic. I request the chairpersons to introduce the speaker.
It's really a great pleasure and privilege to introduce Professor S. John Xavier Sugadev. He is presently the Associate Professor of Department of Psychiatry, Sivagangai Medical College. He was graduated from Madurai Medical College 1987 to 1992 batch. He did his MD from Madurai Medical College 1988 batch. He has done many psychological research works. Among them, few are psychosocial profile of alcoholic suicide attempters, some experience from Yerwadi. He has done some research works, presented some research works in sexual disorders among schizophrenic patients. And apart from that, he has done some research groundwork on bedside cognitive assessments in Wilson's disease. His areas of interest are suicide, substance abuse, personality disorders. I invite Professor Sugadev, my good friend, to start the session to present his paper. Thank you.
Respected chairpersons, senior psychiatrists, postgraduate students and friends. First, I thank IPS Tamil Nadu chapter and the organizing team of the CME program for inviting me to talk on this topic of diagnosis and pharmacological management of postpartum depression. Friends, pregnancy and childbirth is a normal physiological process that we all aware, but it is related with a lot of medical and psychological complications. One among them is postpartum depression. And next 40 minutes, I'm going to speak about this postpartum depression. Though I reviewed many articles, my presentation is based on few selected meta-analysis and structured reviews. And childbirth is a very difficult process that we all aware. A mother goes through a lot of physical, emotional, and psychological experiences during the pregnancy and postpartum period. There are a lot of changes happening in mother's interpersonal and familial world. After childbirth, the mother experiences a lot of emotions from one extreme to the other end. And friends, it is very common for a mother to experience sad mood, irritability during the immediate postpartum period that we all call as postpartum blues. And postpartum blues, the reported prevalence is around 80%, Usually it occurs in the first 10 days of the postpartum period, the peak at the 5th day. And the common symptoms are mood swings, elation, irritability, fatigue, and confusion. There are certain risk factors for the postpartum blues, that is antenatal depression and premenstrual dysphoric disorder and previous history of depression. It is very transient, usually doesn't need any intervention, but the one important thing is it is one of the risk factor for the postpartum depression. To define the postpartum depression, it is an episode of major depressive disorder and temporarily associated with childbirth. And American Psychiatric Association's DSM-5 amended the name of condition as a peripartum depression because they included both the depression occurring in the during pregnancy and immediate postpartum period. And it is a serious psychiatric disorder. It is understudied and underdiagnosed. When I went through the literature, there are a lot of literatures available regarding other psychiatric disorders. There is paucity of data, particularly related with the postpartum or peripartum psychiatric disorders, and the data are very minimal in our Indian continent. And see, we all know that maternal mortality is a very important factor. People working in the government sector, madam, will be aware that when maternal death is happening, how they are reviewing the auditing the maternal death from the primary health center level to the state level. And suicide is very important cause of postpartum death. It occupies around 20% across the world. And depression is one of the most common complication related with the childbirth. And a meta-analytic review found approximately 13% of the women experience major depressive episode during the first postpartum year. And a systematic review of 47 studies in 18 countries revealed the prevalence is 18.6%. And the risk for the postpartum depression in subsequent pregnancies doubled. And the main risk factors for the recurrent postpartum depression is depression occurring within 6 to 8 weeks of the postpartum period, and severe depression, and presence of psychotic symptoms, and presence of manic or hypomanic symptoms. When I went to the literature, the prevalence rate vary from 0.5 to 60%. That is based on certain factors like how the study was done, what were the scales utilized, and the patient population. Like that, the prevalence differs. So, what is the impact of postpartum depression? Postpartum depression, if a mother develops, it affects the ability to play the maternal role and make them to be less responsive in carrying their baby, and breastfeeding and mother child bonding is definitely affected when the mother develops postpartum depression. And the rate of vaccination, baby vaccination or baby's health care is affected if a mother develops a postpartum depression. And during the pregnancy, the untreated depression, there's high incidence of preterm deliveries, eclampsia, preeclampsia, low birth weight, and behavioral disturbance in the newborn, and maternal suicide. The infants also affected by the maternal depression. They develop difficulties in the social engagement or emotional regulation, and increased negative emotionality, and high cortisol reactivity in the later life of the infants born to a depressed mother. And there is an increased risk of long-term cognitive, emotional difficulties and behavioral problems in the children with born to postpartum depression mothers. Then when I reviewed Indian literature, I found the one structured review that was published in WHO World Bulletin. That Indian scenario, this review studied 38 studies, around 20,043 mothers, and majority of the studies were from South India. They found the prevalence rate of depression is 22%, and particularly in southern region it is increased to around 26%. And the main risk factors in these studies they found were financial difficulties, birth of a female child, marital conflict, lack of family support, and past history of psychiatric disorders, and other medical complications related to pregnancy, and low maternal education. These were found to be common risk factors in Indian population, mothers who develop depression during pregnancy and postpartum. Coming to the pathophysiology of the postpartum depression. Friends, postpartum depression is not a homogeneous psychiatric disorder, it is heterogeneous. There are particularly women developing depression during the postpartum period alone. Otherwise, they didn't develop any psychiatric disorder in the past or in the future. So that is a distinct type of a postpartum depression that is having different pathophysiology. But in general, there are a lot of changes happening during the postpartum period. These are the normal physiological neuroendocrine hormonal changes that is happening, and particularly in vulnerable individuals, that resulted in abnormality in the neurochemical pathways of the brain that result in postpartum or peripartum depression. One important thing is epigenetic changes happening in the oxytocin receptor that result in reduction of the that hormones estrogen and progesterone that is implicated in the postpartum depression, and also that reduction in the other metabolites, other allopregnanolone that affects the brain in a negative way. They say there is a crosstalk between the hypothalamic pituitary gonadal axis and hypothalamic pituitary adrenal axis that found to be common in persons developing postpartum depression. And also that neuroinflammatory markers found to be elevated in women developing depression in pregnancy or postpartum period. So all these things interacting in a dynamic way, and it results in depression in vulnerable individuals. To highlight the pathophysiological mechanisms, it is diverse and it exerts influence on one another. And stress and adverse life events are the prevalent risk factors for the postpartum depression. There is a direct influence between the stress and epigenetic implicated in the postpartum depression. Epigenetic and neuroendocrine changes associated with the postpartum depression influence the neuroinflammatory markers, and biochemical changes are linked to the circuit level changes which may contribute to the postpartum depression. Coming to the diagnosis of postpartum depression, there are certain obstacles to diagnose the postpartum depression because most of the depressive symptoms that mentioned in the diagnostic manuals are common in the postpartum period, normal in the postpartum period. So that makes the identify the person suffering with the postpartum mothers. And also that the mother actually when they are diagnosed postpartum depression, they feel less than a mother. So they are hesitant to reveal their depressive symptoms when interviewed. And also family members are not ready to accept. We all know the stigma associated with psychiatric disorders. So when a mother develops a psychiatric disorder, there is a lot more stigma associated with the postpartum depression. So the relatives are not ready to accept that the mother is suffering with a psychiatric disorder in the postpartum or peripartum period. And certain symptoms like sleep insomnia or hypersomnia, loss of appetite, fatigue are common during the normal during the postpartum period. There are, you know that how the postpartum depression is diagnosed. Uh, both the diagnostic system DSM-5 and ICD-11 do not consider PPD as a separate diagnosis. They say that the patient should meet the criteria for the major depressive episode. The time criterion is 6 weeks for the ICD-11 and 4 weeks for the DSM-5. So this is a ICD-11 criteria for postpartum depression. It's all aware that the two major criteria and 9 minor criteria. That they should have at least one major criteria. There is either depressed or irritable mood. Second one is anhedonia. The other symptoms were difficulty in concentration, low self-esteem, hopelessness, and recurrent thoughts of suicide or death, insomnia or hypersomnia, loss of appetite or increased appetite, psychomotor agitation or retardation, and fatigue. And the cause specified in ICD-11 is a mental and behavioral disorders associated with pregnancy, childbirth, or puerperium, with psychotic symptoms or without psychotic symptoms. And DSM-5, the same symptoms, the same criteria that one of the symptoms should be depressed mood or anhedonia. The other symptoms are as described in the ICD-11. And the cause specifier is with the peripartum onset. So these are the difference between the normal postpartum period and postpartum depression or normal or postpartum blues. That anhedonia and agitation or retardation, guilt, and frequent thoughts of death or suicide. These are uncommon during the normal postpartum blues or normal postpartum period. If these symptoms are present, that you should evaluate the person for the postpartum depression. Yes, the diagnostic criteria says that depression occurring during the postpartum period. Are they distinct? Is there any distinct features related to the postpartum? And symptoms of psychomotor agitation or lethargy are more prominent in postpartum depression. And mood lability and preoccupation with the infant, well-being of the infant, that is very common in postpartum depression. And it is usually associated with anxiety and ruminative or obsessive thoughts related with the health of the baby or infant. Considering the incidence of postpartum depression, it is a screening of all mothers during their pregnancy and childbirth is very, very important. And postpartum mothers should be screened not the immediate postpartum period. Usually during the first postnatal visit, that is 4 or 6 weeks after the delivery, or when they bring the baby for the vaccination. During that period, the mothers should be evaluated, screened for the postpartum depression. If they are screened positive for the screening, it doesn't mean that they are suffering with the postpartum depression. That if they have positive during the screening, they should be clinically evaluated, elaborately evaluated, whether they are suffering with the postpartum depression or not. And all women diagnosed with perinatal depression should be counseled, because there will be a hesitation to accept the treatment, and they should be educated they are not less than a mother, and it is a medical disorder. It can be treated and cured. These are the common screening tools available. Edinburgh Postnatal Depression Scale is a gold standard scale for screening mothers for postpartum depression. It is very simple and most reliable. Another things are patient health questionnaire 9 and patient health questionnaire 2. These tools are very used screening because it's very easy to apply, and it takes few minutes to evaluate the person, to screen the person. Since Edinburgh postnatal depression scale is widely used, and a few points about this EPDS. It is one of the simplest and most reliable screening tool, and it is cross-culturally validated. It is having 10 questions. Of course, it is a Likert scale. The points from 0 to 3 for every scale. Total score is maximum score is 30, minimum score is 0. Friends, it is twice as effective as clinical interview in diagnosing postpartum or peripartum depression. And the cutoff score for the depression in the Edinburgh Postnatal Depression Scale, for the probable depression it is 12 or 13, for the possible depression it is 9 or 10. So this is the Edinburgh Postpartum Depression Scale English version. This is a Tamil version. That it's a self-rating scale only. The Tamil version, that the patient is able to, as an educator, able to read, they can themselves they fill and tick the things. The one important thing is, if the person is saying one or 2 or 3 for the 10th question, that is about the social thoughts, should be evaluated in detail. Even if the other scores are 0, should be evaluated whether the person is suffering with depression or not, because suicidal thought is maybe the one single presenting symptom of a postpartum or peripartum depression. So coming to the major part of the management of postpartum depression, the main treatments are pharmacological management, psychotherapy, and it's interpersonal and cognitive behavior therapy is well studied, well researched, and found to be most effective. And other therapies like neuromodulation therapies like ECT and non-invasive brain stimulation and RTMS. My concern is pharmacological treatment of postpartum depression. Friends, I reviewed 4 important systematic reviews. One is a Cochrane database of systematic reviews. Another is a Canadian Network for Mood and Anxiety Disorder Treatment 2016 clinical guidelines. I found it to be more comprehensive and well accepted CANMET guidelines and treatment of special populations women. And another study on recommendations for the prevention and treatment of postpartum depression. And another recent research article on advances in pharmacotherapy of postpartum depression. So Cochrane review. It included OSCTs of women with depression during the first 12 months of postpartum that compared antidepressant treatment with any other treatments, placebo or treatment as usual, and identified 11 OSCTs, 1016 women. Most of the studies were in high income countries, 2 from middle income countries. And most of the studies used SSRIs for the treatment of postpartum depression, and the treatment duration ranged from 4 to 12 weeks. And the meta-analysis showed benefits of SSRIs over the placebo in response, remission, and reduction of the depressive symptoms. And there was no evidence of difference between the acceptability of the SSRI and placebo. That means that SSRIs were well accepted by the mothers. The adverse effects also very minimal. There was no difference between the placebo and treatment group regarding the adverse effects. And data on effects on children, including breastfeeding infants, were limited, although no adverse effects are reported in the studies that reviewed. Cochrane review concluded that the clinicians need to consider study evidence from general population and current clinical guidelines, along with women's illness history, current symptoms, to make an individualized risk-benefit treatment decisions with the particular woman suffering with the postpartum depression. So the Cochrane review leaves this clinician to decide based on the guidelines available. So this CANMET guidelines 2016. And the principles of management of perinatal depression is, and the treatment of major depressive disorder during pregnancy and postpartum period marked a number of unique challenges. And the risk of fetal exposure during the pregnancy and the risk of infant exposure during the lactation, and developed separate sets of recommendations for treatment of depression in pregnancy and postpartum period, and separate sets of recommendations for mild to moderate depression and severe depression. the psychiatrist must balance the risk associated with the fetal exposure or infant exposure and the untreated depression, fetal exposure and the untreated depression during the pregnancy. Because the untreated depression also can have a teratogenic effect. It results in poor nutrition and poor perinatal medical care. Uh, the mother will suffer significantly. There's increased risk of poor obstetric outcomes, the untreated peripartum depression. There will be small neonates and increased neonatal complications in untreated postpartum peripartum mothers, and impairment of infant mother bonding, and there is mild developmental delays in the infants noted, and there are a lot of cognitive, behavioral and emotional problems associated with observed in the infants born to the mothers suffered with depression during pregnancy. And how should depression should be treated during the postpartum period? The first line treatment of mild to moderate depression is either interpersonal therapy or cognitive behavior therapy. And the meta-analysis of studies found that sertraline, citalopram, and escitalopram are recommended based on the efficacy and safety. And the combination treatments with SSRIs and CBT or IPT can be considered. And other SSRIs, new antidepressants, are less preferred given the relative absence of reproductive data and the limited antenatal clinical use. Despite the increased risk of cardiovascular malformations, paroxetine and clomipramine may be considered when there is a compelling reason, like previous good response to paroxetine or clomipramine, or ongoing stability on that medication. That the mother is on a paroxetine during the before becoming pregnant. If the mother is continuing the paroxetine maintained well, you need not stop the paroxetine. You can continue. That is the Kahneman guidelines. And they say that doxycycline should be avoided because the high rate of passage in the breast milk. Because when the mother is taking the doxycycline antenatal period, should continue in the postnatal period, the same medication. Since this relative infant dose is high with the doxycycline, it should be avoided. And MOAs are not recommended because there are a lot of paucity of data, and also that interaction with analgesics and anesthetic agents used during the delivery. And neurostimulation or complementary alternative medical strategies can also be considered as third line of treatment option. And interventions that were previously effective, they are worth discussing as second line strategies as long as not contraindicated. And treatment during the 6 to 12 months after remission in low risk women. The duration of treatment should be 6 to 12 months in low risk, and longer periods for those with a high risk or relapse. Suppose that recurrent postpartum depression may need longer duration of treatment. If they have severe symptoms, suicidal thoughts, they may need longer duration of treatment. If they have psychotic symptoms, they may need longer duration of treatment. And for severe depression, the first line of treatment is definitely pharmacological. That is preferred drugs for sertraline, citalopram, or escitalopram, either alone or along with psychotherapies. Second line, remaining SSRIs except paroxetine. And new generation antidepressants, TCAs, can be used as second line treatment. And ECT can be considered. And combination therapy may be cautiously considered. What are the risks of antidepressants during pregnancy? Friends, the studies are very limited, and the magnitude of teratogenic effects are not completely understood. But most antidepressants not linked to increased risk of any major congenital malformations. They found that increased cardiovascular malformations with paroxetine and clomipramine. But the study says the complications will spontaneously resolve even if an infant develops paroxetine associated cardiovascular malformations. Atrial septal defect is the most common malformation associated with paroxetine. There are other structural abnormalities also can occur with paroxetine. But they say that they will remit spontaneously and will not cause any significant functional impairment in the mothers, in the infants. And fluoxetine there is a small increased risk of congenital malformations if it is used in the first trimester. And for clomipramine, there is almost also a elevated risk of cardiovascular malformations. There is a modest link between the gestational use of SSRIs and spontaneous abortions. Fetus exposed to the SSRIs in the third trimester, there is an elevated risk of developing syndrome is characterized by the poor neonatal adaptations, jitteriness, irritability, tremor, respiratory distress, and excessive crying. Seems to be most of SSRI withdrawal symptoms. And the incidence is 15 to 30%. It is time limited. Usually it resolves in 2 to 14 days and not associated with any increased risk of mortality or any long-term neurodevelopmental abnormalities. And the risk is highest with the paroxetine and fluoxetine because of the long half-life. And third trimester SSRIs, there is a relationship between some studies say that patients may develop persistent pulmonary hypertension, but the absolute risk is 2.9 to 3.3 per thousand. It is not that much elevated compared to the general population risk of 2 per thousand. And fetal exposure to the SSRIs, there are thoughts, the ideas that it increases the risk of autism spectrum disorder in children for mothers treated with SSRI during the antenatal period. But there are methodological limitations with these studies and wide confidence intervals. This requires further evaluation whether there is a really a relationship between autism spectrum disorder and antidepressant use during the antenatal period. The evidence is very weak. Then how the depression should be treated during the postpartum period? Breastfeeding is not contraindicated during the treatment with any antidepressants. The first line treatment is for mild to moderate depression. They say that interpersonal psychotherapy or cognitive behavior therapy. The second line treatment, citalopram, escitalopram, sertraline or nortriptyline. Because the data are for the many data are available for the effectiveness of these drugs during the postpartum period and minimal risk during lactation and least known risk during the childbearing years. Fluoxetine and paroxetine is a third line drug during the postpartum period. The reasons fluoxetine is having longer half-life, slightly higher rates of minor adverse reactions in breastfeeding infants. Paroxetine associated with the CV malformation. If the mother is continuing in the postpartum period, she may become pregnant at any time after 6 months. So the risk of CV malformation during the pregnancy is there. And the other second generation antidepressants can be used as a third line treatment because of the limited evidence regarding with these drugs. They say that doxepin particularly should be avoided because of significant adverse reactions in infants with the breastfeeding, because the relative infant dose is high for doxepin. Now, what is approach for treating severe postpartum depression? The pharmacotherapy is the first line treatment. The choice of medications are citalopram, escitalopram or sertraline. Second line choice, any other antidepressants. Third choice, ECT. ECT can be the first line of treatment. The depression is associated with psychotic symptoms. And mothers can continue breastfeeding during the procedures of ECT. What are the risks of antidepressants during breastfeeding? Exposure to antidepressants in breastfed is 5 to 10 times lower than the exposure in utero. Fetal exposure, breastfeeding exposure is lower than the fetal exposure. The antidepressant used in the pregnancy, when they used in pregnancy, and the risk is high with the preterm infants and with the liver or kidney impairment. So they compare with the relative infant dose and actual plasma level of drugs in infants. For most of the antidepressants, it is less than 10% relative infant dose. If it is less than 10%, that means the drug is safe. And sertraline, fluoxamine, paroxetine have lower relative infant dose and milk to plasma ratios. Citalopram and fluoxetine related to the highest rates of infant reactions, is 4 to 5%, but the reactions were reversible, short-lived, characterized by increased irritability, restlessness, somnolence or insomnia. Among the TCAs, nortriptyline is a good choice. No data exists on MOAs during the lactation. There is a positive data on long-term neurodevelopmental outcomes, and no evidence of significant long-term neurodevelopmental effects of these drugs when used in the postpartum period. So these are the various guidelines, APA guidelines or NICE guidelines or SIGN, Scottish Intercollegiate Guideline Network, and Beyond Blue, that's an Australian guidelines for treating depression. All the guidelines recommend psychotherapy as a first line of treatment, and second line they recommend the pharmacological management. This is a recent research article on the advances in the pharmacotherapy. It's published in 2022. This study reviewed, this is a structured review, reviewed 10 RCTs related with standard care antidepressants, that is SSRIs and other antidepressants, and 5 RCTs related to the hormonal treatment, and 2 RCTs related to the brexanolone, and 1 RCT related with the zuranolone. So these are the studies that reviewed. The evidences were, despite the limited data, there is a consensus supporting the antidepressant use in the postpartum mothers. SSRI is typically considered as first line therapy based on the perceived good tolerability. A meta-analysis of 3 RCTs compared SSRIs with the placebo found that women who received SSRIs were more likely to show symptom response, 52% in a treatment group versus 36.5% in a placebo group, and remission and follow-up. A systematic review of 6 studies concluded that SSRIs, nortriptyline, and psychotherapy are efficacious for short-term treatment of postpartum depression. These are the studies on the hormones and hormone-based therapeutics. The conclusions were there is use of transdermal estradiol. The evidences are limited with the mixed results. Additional data from the large RCT is needed before recommending estrogen as a treatment for postpartum depression. There are fewer data exists on the synthetic progesterone treatment. Usually progesterone is, the conclusion is progesterone is not recommended for treating postpartum depression. And these are the studies on these newer drugs, that is neuroactive steroids, GABAergic neuroactive steroids. There were the 3 studies reviewed, and these are the naturally occurring neuroactive steroids synthesized from the cholesterol in the central nervous system. They are positive allostatic modulators of the inhibitory GABA receptors. And NAS binds primarily to the transmembrane alpha subunit of the GABA A receptors, with potentially having a that effect on the alpha to delta 2 subunit of the GABA receptor is having anxiolytic effect. Sorry, alpha 2. And delta subunits play a larger role in overall sensitization of the receptors for the neuroactive steroids. The available evidences suggest that PPD may be associated with a trigger of rapidly declining neurosteroid levels during the postpartum period and impaired upregulation of the GABA A receptors. Usually there is a high level of allopregnanolone during the pregnancy. There is a fall in the that is having a effect on the GABA A receptors. There is a downregulation of the GABA A receptor during the pregnancy. During the postpartum period, that upregulation, if it doesn't happen, may result in postpartum depression. The manifestation of depressive symptoms based on the GABA deficits that are common to the many depressed patients, not only in the postpartum period. Because certain neurosteroids, allopregnanolone, highly potent modulators of GABA A receptors, the pharmacological effects can be expected to improve the symptoms of depression. So based on these pathophysiological mechanisms, they developed certain neuroactive steroids. One among the drug is brexanolone. The first RCT was conducted in 21 women with severe symptoms. Total HAM-D score was more than 26 in 4 centers in USA. Patients were followed up in blind manner for 30 days. After 60 hours, the mean difference between the groups, that is a treatment group and placebo group, was 12.2, favoring the brexanolone group. There was a reduction in the HAM-D score by around 12.2 in a treatment group. And HAM-D score improvements favored the brexanolone group at 36 hours, 48 hours, 60 hours, 72 hours, 7 days, and 30 days of the treatment period. And remission was observed in 7 out of 10 patients in brexanolone group, but compared to the 1 out of 11 patients in placebo group. There were no serious adverse events or discontinuation in either group. The most frequent adverse effects observed in the brexanolone group was dizziness and somnolence. Based on the 3 RCTs, brexanolone infusion was approved by the FDA in March 2019 for the treatment of adults with postpartum depression. There is an indirect, there was no comparison with the conventional antidepressants, that's SSRIs or other antidepressants, but indirect treatment comparison showed brexanolone demonstrated a more rapid improvement and larger difference in change from baseline of the treatment of PPD relative to SSRIs. The terminal half-life of brexanolone was approximately 9 hours. It is excessively metabolized by the cytochrome P450 systems, mainly by the non-cytochrome P450 systems like keto reduction, gluconization, and sulfation. So even liver pathology will not affect the metabolism of brexanolone, and should not be used in patients with hypersensitivity to allopurinol or other neuroactive steroids, and in patients with end-stage renal disease. So there is a method to, how to administer the brexanolone. It's usually administered in the dosage of 60 microgram per kilogram per hour. To enhance the tolerability, the dose was stepped up and back down gradually over 60 hours. For the first 30 hours, for first 4 hours, 0 to 4 hours, the dosage is 30 microgram per kilogram per hour, and 4 to 24 hours, 60 microgram per kilogram per hour, and 24 to 52 hours, it may be either 60 microgram per kilogram per hour or 90 microgram per kilogram per hour, depending on the tolerability. If the person develops more sleep or somnolence, you may reduce to 90 to 60. And 52 to 56 hours, 60 microgram per kilogram per hour. And for 56 to 60 hours, it is 30 microgram per kilogram per hour. And a lactation study demonstrated lower relative infant dose, that is less, around 1.3. There was no evidence of increased suicidality during the treatment. And excessive sedation was following brexanolone infusion considered as severe adverse event. And since it is administered as an IV preparation, patients should be admitted for at least 3 days. And there are certain adverse effects like increased somnolence. There are few reports of loss of consciousness during the treatment, and high cost with IP and IV treatment. There were studies on orally active neuroactive steroids. One among the drug was zuranolone. Actually, it was recently approved in August 2023. In the study, during this study period, it was in clinical trials, phase 3 clinical trials. And the most common adverse effects associated with zuranolone was sedation, headache, somnolence, dizziness, upper respiratory infection, and diarrhea. To conclude, depression is a common during pregnancy and childbirth. Untreated depression is one of the commonest cause of postpartum mortality, and all mothers should be screened for postpartum depression. And Edinburgh Postpartum Depression Scale is a simple gold standard screening tool. SSRIs are the first line of pharmacological management. Neuroactive steroids are promising and emerging treatment options. Thank you, friends.
Thank you, sir, for providing excellent insight into the postpartum depression. Just an obstetrician's perspective from my side, actually, mental health is not given much importance during our postnatal visits because screening for mental health is not a standard point of care among the obstetric crowd. This is because the knowledge gap exists, and during the postgraduate obstetric teaching curriculum, perinatal mental health is given the very least importance. So probably we should integrate mental health in maternal care so that this doesn't happen. That is why most of the cases go either undiagnosed or under-recognized, because we don't pinpoint depression. And I'm from a tertiary care private hospital, sir. We have included EPDS questionnaire in our case sheets, and during the first postnatal visits, we give the patients the questionnaire. And those with score more than 13, we refer to the psychiatrist. But it is very difficult to convince the family to meet a psychiatrist because social stigma still exists even among the educated crowd. Thank you, sir.
Madam, this Tamil Nadu government recently has initiated the program for the identifying and treating the postpartum psychiatric disorders. There's a postnatal that in all medical colleges, all the mothers should be evaluated by a psychiatric team for any evidences for postpartum depression. Even in our Sivaganga Medical College, we started evaluating all the mothers with an Edinburgh postnatal depression scale during the pregnancy and the postnatal visit. Not in the, actually that most of the time that this was misunderstood. Most of the time that even we were evaluating the persons immediately after birth. Most of the time that normal delivery they stay in the hospital for 1 or 2 days. For following LSCS they stay for 7 days. But assessing during that period will not be useful at all. So that the point is that the mothers should be evaluated during the first postnatal visit. That is a 4 weeks, or when they are coming for that vaccination. That we have initiated in collaboration with the pediatric and OG department.
More time for discussion.
And many medical colleges they are doing, I think.
This is a good presentation by Professor Sugadev. It's a very crispy, comprehensive presentation with much clarity. Good to see a good attendance in the early morning Sunday hours, most of the youngsters. It's nice to see Professor Kumanan, Dr. Zaman, Palanipan and Panniselvam, Dr. Arun Kumar. Nice. The thing is, some of us can discuss about the use of benzodiazepines as an adjuvant in puerperal depression. One thing I want to tell, my interest in recently is the etymology of medical terms. Traditionally, we were taught that and the medical terms are originated from Latin and Greek. Let me say some 2 words related to this puerperal depression. Puerperal means puerperal, P-U-E-R, P-E-R-A-L. Puerperal is periperal. Peri means baby, peral means to receive, to gain, to get profit. There is some words like high parity. Parity means parity you have to read in Tamil as peru adaya. You see the words like multiparous, nulliparous. The parous signify peru, baby. That's all. There is some time for discussion also. You can raise questions or else you can contribute something. Thanks a lot.
Good morning, sir. I have 2 scenarios in need of your expert discussion. One is this happened in our department in Chengalpet 3-4 years back. A primee delivered by LSCS. 7th day, she presented with symptoms of crying spells, withdrawn, not communicating and taking care of her baby. So initially, an evaluation was done and a diagnosis of postpartum depression was given. But still, to look for other causes, we asked them to do a CT brain. But unfortunately, the patient got discharged and we never had a follow-up. The patient went to a private psychiatrist in Chengalpet and they took a CT. The CT was normal. Again, the diagnosis of postpartum depression was made and she was started on escitalopram and clonazepam. After 4 days, she was brought to the emergency department in a comatose state, not responding, and she died. And the postmortem report says there is an extensive bleed in the lungs as well as in the brain parenchyma. So my question is, in a postpartum depression, to rule out other causes like CVT, where CT brain is known to be normal, what is the role of MRI in postpartum depression? So this is my first scenario. The second one, I don't know, OG madam will be the chairperson. My comment was in a tertiary care institute, a government institute, say 1 in 5 or 10 referrals from the OG department. So they refer the person as postpartum depression or postpartum psychosis. When we sit and talk with the person, the incident that would have happened in the labor ward is the mother or the woman would have asked for discharge. The treating physician would have blasted that woman. She started crying. Then they were referred to psychiatry department to evaluate for depression or psychosis. Thank you.
Sir, so the postmortem on the CVT. Lungs in sonar.
Symptoms suggestive of postpartum depression. Diagnosed CT was normal. CT was normal. Yeah. CT was normal, diagnosed as postpartum depression, but in the postmortem finding, we could see clots and bleed in the lung cavity as well as in the brain parenchyma. After discussion with the neurologist and the physician, they told it could be CVT, which was not picked up in the initial CT.
Yeah, that is possible. Sometimes it is, even in CVT, CT may be normal, but clinical evaluation, neurological evaluation definitely will be helpful to pick up some focal neurological deficits. And also that CVT, one of the important differential diagnoses in postpartum depression. The thing is that CVT, there will be change in clinical picture. Even that we say that we get the call over that person is having a psychiatric, there is a Cori conversion disorder or hysteria. Because in the morning the patient will tell that kanne theriyala, onnume paaka onnu theriya maatengudhu. Then after some time, patient nalla theriyudhu apdi solluvaanga. And ஒரு சமயம் கை காலே வரல paralysis. After some time they say that they were able to use the hands. That a fleeting type of paralysis. That is a very common clinical picture in CVT. So any woman in the postpartum period, definitely as Sudhakar said, postpartum sepsis and CVT should be ruled out before diagnosing a depressive disorder, because the treatment is entirely different. If the CVT is diagnosed earlier, and the patient could have missed it. It is because most of them the proper treatment CVT is reversible, could be saved. For the postgraduates, that when you go to the postpartum ward for evaluating the mother, you should keep in mind that always think of organicity. After ruling out the organicity, that most of them that we can suspect by a proper clinical evaluation and clinical examination. So neurological examination is must, and fundus examination is must. That's what we were taught. So that is very important. Very important, that should rule out any other organic causes for the psychiatric manifestations.
Due to lack of time, we finish the session. We thank the organizers. We appreciate the growth and the competency of the Pudukkottai psychiatrists, particularly Dr. Karthik and Dr. Zaman. We welcome our judge madam now. Thank you, Dr. Professor Sugadev.
Thank you very much for your wonderful presentation, sir. Now I request the chairpersons to honor the speaker. Now I request Dr. Sriram sir, Associate Professor of Psychiatry, Thuthukudi Medical College, to honor the chairpersons. Thank you, sir.
We are moving on to the next interesting session. This session will be under the topic of law and psychiatry intersection, navigating Legal Standards and Collaborative Approaches. This session will be chaired by retired Professor Dr. Rajeshwari Ma'am, District Mental Health Review Board, Salem, and our TNIPS President Dr. Paneer Selvan Sir. Kindly come to the stage, ma'am and sir. Please take your seats. I am extremely honored to invite with gratitude and our esteemed speaker, Honorable Tirumadi Vasanthi Madam, Additional District and Sessions Judge of Pudukkottai, to enlighten us on topic Law and Psychiatry Intersection, Navigating Legal Standards and Collaborative Approaches. Welcome, ma'am. I request Rajkumar sir, Professor.
Now I request Senior Psychiatrist Professor Rajkumar sir to felicitate our esteemed speaker.
டாபிக் இன்ட்ரடியூஸ் பண்ணிடுறேன், நீங்கள் ஸ்பீக்கர் சும்மா ஜென்ரல் ஒன்றும் பிரச்சனை இல்லை மேடம். உங்கள் எக்ஸ்பீரியன்ஸை சொன்னீங்க. At the outset, I thank the organizers for giving me the opportunity to chair this wonderful session. And as we all know, the psychiatrists are being called to the court very often to either give the opinion regarding the criminal responsibility of the mentally ill offenders, or intellectual ability of an juvenile offender, or to marriage or uphold the marriage or nullify the marriage, or in the cases of divorce applied by the spouses of mentally ill, or regarding the capacity assessment of testimony capacity or property issues, in either all these, etc., etc. And at the same time, we are also not being called to testify, but also we have become abiders of law, that is by obliging Mental Health Care Act, and also the people with living with the Disability Act, and also as a part of Mental Health Review Board members, we are also enforcing the law by obliging all these rules and regulations, and applying psychiatric knowledge to the mental health, psychiatric knowledge to legal issues, and legal knowledge to psychiatric patients are being discussed in this forum like this only by psychiatrists so far. For the first time, we have included the judiciary people to give their opinion regarding this. I appreciate the effort of the organizers to call the judicial aspect of this topic. With these few words, I ask my co-chairperson to introduce the speaker to the crowd.
Thank you, madam. Once upon a time, the hospital was considered as the temple and the doctor were considered as a god. நீங்கள் தான் ஏன் கடவுள் அப்படிங்கிற காலம் மாறி, today the doctors are considered as a businessmen and profit makers. We should consider all the patients which come to us is a potential litigant. எப்பயுமே நம்ம என்ன செய்யணும், we should always the safeguard ourselves. We should go into the depth of the patients this thing. So today we have excellent lectures going to given by Justice GM Vasanthi, and Madam is an additional district judge and session judge and Chief Judicial Magistrate Court, Pudukkottai. I welcome you, Madam, and give your speech.
மதிப்பிற்குரிய ப்ரொஃபஸர்ஸ், மருத்துவக் கல்லூரி மருத்துவர்கள், பல்வேறு மாவட்டத்திலிருந்து வந்திருக்கக்கூடிய மருத்துவத்துறை பேராசிரியர்கள், ஸ்டூடெண்ட்ஸ் ஃப்ரம்
பாண்டியன், கடலூர். எல்லாருக்கும் என்னுடைய காலை அன்பான வணக்கத்தை தெரிவித்துக் கொள்கிறேன். நான் உங்கள் மருத்துவர் வந்து கூப்பிட்ட பொழுது நான் கேட்டேன், மருத்துவர்கள் முன்னாடி நான் என்ன சார் பேச இருக்குன்னு நான் கேட்டேன். ஜென்ரலாக பேசுங்கம்மான்னு சொன்னாங்க. எனக்கு தெரிஞ்ச விஷயங்களை குறித்து பேசலான்னு இருக்கேன். இப்போது நம்மளுடைய நாட்டினுடைய முதன்மையான சட்டம் அப்படின்னு இந்திய அரசியலமைப்பு சட்டத்தை சொல்கிறோம். இந்த கான்ஸ்டியூஷன் லா இதை அனுசரித்து இதில் உள்ள சங்கதிகளை அனுசரித்து தான் மற்ற எல்லா சட்டமும் ஒவ்வொன்றாக பாராளுமன்றத்தில் ஏற்றப்படுது. அந்த மாதிரி ஏற்றப்பட்ட இந்த சட்டம்தான் மனநல பாதுகாப்பு சட்டம், மென்டல் ஹெல்த் கேர் ஆக்ட் 2017. இது வந்து ஏப்ரல் 7ஆம் தேதி 2017 ஒப்புக்கொள்ளப்பட்டு நடைமுறைக்கு வந்த தேதி 29 மே மாதம் 2018. இப்போது நம்மளுடைய அரசியலமைப்பு சட்டத்தில் பிரிவு 39A ஃப்ரீ லீகல் எய்ட், இலவச சட்ட உதவி, அதாவது பணம் இருக்கிறவங்க பணத்தை கட்டி சிகிச்சைக்கு போகிறாங்க, சட்ட உதவி ஆலோசனை கேட்க முடியுது. ஆனால் நம்ம அரசியலமைப்பு சட்டத்தில் என்ன சொல்கிறாங்கன்னா, அந்த மாதிரி கோர்ட்டுக்கு போக முடியாதவங்க, தங்களுடைய பிரச்சனை எடுத்து செல்ல முடியாதவங்க, ஒரு மருத்துவ சிகிச்சை வேணும் ஆனால் ஏழ்மை நிலையாக இருக்குது, விவரம் தெரியலை, ஆலோசனை பெற முடியலை, வசதி வாய்ப்பு இல்லை, குறிப்பாக அவங்க மனநலம் பாதிக்கப்பட்டவங்க அப்படின்னும் பொழுது அவங்களுக்கு சட்ட பாதுகாப்பு கொடுக்கணும் அப்படின்றத இந்த சட்டத்தில் வலியுறுத்தி இருக்கிறாங்க. இந்த புதுக்கோட்டை மாவட்டத்தில் டிஎல்எஸ்ஏ, டிஸ்ட்ரிக்ட் லீகல் சர்வீசஸ் அத்தாரிட்டி அப்படின்ற ஒரு அரசியலமைப்பு சட்டம் நான் சொன்னேன் இல்லைங்களா, 39A, ஃப்ரீ லீகல் எய்ட், ஆக்சஸ் டு ஜஸ்டிஸ், ஆக்சஸ் டு லீகல் ப்ராசஸ் டு எவ்ரி ஒன் நீடி பீப்புள் அப்படின்றத அமல்படுத்தணும். அப்படின்றதுக்காக தேசிய அளவில் நல்சா, அதில் வந்து மாண்பமை சுப்ரீம் கோர்ட் ஜட்ஜஸ் வந்து தலைமை வகிப்பாங்க. மாநில அளவில் ஸ்டேட் லீகல் சர்வீசஸ் அத்தாரிட்டி, அதில் வந்து உயர்நீதிமன்றத்தினுடைய நீதிபதி அவங்க முன்னிலை வகிப்பாங்க. அதே மாதிரி இந்த நம்ம புதுக்கோட்டை மாவட்டத்தில் பிரின்சிபால் டிஸ்ட்ரிக்ட் ஜட்ஜ் இருக்கிறாங்க. அவங்க தான் இந்த டிஸ்ட்ரிக்ட் லீகல் எய்ட் அத்தாரிட்டியினுடைய சேர்மன். அதுக்கு ஒரு லீகல் எய்டு செக்ரட்டரி இருக்கிறாரு, அவர் சப்ஜெக்ட் லெவலில் இருப்பார். இப்போது நாங்கள் சட்டம் சம்மந்தமாக என்ன செய்கிறோம் இந்த சர்வீசஸ் மூலமாக, அதே மாதிரி தாலுக் லெவல்லையும் இருக்குது, தாலுக் லீகல் சர்வீசஸ் அத்தாரிட்டி இருக்குது. அதுக்கு அந்த கன்சர்ன்டு ஜேஎம் ஆர் முன்சிப் சேர்மனாக இருப்பாங்க. இப்போது இந்த டிஎல்எஸ்ஏ சம்மந்தமாக யாருக்கு இந்த சட்டப்படி உதவி போகுது நாம் அப்ரோச் பண்ணுறோம் அப்படின்னா, அக்யூஸ்டு ஜெயிலில் இருக்கிறாரு. சுப்ரீம் கோர்ட்டில் வந்து என்ன டைரக்ஷன் கொடுக்குறாங்கன்னா, 3 months ஒன்ஸ் ஜெயில் விசிட் மேண்டேட்டரி. அப்படி ஜெயிலுக்கு போயிட்டு விசாரிக்கும் பொழுது அவருக்கு மனநல பாதிப்பு இருந்ததுன்னா அவங்கள பொறுத்து நடவடிக்கை கட்டாயம் எடுக்கணும் அப்படின்னு சொல்லப்பட்டிருக்கு. இதை அதன் அடுத்த நோக்கம் என்னன்னு பார்க்கும் பொழுது, ஜெயிலில் கைதிகளுடைய எண்ணிக்கையும் அதிகமாக இருக்குது. அப்போது எந்தெந்த நாம் அப்படியே பார்க்காம நடவடிக்கை எடுக்காமல் விட்டுடக்கூடாது. எந்தெந்த அக்யூஸ்டை பெயிலுக்கு கொடுக்க முடியும், பெயிலில் விடலாம், எந்த வகையில் அக்யூஸ்னுடைய எண்ணிக்கை குறைக்கலாம், இந்த மாதிரி மனநல பாதிப்பு இருக்கிற அக்யூஸ்டுக்கு எந்த வகையில் உதவி செய்யலாம் அப்படின்றத பற்றியெல்லாம் நம்மளுடைய மாண்பமை சுப்ரீம் கோர்ட் வந்து டைரக்ஷன் கொடுக்குறாங்க. அதை அனுசரித்து ஒவ்வொரு தாலுக்லையும் டிஸ்ட்ரிக்ட்லையும் ஜெயிலுக்கு கன்சர்ன் மேஜிஸ்ட்ரேட் அல்லது சீஃப் ஜுடிஷியல் மேஜிஸ்ட்ரேட் போகிறாங்க, விசிட் பண்ணுறாங்க. இது ஒரு பக்கம். இன்னொன்று, அந்த நம்ம டிஸ்ட்ரிக்ட் லீகல் சர்வீசஸ் அத்தாரிட்டி புதுக்கோட்டை பிடிஜி பிரின்சிபால் டிஸ்ட்ரிக்ட் ஜட்ஜ் சேர்மனாக இருக்கிறாங்க. அதுக்கு கீழே செக்ரட்டரி இருக்கிறார், அவரோட உத்தரவு அமல்படுத்த. அதாவது டைரெக்டாக ஜுடிஷியல் ஆஃபீஸர்ஸும் போய் பார்க்குறாங்க ஜெயிலில் அக்யூஸ்டை. இந்த அத்தாரிட்டி லீகல் சர்வீஸ் அத்தாரிட்டி மூலமாகவும் சேர்மன் செக்ரட்டரி போய் பார்க்கவும் செய்கிறாங்க. அங்கே போயிட்டு இந்த மாதிரி மனநல பாதிப்பு அவங்க பேசுகிறாங்க. இப்போது நீங்கள் எப்படி பேசுவீங்களோ மருத்துவர்கள் வந்து பேஷண்ட்டுக்கிட்ட, அந்த மாதிரி அவங்க ஜட்ஜஸ் வந்து எக்ஸ்பர்ட் கிடையாது. பட் இனிஷியலாக அவங்க எடுக்கக்கூடிய நடவடிக்கை என்ன அப்படின்றத பற்றி சட்டத்தில் சொல்லப்பட்டிருக்கு. போகும்பொழுது பேசி பார்க்குறாங்க. அவங்கள வந்து மனநல பாதிப்பு இருக்குது அப்படின்னு தெரிய வந்தால் கன்சர்ன் ஜெயில் அத்தாரிட்டிக்கிட்ட ஒரு லெட்டர் ரிசீவ் பண்ணுறாங்க. அங்கேருந்து வந்து மெடிக்கல் ஆஃபீஸர்கிட்ட, மனநல மருத்துவர்கிட்ட, மனநல நிபுணர்கிட்ட ஒரு அறிக்கையும் வாங்குறாங்க. அந்த அறிக்கையோட கன்சர்ன் அந்த அக்யூஸ்டு எந்த கேஸில், எந்த கோர்ட்டு கேஸில் அவர் உள்ளே இருக்கிறாரோ அந்த நீதிமன்றத்தில் இந்த அறிக்கையை சமர்ப்பிக்கிறாங்க. இல்லைன்னா இந்த டிஎல்எஸ் அத்தாரிட்டி ஜெயிலுக்கு போயிட்டு விசிட் பண்ணிட்டு வந்தாங்கன்னா இந்த விவரம் அடங்கிய தகவலை தபாலை கன்சர்ன்டு மேஜிஸ்ட்ரேட்டுக்கு சப்மிட் பண்ணுவாங்க. அவங்க இன்டர்ன் என்ன பண்ணுவாங்கன்னா அந்த ஜெயிலுக்கு வந்து லெட்ரு போடுவாங்க, இன்ஃபார்ம் பண்ணுவாங்க. அங்கேருந்து அந்த போலீஸ் அக்யூஸ்டை கொண்டு வருவாங்க. அப்போது ஜட்ஜி பேசி பார்ப்பாங்க. பேசிட்டு சரி ப்ரைமா ஃபேஸியாக இவருக்கு மனநல பாதிப்பு இருக்குதுன்னு முடிவுக்கு வந்தால் மெடிக்கல் ஆஃபீஸர்கிட்ட, கன்சர்ன் மெடிக்கல் ஆஃபீஸர்கிட்ட ரிப்போர்ட் வாங்குறாங்க. தேவைப்பட்டால் மெடிக்கல் ஆஃபீஸரை கூப்பிட்டு விசாரிக்கவும் செய்யலாம் கோர்ட்டில். ஏன்னா நான் ஏற்கனவே சொன்னது மாதிரி ஜட்ஜஸ் ஆர் நாட் எக்ஸ்பர்ட் இன் திஸ் ஃபீல்ட். ஸோ மெடிக்கல் ஆஃபீஸர்ஸ்னுடைய உதவி, நீங்கள் கொடுக்குற ரிப்போர்ட், இதை அனுசரித்து தான் ஒருத்தவர் வந்து சொசைட்டியில் மற்றவங்களோட சேர்ந்து பழக முடியுமா, இல்லை தனித்து வைக்கப்படணுமா, அவரோட உரிமை மீறப்படுதா இல்லையா, தொடர் சிகிச்சை தேவைப்படுதா, இல்லை அப்சர்வேஷனோட போருமா, அப்படின்றது எல்லாமே உங்களுடைய ரிப்போர்ட்டினால தான் முக்கியத்துவப்படுத்தப்படுது. ஆக உங்களுடைய பணி அப்படின்றது இந்த சொசைட்டிக்கு மிக முக்கியமானதாக இருக்குது. அதே மாதிரி அந்த நீங்கள் கொடுக்குற மெடிக்கல் ரிப்போர்ட், அசஸ்மெண்ட் ரிப்போர்ட் கொடுக்குறீங்க இல்லையா, அதை அனுசரித்து அப்சர்வேஷனுக்கு அனுப்புகிறோம். ஒரு 3 நாள் இல்லை 7 நாளுக்கு நீங்கள் ரிப்போர்ட் கொடுக்கும் பொழுது நீங்கள் அதில் எழுதுறீங்க. அதாவது இவருக்கு அப்சர்வேஷனோட போகிறோம், அதுக்குண்டான மருந்து மாத்திரைகள் கொடுத்தாலே போகிறோம், இல்லை கண்டினியூஸ் ட்ரீட்மெண்ட் தேவை, மெட்ராஸ் மனநல பாதிப்பு சிகிச்சை மையத்துக்கு கீழ்ப்பா ஹாஸ்பிட்டலுக்கு அனுப்புங்க அப்படின்னு ரெஃபர் பண்ணிங்கன்னா அதை அனுசரித்து நாங்கள் ரெஃபர் பண்ணுறோம். இந்த ஆக்டில் வந்து என்ன சொல்கிறாங்கன்னா, அந்த மனநல பாதுகாப்பு மையத்திலலாம் இருக்கிற மனநல பாதிக்கப்பட்ட நபர்கள் வந்து 30 நாள் இருக்கலாம், அதுக்கு மேலே 1 மாதம் வைக்கலாம், அதுக்கு மேலே 6 மாதம், அதுக்கு மேலே தாண்டக்கூடாதுன்றாங்க. சப்போஸ் கண்டினியூஸாக பொதுவாக மனநல பாதுகாப்பு மையத்தில் இருக்கிறவங்களுக்கு தேவைன்னா 6 months ஒன்ஸ் மெடிக்கல் ரிவ்யூ போர்டில் பர்மிஷன் வாங்கணும்னு சொல்லியிருக்கிறாங்க. சரி, இப்போ இங்கே ஸ்டூடெண்ட், இப்போ இது வந்து நான் ஜென்ரலாக சொன்னேன். அதே மாதிரி அக்யூஸ்டை பொறுத்தும் ஜட்ஜஸ் எடுக்கிற நடவடிக்கை, அட்வைஸ் யாரோடது, மருத்துவரோட அட்வைஸை வாங்கி அந்த பர்சனோட நலனுக்காக நாம் அனுப்பி வைக்கிறோம். இது ஒரு பக்கம் இருக்குது. அடுத்தது, அந்த பர்சன் சட்டத்தில் என்ன சொல்லியிருக்குன்னா, அவருக்கு இன்ஃபார்ம்டு கன்சென்ட், அவருக்கு நீங்கள் இன்ஃபார்ம் பண்ணி சம்மதத்தை வாங்க வேண்டியது கட்டாயம்னு சொல்லியிருக்கு. அதாவது அவர் அதாவது என்ன அண்டர்ஸ்டாண்டிங் கெப்பாசிட்டி உள்ள பாதிக்கப்பட்ட அந்த மனநல பாதிப்புள்ள நபர்கிட்ட நீங்கள் எந்த ஒரு அட்மிஷன் போடுறதா இருந்தாலும், ட்ரீட்மெண்ட் கொடுக்குறதா இருந்தாலும், அவரை கண்டினியூஸ் ட்ரீட்மெண்ட்டுக்கு உட்படுத்துகிறதா இருந்தாலும் கன்சென்ட்டு மஸ்ட் அப்படின்னு சொல்லியிருக்கு. அடுத்ததாக இந்த புது ஆக்டில் என்ன சொல்லியிருக்குன்னா, அட்வான்ஸ் டைரக்டிவ்னு ஒன்று சொல்லியிருக்கிறாங்க. அதாவது இப்போ சொத்து சம்மந்தமாக என்ன பண்ணுறாங்கன்னா, உயில் எழுதி வைக்கிறாங்க. இப்போ நான் இறந்துட்டா எனக்கு பின்னாடி இன்னார் வந்து சொத்துக்களை அனுபவிக்கலான்னு சொல்லப்பட்டிருக்கு. அந்த மாதிரி இந்த ஆக்டில் என்ன கொண்டு வராங்க, எனக்கு இந்த மாதிரி ஒரு சுச்சுவேஷன் வந்துட்டா இந்த மாதிரி ஒரு மருத்துவ சிகிச்சையை தான் நீங்கள் மேற்கொள்ளணும், இந்த மாதிரி மருத்துவ சிகிச்சை நீங்கள் மேற்கொள்ளக்கூடாது, எனக்கு பாதுகாப்பாக ரெப்ரசன்டேட்டிவ் இன்னார் தான் இருக்கணும் அப்படின்லாம் எழுதி வாங்கணும்னு இதில் சொல்லப்பட்டிருக்கு. அதே மாதிரி அந்த ரெப்ரசன்டேட்டிவ் அவருக்கு இன்ட்ரெஸ்ட்டுக்கு அகெயின்ஸ்டாக செயல்பட்டால் அவரை நீக்கிடலாம். அதாவது அவருக்கு அவர் சொந்தக்காரங்க இல்லைன்னா நாமினேட்டட் ரெப்ரசன்டேட்டிவ் அப்படின்னு ரெவ்யூ போர்டில் நியமிக்கிறாங்க. அவருக்கு ஆதரவாக இருப்பார். அவர் மருத்துவ சிகிச்சைக்கு எந்தெந்த மருத்துவ சிகிச்சைக்கு அவர் போகலாம், எந்த சமயத்தில் அவர்கிட்ட கன்சென்ட் வாங்கணும் அப்படின்றதெல்லாம் அந்த ரெப்ரசன்டேட்டிவ் ரெப்ரசன்ட் பண்ணுவார். சப்போஸ் இந்த மனநல மருத்துவர் வந்து கொடுக்குற அறிக்கை, அவர் வந்து சிகிச்சையில் இருக்கணும் அப்படின்னு கொடுத்துட்றார். ஆனால் அந்த சம்மந்தப்பட்ட நபர் அல்லது ரெப்ரசன்டேட்டிவ் அல்லது அவருக்கு யாரோ பெட்டிஷன் போட்டு ஒரு கோர்ட்டு மூலமாக இவங்கெல்லாம் என்ன பண்ணலான்னா ரெவ்யூ போர்டில் அப்பீல் பண்ணலாம். இந்த மாதிரி அவர் குணமாயிடுச்சு, இல்லை நல்லா இருக்கிறாரு, இந்த மருத்துவ அறிக்கை வந்து ஆட்சேபனைக்குரியதாக இருக்குது அப்படின்னு போர்டில் ரெப்ரசன்டேஷன் வைக்கலான்னு இருக்குது. அடுத்ததாக இப்போ ஸ்டூடெண்ட்ஸ் வந்திருக்கிற நிலையில் என்ன வந்து நீங்கள் அவங்களுக்கு செய்யணும், அதாவது என்ன அவங்களுக்கு என்ன உரிமை இருக்குது அதை பாதுகாக்கணும், அவ்வளோதான். சிகிச்சை கொடுக்குற சமயத்தில் அதாவது சாதாரணமாக ஒரு மனுஷனுக்கு அரசியலமைப்பு சட்டப்படி என்ன சொல்கிறாங்கன்னா உரிமை இருக்குது, அவரோட சுதந்திரம் அடுத்தவங்களுக்கு இடையூறு இல்லாமல் சுதந்திரமாக இருக்கலாம், ஒரு தொழில் செய்யலாம், படிக்கலாம், பிஸ்னஸ் சம்மந்தமாக வெளியூரில் போய் தங்கலான்னு சாதாரண மனுஷனுக்கு அரசியலமைப்பு சட்டத்தில் உரிமைகள் கொடுக்கப்பட்டிருக்கு. அதே மாதிரி இந்த ஆக்டில் அவருக்கு உண்டான உரிமைகள் சிகிச்சையின் பொழுது என்னென்னு சொல்லப்பட்டிருக்கு. அதை பொறுத்து மட்டும் சுருக்கமாக சொல்லன்னு இருக்கேன். இந்த ஆக்டில் சாப்டர் 5ல் ரைட்ஸ் ஆஃப் பர்சன் வித் மென்டல் இல்னஸ் அப்படின்னு சொல்லியிருக்கு. அதில் 18வது பிரிவில் ரைட் டு ஆக்சஸ் மென்டல் ஹெல்த் கேர், அதாவது தான் சிகிச்சை எடுக்கக்கூடிய முடிவை எடுக்கக்கூடிய அதிகாரம் அவருக்கு இருக்குது அப்படின்னு சொல்லப்பட்டிருக்கு. அதே மாதிரி பிரிவு 19ல் ரைட் டு கம்யூனிட்டி லிவிங், முடிஞ்ச அளவுக்கு அவரை அவர் குடும்பத்திலேருந்து பிரிக்காமல் ட்ரீட்மெண்ட்டு கொடுக்க முயற்சி செஞ்சால் நல்லாயிருக்கும் அப்படின்ற மாதிரி சொல்லப்பட்டிருக்கு. அடுத்தது பார்த்திங்கன்னா ரைட் டு ப்ரொடெக்ஷன் ஃப்ரம் குருவல், இன்ஹியூமன் அண்ட் டீக்ரேடிங் ட்ரீட்மெண்ட், அவருக்கு எந்தவித தொந்தரவும் இடையூறும் செய்யாமல் சிகிச்சை கொடுக்கணும், அதுக்கு அவருக்கு உரிமை இருக்குது, அந்த உரிமை மீறப்பட்டால் அவர் புகார் கொடுக்கலாம் அப்படின்றது அதனுடைய பொருள். அடுத்ததாக பிரிவு 21ல் ரைட் டு ஈக்குவாலிட்டி அண்ட் நான் டிஸ்கிரிமினேஷன், இப்போது உடல்நல பாதிப்பு உள்ளவங்களுக்கு எப்படி வந்து மருத்துவ சிகிச்சை கொடுக்குறாங்களோ வேறுபாடு இல்லாமல் நடத்துகிறாங்களோ, அதே மாதிரி மனநல பாதிப்பு உள்ளவங்களையும் ட்ரீட் பண்ணி எந்த வேறுபாடும் காட்டாமல் கம்யூனிட்டி அல்லது ரேஸு அது நிறைய சொல்லியிருக்கால் நீங்கள் பார்த்துக்கோங்க. அந்த மாதிரி இல்லை ஏழ்மையாக இருக்கார், பணம் கட்ட முடியல, இல்லை அவருக்கு வேண்டிய நபர்கள் இல்லை, ஆதரவு இல்லை அப்படின்ற மாதிரி எந்த வித பாகுபாடும் காட்டி வேறுபடுத்தக்கூடாது அப்படின்றத இந்த சட்டத்தில் உறுதிப்படுத்துகிறாங்க. அதே மாதிரி பிரிவு 22ல் ரைட் டு இன்ஃபர்மேஷன், இப்போ சாதாரணமாக நம்ம ஹாஸ்பிட்டலுக்கு போகிறோன்னா நம்ம சிந்தனை உள்ளவங்க என்ன சார், ஆனால் டாக்டர் எழுதி கொடுக்குற மாத்திரை வந்து நமக்கு புரியாது, ஆனால் இப்போ சுகர் டயபெட்டிக்கு ட்ரீட்மெண்ட் எடுக்கிறோமா, பிபிக்கு எடுக்கிறோமா, இல்லை வேறு என்ன அதுக்கு நம்ம தெரிஞ்சுக்கிறோம், கேட்டால் டாக்டர் சொல்கிறாங்க. அதே மாதிரி இந்த மனநல பாதிப்பு உடையவர்களுக்கு அவங்க ட்ரீட்மெண்ட் சம்மந்தப்பட்ட இன்ஃபர்மேஷனை டாக்டர்ஸு கொடுக்கணும், அது வயலேட் பண்ண நடவடிக்கை எடுக்கலான்னு சொல்லப்பட்டிருக்கு. அதே மாதிரி செக்ஷன் 23ல் ரைட் டு கான்ஃபிடென்ஷியாலிட்டி, இப்போ இந்த போக்சோ கேஸ்லாம் பார்த்திங்கன்னா பாதிக்கப்பட்ட 18 வயசுக்கு உட்பட்ட குழந்தைகளுடைய ஐடென்டிட்டி, அட்ரஸ், அவங்களோட ரிலேட்டிவ்ஸ் இந்த மாதிரி எதையுமே வெளிப்படுத்தக்கூடாதுன்னு இருக்குது. அதே மாதிரி இவங்களுக்கும் அப்ளை ஆகுது. இவங்களுடைய பாதுகாப்பு சம்மந்தப்பட்ட மருத்துவ ஆவணங்கள், அவர் என்ன மாதிரி சிகிச்சை எடுத்துக்கிறாரு, என்ன மாதிரி பாதிக்கப்பட்டிருக்கிறாரு, இந்த விவரத்தை மற்றவங்களுக்கு வெளிப்படுத்தக்கூடாதுன்னு சொல்லப்பட்டிருக்கு. ஆனால் அதில் ஒரு எக்ஸப்ஷன் கொடுத்துருக்குறோம். அதே மாதிரி இந்த ப்ரொசீடிங்ஸ் இன் கேமரா ப்ரொசீடிங்ஸில் ரெவ்யூ போர்டில் நடத்தணும்னு சொல்கிறாங்க. ஆனால் அதுக்குண்டான எக்ஸப்ஷன்ஸ் கொடுத்துருக்குறாங்க. எந்த மாதிரி சமயத்தில் இந்த கான்ஃபிடென்ஷியாலிட்டியை வந்து நாம் பிரேக் பண்ணலான்னா, பொது நலனுக்கு அந்த கான்ஃபிடென்ஷியாலிட்டியை வெளிப்படுத்தலான்னா செய்யலாம், ஆனால் அது நம்ம லாஸ்ட் ஆப்ஷனாக தான் வச்சுக்கணும், அப்படின்னா பிரச்சனை இல்லைன்னு சொல்லப்பட்டிருக்கு. அதே மாதிரி அதான் செக்ஷன் 24ல் ரெஸ்ட்ரிக்ஷன் ஆன் ரிலீஸ் ஆஃப் இன்ஃபர்மேஷன் ரெஸ்பெக்ட் ஆஃப் மென்டல் இல்னஸ், அதுதான் மனநல பாதிப்பு விவரங்களை வெளிப்படுத்தக்கூடாது. அதனால் ஏன்னா இன்னும் வந்து இது சமூகத்தில் வந்து நல்லா எடுத்துக்கலை, உடல்நல பாதிப்பு உடையவர்களை வந்து நடத்துகிற மாதிரி மனநல பாதிப்பு உடையவங்களை வந்து நம்ம சமுதாயம் வந்து இன்னும் எடுத்துக்கலை, அதுதான் நிதர்சனமான உண்மை. அடுத்ததாக பார்த்திங்கன்னா செக்ஷன் 26 ரைட் டு பர்சனல் கான்டாக்ட்ஸ் அண்ட் கம்யூனிகேஷன், இதில் என்ன சொல்கிறாங்கன்னா, இந்த மனநல பாதிப்பு உள்ளவர் வந்து ட்ரீட்மெண்ட் எடுத்துக்கிட்டு இருக்கிறார், அவர் சாதாரணமாக மன வெறுப்பில் தான் இருப்பார், யாரையும் பார்க்க விரும்ப மாட்டார், எந்த மெசேஜையும் வாங்க விரும்ப மாட்டார். அவர் வந்து சொல்லலாம், என்னை யாரும் பார்க்க சொந்தக்காரங்க அனுமதிக்கலை, எனக்கு எந்த தகவலும் வரக்கூடாதுன்னு. இதுலேயும் ஒரு எக்ஸப்ஷன் கொடுத்துருக்குறாங்க. அதுவுமே அந்த பொது அமைதிக்காக, பொது மக்களுக்காக, இவரால் மற்றவங்களுக்கு எந்த பாதிப்பும் வரக்கூடாது அப்படின்ற சூழ்நிலைக்காக, எக்ஸ்ட்ராடினரி சர்க்கம்ஸ்டன்சஸ் பட் இட் இஸ் மஸ்ட் நெசசரி அப்படின்னும் பொழுது எனி ஜட்ஜ் or officer authorized by a competent court can contact. Members of the concerned board or the central authority or the state. Any member of the parliament or a member of state legislature, nominated representative, lawyer or legal representative of the person, medical practitioner in charge of the person's treatment, any other person authorized by the appropriate government அப்படின்னு சொல்லப்பட்டிருக்கு. இப்போ நம்ம சட்டத்துறையை பொறுத்து தான் இந்த செக்ஷன் 27ல் ரைட் டு லீகல் எய்ட், இதைத்தான் நான் ஏற்கனவே சொன்னேன். இந்த மாதிரி டிஎல்எஸ்ஏ டிஸ்ட்ரிக்ட் லீகல் சர்வீசஸ் அத்தாரிட்டி புதுக்கோட்டையில் இயங்கிட்டு இருக்கு. நேஷ்னல் வைட், ஸ்டேட் வைட், டிஸ்ட்ரிக்ட் வைட், தாலுக் வைட். இப்போ நம்ம டிஸ்ட்ரிக்டில் வந்து இந்த மாதிரி மாண்புமிகு சுப்ரீம் கோர்ட்டினுடைய டைரக்ஷனில் ஜெயிலுக்கு போயிட்டு அங்கே உள்ள அக்யூஸ்டை விவரம் கேட்டு அவங்களுக்கு இந்த சிம்டம்ஸ் இருந்ததுன்னா கட்டாயம் முக்கியமாக மனநல மருத்துவர்களோட அறிக்கையை பெற்று போர்டினுடைய ஒப்புதலை பெற்று இவங்களுக்கு தற்காலிக ட்ரீட்மெண்ட் போருமா இல்லை நெடுநாளைய ட்ரீட்மெண்ட்டு வேணுமா, அதுவுமே வந்து 6 months தான் கொடுத்துருக்குறாங்க. அதுக்கு மேலே ஒவ்வொரு தரமும் வந்து எக்ஸ்டெண்ட் பண்ணுறதுக்கு மெடிக்கல் போர்டோட பர்மிஷன் தேவை. அதனால் இந்த ஆக்டை நீங்கள் கொஞ்சம் நல்லா பார்த்துக்கிட்டிங்கன்னா வசதியாக இருக்கும். அடுத்ததாக பார்த்தீங்கன்னா செக்ஷன் 28 ரைட் டு மேக் கம்ப்ளைண்ட்ஸ் அபவுட் டெஃபிஷியன்ஸ் இன் ப்ரொவிஷன் ஆஃப் சர்வீசஸ். அதான் இப்போது இந்த சட்டத்தில் என்ன சொல்கிறாங்கன்னா, இந்த மாதிரி ரொம்ப ஏழ்மை நிலையில் உள்ளவங்க காப்பகத்தில் இருக்கிறவங்களுக்கு சில நேரம் பணம் கட்ட முடியாது. அப்போ வந்து அந்த ஏழ்மை நிலைக்கு பார்டர் லைனுக்கு கீழே இருக்கும்போது கவர்மெண்ட்டே அவங்களுக்கு உண்டான செலவுக்கு பணம் கட்டணும்னு சொல்கிறாங்க. அரசு மருத்துவமனையில் ட்ரீட்மெண்ட் கொடுக்கும் பொழுது அவங்களுக்கு ஏதாவது பிரச்சனைகள் இருக்கும்போது புகார் கொடுக்கலாம் அப்படின்றது இந்த சட்டத்தில் உறுதிப்படுத்துகிறாங்க. இதில் வந்து ஆக இந்த ஆக்டில் வந்து நிறைய சொல்லப்பட்டிருந்தாலும் நம்ம வந்து அதனுடைய சப்ஸ்டான்ஸ் சுருக்கமாக என்ன சொல்லலாம் அப்படின்னு பார்த்தீங்கன்னா, சம்பந்தப்பட்ட மனநல பாதிப்புடைய நபருடைய கன்சன்ட்டு மஸ்ட், இல்லைன்னா ரெப்ரசன்டேட்டிவ் கன்சன்ட்டு மஸ்ட், போர்டினுடைய கன்சன்ட்டு மஸ்ட், கன்சர்ன் கோர்ட்டினுடைய கன்சன்ட்டு மஸ்ட். எந்த சூழ்நிலைக்கு கன்சன்ட் தேவையோ அதுக்கு தகுந்த மாதிரி அந்தந்த அத்தாரிட்டிகிட்ட கன்சன்ட்டு வாங்கலாம். அடுத்தது ஃபிசிக்கல் இல்னஸ் உள்ள பேஷண்ட்டு மாதிரியே மனநல பாதிப்பு கொண்ட நபர்களையும் நடத்தணும் அப்படின்றத உறுதிப்படுத்தணும். அதே மாதிரி டாக்டர்ஸ் வந்து பழைய ஆக்டில் வந்து தற்கொலை பண்ணிட்டா பனிஷ்மெண்ட், தற்கொலை முயற்சி பண்ணால் பனிஷ்மெண்ட்டு. இந்த இதில் வந்து என்ன சொல்கிறாங்கன்னா, தற்கொலைன்றது அவங்களுடைய மன பாதிப்பு வீரிய தன்மையினால் செஞ்சுக்கிறாங்க, அதனால் அது ஒரு குற்ற செயலாக எடுத்துக்க வேண்டாம் அப்படின்ற மாதிரி இதில் கொண்டு வந்திருக்கிறாங்க. அதே மாதிரி ட்ரீட்மெண்ட் கொடுக்கும் பொழுது இது பொதுவாக எல்லா ஆக்ட்லையுமே சொல்கிறது தான், நாம் அந்த பேஷண்ட்டினுடைய நலனுக்காக நன்மைக்காக நல்ல எண்ணத்தோடு செயல்படுறோம் அப்படின்ற சிந்தனை இருக்கணும். எல்லா ஆக்ட்லையும் சொல்கிற மாதிரி தான் இதுலேயும் சொல்லியிருக்கிறாங்க. போனஃபைடு இன்டென்ஷனோட எந்த ஒரு நடவடிக்கையும் அந்த கன்சர்ன் பர்சனுக்கு எடுக்கணும், ட்ரீட்மெண்ட் கொடுக்கணும்னு. அதே மாதிரி 3 வயசு குழந்தை இருக்குது, தாய் ட்ரீட்மெண்ட் எடுக்கிறாங்கன்னா அந்த அம்மாவால் சமாளிக்க முடியும், சிந்திக்கிற ஆட்டன் இருக்குது, அந்த அம்மாவால் குழந்தைக்கு பிரச்சனை வராதுன்னா குழந்தையே கூட இருக்க வைக்கலாம். இல்லைன்னா கன்சர்ன் ரிலேட்டிவ் அல்ல யார் இருக்கிறாங்களோ அவங்கள்ட்ட ஒப்படைக்கலான்னு சொல்லப்பட்டிருக்கு. அதே மாதிரி இளவருக்கு மைனருக்கு எல்லா சட்டங்களும் முக்கியத்துவம் கொடுக்கறது. அதே மாதிரி தான் இந்த ஆக்ட்லேயும் மைனர்ஸ்னால் கவனமாக அவங்கள பரிசோதிக்கணும், கார்டியன் இருக்காங்களான்னு பார்க்கணும், மைனரோட இன்ட்ரெஸ்ட்டுக்கு அவங்க எதிராக செயல்படுறாங்களா அப்படின்றதெல்லாம் பார்த்து செஞ்சுட்டா ஒன்றும் பிரச்சனை இருக்காது. அதே மாதிரி முடிவாக என்ன சொல்கிறேன்னா, முடிஞ்ச அளவுக்கு குறைவான செலவில் நிறைவான மருத்துவ சிகிச்சை கொடுத்து குடும்பத்தோடு அவங்க சேர்ந்து இருக்க பாடுபடணும் அப்படின்றத கேட்டுக்கிட்டு வாய்ப்பளித்த எனக்கு நன்றி கூறி விடைபெறுகிறேன். நன்றி, வணக்கம்.
நன்றி மேடம். நீங்கள் இவ்வளோ தூரம் வந்து மென்டல் ஹெல்த் கேர் ஆக்டை காம்ப்ரிஹென்சிவாக எடுத்து சொன்னதுக்கும் ப்ளஸ் அவைலபிலிட்டி ஆஃப் ஃப்ரீ மென்டல் ஹெல்த் எய்டு ஃபார் த லீகல் எய்ட் ஃபார் த மென்டல் ஹெல்த் பற்றி சொன்னதுக்காகவும் பார்வையாளர்கிட்டருந்து ஏதாவது கேள்விகள் இருந்தால் கேட்குமாறு கேட்டுக்கொள்கிறேன்.
சொல்லுங்கள் சார். அட்டெண்டர் மைனராக இருந்தால் மஸ்ட்டுன்னு சொல்லியிருக்கு சார். அதே மாதிரி லேடியாக இருந்தால் ஒரு லேடி அட்டெண்டரை போடணும்னு சொல்லியிருக்கு சட்டத்தில். அதாவது சீரியஸ் அந்த நோயினுடைய வீரியத்தன்மை அதிகமாக இருக்கும் பொழுது, அவர் இண்டிபெண்ட்டாக செயல்பட முடியாத பொழுது, அவருக்கு யாரும் அட்டெண்டர் இல்லைன்னு போது அட்டெண்டர் மஸ்ட்டு அப்படின்னு தான் சட்டத்தில் சொல்லியிருக்கு.
அட்டெண்டர் ஒருவேளை அவைலபிளாக இல்லை, பேஷண்ட் மட்டும்தான் இருக்காங்க அப்படின்னா வேறு ஏதாவது ப்ரொசீஜர் இருக்குங்களா மேம் அது கன்சென்ட் வாங்குறதுக்குன்னு சொல்லி?
மெடிக்கல் போர்டில் அப்ளை பண்ணணும். மீன்வைல் கன்சர்ன் பர்சன் ஃபிட் பர்சன் may be nominated for temporary period.
As per the act, any NGO can nominate the patient. NGO can take over the patient and he can nominate on behalf of patient. He can be appointed as a nominative representative.
Thank you.
எஸ் சார். ஆனால் அது குறைந்த அளவுக்கு தான், அவரை துன்புறுத்தக்கூடிய அளவுக்கு செய்யக்கூடாதுன்னு தான் இல்லை சொல்லியிருக்கு.
அது பண்ணக்கூடாது.
அதை வந்து போடக்கூடாதுன்னு தான் சார் சொல்லியிருக்கு. அதாவது என்னென்னா உடல் ரீதியாக அவரை வந்து தடை பண்ணலாம், மற்றபடி எந்த வித டார்ச்சரும் செய்யக்கூடாதுன்னு தான் நான் சொல்லியிருக்கு ஆக்டில்.
இருக்குல்ல, எட்வர்ட் ரமன்கிற இங்கிலீஷ்
சொல்லிடுங்க, மெடிக்கல் டேர்ம்ஸில் எனக்கு புரியல.
மெக்னாட்டன்ஸ் லா அப்ளை பண்ணி இந்த கிளையண்ட்டுக்காவது ரிலீஸ் கொடுத்துருக்கீங்களா? ரெண்டாவது பாம்ப்ளேட் அசால்ட் ஆன் டாக்டர்ஸ் நாட் பை தி பேஷண்ட் பட் பை த ரிலேட்டிவ்ஸ் ஆர் இன்ட்ரெஸ்டட் பார்ட்டிஸ், அதுக்கு அதிகமாக ஆகிட்டு வருது. அதுக்கு ஏதாவது டாக்டர்ஸுக்கு ப்ரொடெக்ஷனுக்கு ஏதாவது ப்ரொவிஷன் இருக்கா?
அந்த மாதிரி ஏதாவது ஜட்மெண்ட் அக்யூட் பண்ணியிருக்கா? இது வரல அந்த மாதிரி அனுபவம்? இது வரல அந்த மாதிரி
கிரிமினல் அஃபென்சஸ் கிரியேட் பண்ணியிருக்கான், அவன் வந்து பனிஷபிள் கிடையாது, அந்த மாதிரி ஜட்மெண்ட் பண்ணியிருக்காங்க
சார். சார் அந்த மாதிரி நான் இன்னும் ஹேண்டில் பண்ணலை. ஆனால் சட்டத்தில் என்ன சொல்லியிருக்குன்னா, அந்த மாதிரி மென்டல் இல்னஸ் இருக்கும் பொழுது அவருக்கு எதிராக எந்த நடவடிக்கையும் எடுக்கப்படுறது இல்லை. ஸ்டேடு மாதிரி சஸ்பென்ஷனில் வச்சுடுறோம், அந்த கேஸை தனியாக பிரித்து வச்சுடுவோம். திரும்ப எப்போ அவருக்கு வந்து சவுண்ட் பர்சனாக மாறுறாரோ மென்டலி, அப்போ அதை எடுத்து நடத்தலான்னு இருக்குது. இப்போ நான் ஒரு கேஸு பெண்டிங்கில் இருக்குது, ஆனால் உங்களுக்காக சொல்லலாம்னு நினைக்கிறேன். அதில் என்னென்னா, ஒரு 302 அஃபென்ஸில் ஒரு 5-6 பேர் அக்யூஸ்ட் இருக்கிறாங்க, பெயிலில் வெளியில் வந்துடுறாங்க. அதுக்கப்புறம் ஒரு அக்யூஸ்டுக்கு ஆக்சிடெண்ட் ஆகுது. அந்த அக்யூஸ்டு மனநலம் பாதிக்கப்பட்டுட்டார். அப்போது அவங்க வராங்க, வக்கீல் வந்து என்ன சொல்கிறாரு, அம்மா இவர் வந்து மனநலம் பாதிக்கப்பட்டு இருக்கிறாரு, இவருக்கு இந்த வழக்கினுடைய தன்மையை எதிர்கொள்ள முடியாது, அதனால் அவரை பொறுத்து நீங்கள் வழக்கை தனியாக பிரித்து வைக்கணுன்றாங்க. உடனே நான் என்ன பண்ணேன்னா, இங்கே புதுக்கோட்டை மெடிக்கல் போர்டுக்கு லெட்டர் அனுப்பிச்சேன். அங்கேருந்து வந்தாங்க, வந்து ஒரு ரிப்போர்ட் அனுப்பிச்சிட்டாங்க. அந்த ரிப்போர்ட் வந்து மெடிக்கல் டேர்ம்ஸ் வந்து எங்களுக்கு புரியலை. அப்புறம் நாங்கள் டாக்டர் வரவழைச்சோம், அவங்க வந்து எக்ஸ்பிளைன் பண்ணாங்க அந்த அறிவுத்திறன் குறைபாடு சம்மந்தமாக. அதுக்கப்புறம் அந்த டாக்டர் என்ன சொன்னார், அம்மா இதுக்கு மேலே வந்து ஃபர்தர் ட்ரீட்மெண்ட்டு தஞ்சாவூரில் தான் கொடுத்தாங்கன்னாரு. அப்போது உடனே இவரை நாங்கள் விசாரித்து ரெக்கார்ட் பண்ணிக்கிட்டு தஞ்சாவூர் டாக்டருக்கு நான் மனநல மருத்துவர் அவங்களுக்கு போர்டுக்கு அனுப்பி வந்தாங்க ஒரு மேடம். அவங்க வந்து சொன்னாங்க, இந்த மாதிரி இந்த பேஷண்ட்டை செக் பண்ண வகையில் அறிவுத்திறன் அப்படின்றது இத்தனை சதவீதம் தான் இருக்கணும், அது இவருக்கு குறைவாக காணப்படுது, அதனால் இவர் இந்த கேஸை மர்டர் கேஸை எதிர்கொள்ள முடியாது அப்படின்னு சொன்னாங்க. அதனால் இப்போ நாங்கள் என்ன பண்ணோன்னா, டாக்டரோட எவிடன்ஸை பேஸ் பண்ணி ரெக்கார்ட் பண்ணி அவரை நாங்கள் விடுதலை பண்ணலை. 6 பேர் இருக்கிற அக்யூஸ்டில் அவரை பொறுத்து மட்டும் கேஸை வந்து பிரித்து எடுக்கிறோம், ஸ்ப்ளிட் அப் பண்ணுறோம். அவரை பொறுத்து நாங்கள் பெண்டிங்கில் வச்சிடுறோம். எப்போ அவர் மனநல சரியாக இருக்குன்னு தெரிய வருதோ அப்போ அவர் சட்டத்தின் பிடிக்குள்ளே வந்து தான் ஆகணும். மற்றவங்களை பொறுத்து கேஸ் நடக்கும். இது தான் நான் ஹேண்டில் பண்ணியிருக்கேன் சார்.
மேடம்
அது எல்லாம் எப்பவுமே இருக்கத்தானே சார் செய்யுது. அதாவது போனஃபைடு இன்டென்ஷனோட செயல்பட்டால் இதைத்தான் நான் வந்து சொன்னேன். நல்லெண்ணத்தின் பால் போனஃபைடு இன்டென்ஷன் அந்த பேஷண்ட்டை காப்பாற்றுறதுக்காக இல்லை அந்த பேஷண்ட்டுக்கிட்ட இருந்து சொசைட்டியில் உள்ள நபர் பாதிக்கப்படாமல் இருக்கிறதுக்காக நான் இதை செஞ்சேன் அப்படின்றத ப்ரூவ் பண்ண போரும். அது எல்லா ஆக்டுக்கும் அப்ளிகபிள் தான், அதே மாதிரி தான் இதுக்கும் அப்ளிகபிள்.
மேடம் ஒரு ப்ராக்டிக்கல் டிஃபிகல்ட்டி.
சொல்லுங்கள் சார்.
ஒரு மனநலம் பாதிக்கப்பட்ட நபர் வந்து ஒரு குற்ற செயல் செஞ்சிடறாங்க. காவல்துறை வந்து நேரடியாக வந்து அவங்கள வந்து எங்கள்கிட்ட கூட்டு வந்து சர்டிஃபிகேட் கேட்குறாங்க. எஃப்ஐஆரே பதிவு பண்ணாமல் வந்து அட்மிட் பண்ணி நீங்கள் வந்து இது சர்டிஃபை பண்ணி கொடுத்தீங்கன்னா அதுக்கப்புறம் நாங்கள் எஃப்ஐஆர் போட்டு ஜட்ஜிட்டு காமிக்கணும்னு சொல்கிறாங்க. இப்போ இதை வந்து ஏற்றுக்கொள்ள முடியுமா? அவங்கள்ட்ட நாங்கள் சர்டிஃபை பண்ணி கொடுக்கலாமா? இல்லை நேரடியாக நீங்கள் வந்து ஆர்டர் வாங்கிட்டு வந்ததுக்கப்புறமா நீங்கள் அட்மிட் பண்ணுங்கன்னு சொல்லலாமா?
இல்லை சார், காவல்துறை அதிகாரி வந்து இன்வெஸ்டிகேஷன் ஆஃபீஸர். இந்த ஆக்டில் என்ன சொல்லியிருக்குன்னா, டாக்டர்கிட்ட அந்த போலீஸ் இன்வெஸ்டிகேஷன் ஆஃபீஸர் பேஷண்ட்டை கொண்டு வந்து கொடுத்து அவருடைய மனநலன் சம்மந்தமாக நீங்கள் எங்களுக்கு செக் பண்ணி அறிக்கை கொடுக்கணும்னு கேட்குறாங்க. அவர் வந்து ஹீ இஸ் ஃபுல்லி ஆத்தரைஸ்ட் அஸ் இன்வெஸ்டிகேஷன் ஆஃபீஸர் டு கெட் தி ரெக்கார்ட். ஆனால் அதை அவர் அந்த கேஸுக்காக தான் பயன்படுத்தணும். இந்த ஆக்டில் சொன்ன மாதிரி கான்ஃபிடென்ஷியாலிட்டின்னு ஒன்று இருக்குது. அதுக்கு உட்பட்டு அவர் அந்த பர்சனை சப்போஸ் டாக்டர் சர்டிஃபிகேட் கொடுக்கும் பொழுது அவர் வந்து மென்டலி இல் பர்சன் இல்லை அப்படின்னா குடும்பத்தில் சேர்க்கறதுக்கு விளம்பரம் கொடுத்து குடும்பத்தார் எங்கே இருந்தாலும் கண்டுபிடிச்சி சேர்க்கலாம். அதே மாதிரி எஃப்ஐஆரை பதிவு பண்ணிட்டு தான் இந்த ப்ரொசீஜர் எடுக்க சொல்கிறாங்க. அதில் ஆக ஐஓ as a police officer above the rank of, அதாவது not below the rank of சப் இன்ஸ்பெக்டர், எஸ்ஐக்கு மேலே உள்ள போலீஸ் ஆஃபீஸர் வந்து பேஷண்ட்டை உங்கள்கிட்ட ஆஜர்படுத்தி எங்களுக்கு பரிசோதனை ரிப்போர்ட் கொடுங்கன்னு கேட்டால் கொடுக்கலாம். அதில் வந்து என்ன சொல்லப்பட்டிருக்குன்னா, இப்போ கோர்ட்டுக்கே வந்து சில நேரங்களில் இன்வெஸ்டிகேஷன் எந்த பாதையில் போகுது, அவர் எந்த சூழ்நிலையில் இன்வெஸ்டிகேஷன் எடுத்துகிட்டு போகிறாரு அப்படின்றதுல கோர்ட்டே சில நேரத்தில் தலையிடக்கூடாதுன்னு இருக்குது. இந்த சட்டத்தில் he is fully entitled to receive the report for the purpose of case, but subject to conditions specified in the act.
Thank you, ma'am.
Thanks.
Only two more questions. Yes. Yeah.
Good morning, ma'am. So, abandoning of a mental health person by her relatives or parents. So, அந்த அபரன் கைவிடுறாங்க அப்படின்னா அவங்களுக்கு பனிஷ்மெண்ட் எதுவும் இருக்கா பை லா?
அது பற்றி பனிஷ்மெண்ட்டு இருக்க மாதிரி எனக்கு தெரியலைங்களே சார்.
இல்லை, பிகாஸ் மோஸ்ட் ஆஃப் த டைம் வந்து ஒரு சிவியர் மென்டல் இருக்காங்க.
அதுக்கு தான் இப்போ நான் சொன்னேன். இப்போ இந்த ரோட்லலாம் பக்கெட் பாருட்டு ஆதரவு இல்லாமல் இருக்கிறாங்க பாருங்கள், அவங்கள போலீஸ் கொண்டு வராங்க, கொண்டாந்து ரிப்போர்ட்டை வாங்குறாங்க. ஆள் குடும்பத்தார் எங்கே இருக்காங்கன்னே தெரியல. ஒரு எஃப்ஐஆரை பதிவு பண்ணிவிட்டு விளம்பரம் கொடுத்துட்டு தேடிட்டு இருக்கிறாரு. மீன் வைல் அவரை வந்து கன்சர்ன் ஹோமில் வச்சிடுறாங்க.
பட் இன்டென்ஷனலாக அபேன் பண்ணுறாங்க, நாட் பனிஷபிள் பை லா, அந்த மாதிரி பனிஷபிள் அந்த மாதிரி
அதை பொறுத்து எனக்கு ஒன்றும் ஐடியா இல்லை சார். அது வந்து அது உங்களுக்கு சீனியர் சிட்டிசன் ஆக்ட் இருக்கே, அது சீனியர் சிட்டிசனை கைவிட்டுட்டாங்கன்னா சன்னாக இருந்தாலும் டாக்டராக இருந்தாலும் பனிஷ்மெண்ட்டு கொடுக்கலான்னு இருக்குது. பட் இதை பொறுத்து எனக்கு அவ்வளோ டெப்த் நாலேஜ் இல்லை.
எஸ் டாக்டர்.
குட் மார்னிங்
தேங்க்
இஸ் த லாஸ்ட் கொஸ்டின். எஸ்
குட் மார்னிங் மேம். இப்போ போக்சோ விக்டிம் அந்த மாதிரி கூட்டிகிட்டு வராங்க மேம், இன்வெஸ்டிகேட்டிவ் ஆஃபீஸர் கேட்குறாங்க. பட் ஒரே நாளில் எங்களால் அசஸ் பண்ண முடியாத பட்சத்தில் நாங்கள் அட்மிஷன் போட சொல்கிறேன் மேம். அவங்க ஆனால் வந்து உடனே கொடுக்க சொல்கிறாங்க.
இல்லை, உங்களுக்கு இந்த ஆக்டில் 3 நாள் கொடுத்துருக்குங்களா சார்? 10 days. அது யூ ஆர் எலிஜிபிள் டு டேக் தட் பீரியட். நீங்கள் ஆனால் என்னென்னா நோட்டீஸு ரிப்ளை மஸ்ட். உங்களுக்கு அதாவது அந்த நெசசிட்டி இருக்கும்போது இன்ஃபார்ம் பண்ணணும், அதுதான் மஸ்ட். கோர்ட்லேருந்து நோட்டீஸ் வந்தால் சார் கூட சொன்னாங்க, சம்மன் வந்தால் நீங்கள் ரிசீவ் பண்ணுங்கள். அந்த வாய்தா தேதிக்கு வர முடிஞ்சால் வரலாம், வரலைன்னா எக்ஸ்டென்ஷன் ஆஃப் டைம் கேட்கலாம். இல்லை அதுக்குண்டான காரணம் என்னன்னு சொல்லலாம். எங்கே வந்து நிறைய பிரச்சனைகள் ஏற்படுதுன்னா ரிப்ளை பண்ணுறது கிடையாது. அதனால தான் கோர்ட்டில் வந்து ஏன் டாக்டர்ஸ் வரலை என்ன காரணம் கேட்குறாங்க. அதே மாதிரி இந்த ஆக்டில் என்ன சொல்லியிருக்குன்னா, வெறும் மெடிக்கல் சர்டிஃபிகேட் வச்சே நீதிபதி முடிவு பண்ண முடியாது இவர் வந்து மென்டலி இல் பர்சன் இல்லை ஃபிட் பர்சன். டாக்டர்னுடைய அப்பியரன்ஸ் எவிடன்ஸ் மஸ்ட்டு. அதனால் சம்மன் வந்தது, இட்ஸ் அ லீகல் ஆர்டர். சம்மன்றது எவ்ரிபடி டு ஒபே. வர முடியல, அதுக்கு ரீசன் சொல்லணும், எக்ஸ்டென்ஷன் ஆஃப் டைம் கேட்டுக்கணும்.
சர்டிஃபிகேட் சொல்கிறீங்க மேடம். அப்போ எங்களுடைய ப்ரிஸ்கிரிப்ஷன், பழைய ப்ரிஸ்கிரிப்ஷன் வச்சுட்டே கோர்ட்டுக்கு போய் எங்களை இழுக்கிறவங்களாம் நிறைய பேர் இருக்காங்க. வில் பி த ப்ரிஸ்கிரிப்ஷன் கேன்
இல்லை, எது ஒன்றுமே நீங்கள் வந்து ப்ராப்பர் ரிப்ளை கொடுக்கணும். அதை ஜட்ஜி ஏற்றுப்பாங்க. எப்படி ஏற்றுக்க மாட்டேன்னு சொல்லுவாங்க. நான் ஏற்கனவே சொன்னேன், இப்போ நான் வந்து எக்ஸ்பர்ட் இல்லை நீங்கள் கேட்ட கேள்விக்கெலாம் பதில் சொல்கிறதுக்கு. நான் வந்து இங்கே ஒரு ஸ்டூடெண்ட்ஸுக்கு ஒரு அவேர்னஸ் உண்டு பண்ணுறதுக்கு நான் படிச்சு சொன்னேன், அவ்வளோதான். அதனால் நீங்கள் நான் எக்ஸ்பர்ட்டு, நான் தவறாக சொல்லிட்டு தான் எடுத்துக்காதீங்க, சரியாக சொல்லி எடுத்துக்கோங்க.
தேங்க்யூ மேம். ஆக்சுவலாக நம்ம சீனியர் ஜட்ஜ் மேடம் வந்து ஒரு ப்ரொஃபஸோரியலாக நமக்கு ஒரு செஷன் எடுத்தாங்க. சில கேள்விகள்லாம் நம்ம வந்து ஸ்டூடெண்ட்ஸ் அனுப்பிச்சிருக்காங்க மேடம். ரொம்ப சிம்பிளான கேள்விகள், பட் டாக்டர்ஸை பொறுத்தவரை அது ஸ்டூடெண்ட்ஸ்க்கு ரொம்ப எசென்ஷியல். இப்போ உதாரணத்துக்கு கோர்ட்டுனா என்ன, குவாசி ஜுடிஷியரி பாடினா என்ன, ஏதாவது டிஃப்ரென்ஸ் இருக்கா? இப்போ பார்த்தீங்கன்னா கோர்ட்னா எல்லாருக்கும் தெரியும் எங்கே இருக்குது அப்படின்னு, என்ன பண்ணுவாங்கன்னு. குவாசி ஜுடிஷியரி பாடினா நம்மளை பொறுத்தவரை மென்டல் ஹெல்த் ரிவ்யூ போர்டுன்னு ஒன்று இருக்குது. ஸோ இது ரெண்டுக்கும் உள்ள ஒரு ஸ்லைட் வித்தியாசம்.
சார் ஒன்றும் இல்லை சார். இப்போ கான்ஸ்டியூஷனல் பாடி அப்படின்னா அரசியலமைப்பு சட்டத்திலேயே இன்பில்ட்டாக இந்த அமைப்பு, கமிட்டி, ஒரு அத்தாரிட்டி இருக்கணும், இதுக்குண்டான அதிகாரம் இது அப்படின்னு அதில் சொல்லியிருக்கு. இது வந்து கான்ஸ்டியூஷனல் பாடிஸ். ஸ்டாச்சுட்டரி பாடிஸ்னால் நான் ஏற்கனவே சொன்னது மாதிரி நம்மளுடைய நாட்டினுடைய முதன்மையான சட்டம் கான்ஸ்டியூஷன் லா. அதில் உள்ள சங்கதிகளை அமல்படுத்த தான் ஒவ்வொரு சட்டமாக வந்துகிட்டு இருக்கு. அந்த மாதிரி ஒரு சட்டம் ஏற்றப்படுதுன்னு வைங்க, இந்த சட்டமே இருக்குன்னு வைங்க. இதில் வந்து இன்பில்ட்டாக இந்த கமிட்டி இருக்கணும், இதுக்காக இந்த ஆஃபீஸ் இருக்கணும் அப்படின்னு சொன்னால் அது ஸ்டாச்சுட்டரி பாடி. கான்ஸ்டியூஷன் லாவிலேயே இன்பில்ட்டாக இந்த அமைப்பு இருக்கணும்னு சொன்னால் கான்ஸ்டியூஷன் பாடி. அதை அனுசரித்து ஒவ்வொரு சட்டத்திலையும், எந்த ஒரு சட்டமாக இருக்கட்டும், அதிலே இந்த அமைப்பு இருக்கணும், இதில் இத்தனை மெம்பர்ஸ் இருக்கணும், எங்களுக்கு இவ்வளோ அதிகாரம் இருக்குது, இவங்களுக்கு இத்தனை வருஷம்தான் ஃபங்க்ஷன் பீரியடு, இந்த வருஷம் ரிட்டையர்மெண்ட்டு அப்படி இன்பில்ட்டாக கொடுத்துருந்தா சட்டத்தில் ஸ்டாச்சுட்டரி பாடி. இப்போ ஜுடிஷியல் பாடின்றது கோர்ட், சுப்ரீம் கோர்ட், ஹை கோர்ட் எல்லாமே. அடுத்ததாக இப்போ சார் கேட்டதுக்கு நான் வரேன். அது மாதிரி ரெகுலேஷன் பாடின்னு இருக்குது. ஒன்றை வந்து ஒழுங்குபடுத்தணுன்றதுக்காக ஒரு அமைப்பை ஏற்படுத்துறது. குவாசி ஜுடிஷியல் பாடி அப்படின்னா நீதிமன்றத்தினுடைய உத்தரவின் பேரில், டைரக்ஷன் பேரில் ஒரு அமைப்பை ஏற்படுத்துறது. அந்த அமைப்பு கொடுக்கக்கூடிய உத்தரவும் நீதிமன்றம் கொடுக்கக்கூடிய உத்தரவுக்கு ஒத்து இருக்கும். அதாவது ஒரு பிரச்சனையை முடிவு பண்ணுறது, ஒரு பிரச்சனைக்கு தீர்வு கொடுக்கறது. இல்லை இப்போ இந்த சார் சொன்ன மாதிரி மெடிக்கல் போர்டு, இப்போ இந்த பர்சன் மெடிக்கல் மென்டலி ஃபிட்னஸாக இல்லையா அப்படின்ட்டு அறிக்கை கொடுக்கறது, விசாரிக்கிறது. இப்போ வந்து புகார் வரும்பொழுதோ இல்லை அவருடைய பீரியட் எக்ஸ்டெண்ட் பண்ணும் பொழுதோ அந்த மருத்துவர் அப்போ ரெப்ரஸன்டேட்டிவ்லாம் விசாரித்து இந்த போர்டில் ஒரு டிஸ்பியூட், அதாவது அந்த பேஷண்ட் வந்து மென்டலி இல் பர்சனா இல்லையா, இது ஒரு பிரச்சனை, இதுக்கு தீர்வு காண்றாரு. அதாவது குவாசி ஜுடிஷியல் பாடின்றது தானே ஏதோ வந்துடல, கோர்ட்டு அரசாங்க செலவோட, கோர்ட் உத்தரவு அரசாங்க செலவு அப்படி எடுத்துக்கலாம், ஒரு அமைப்பு உண்டாக்கப்படுது. கோர்ட்டு வந்து ஒரு டைரக்ஷன் கொடுக்குது, இந்த ஒர்க்கு ஃபங்க்ஷன் செய்யணும், இதில் இத்தனை மெம்பர்ஸ் இருக்கணும், இதில் நீங்கள் இந்த டிஸ்பியூட்டுக்கு முடிவு காணணும், இதில் உங்களுக்கு இந்த பீரியடு ஃபங்க்ஷன் வேலிட் பீரியடு, ரிட்டையர்மெண்ட் எவ்வளோ அப்படின்றத அதிகாரமுள்ள கோர்ட்டு டைரக்ஷனில் ஏற்படுத்தப்படுற அமைப்பு. அந்த அமைப்பினுடைய உத்தரவும் கோர்ட் உத்தரவு மாதிரி ஈக்குவலி டு பி ட்ரீட்டட். அதனால் ரெண்டுமே ஒவே பண்ணித்தான் ஆகணும். இது கோர்ட் வந்து டைரக்டாக அதிகாரம் இருக்குன்னு சொன்னால் கோர்ட் உத்தரவின் பேரில் அதிகாரம் பெற்றதான் குவாசி ஜுடிஷியல் அமைப்பு. அதனால் போத் ஆர்டர்ஸ் டு பி ஈக்குவலி ஃபாலோட்.
தேங்க்யூ மேடம். ஸோ குவாசி ஜுடிஷியரி பாடி, அவர் டிஸ்ட்ரிக்ட் ரிவ்யூ போர்ட் இஸ் ஈக்குவல் டு ஆல்மோஸ்ட் ஈக்குவல் டு எ கோர்ட். ஓகே மேம், ஒரு பேசிக் டவுட்ஸ். சம்மனை நம்ம ரிசீவ் பண்ண முடியல அப்படின்னா ரிப்போர்ட் பண்ணணும்னு சொன்னீங்களா மேடம்? சப்போஸ் அவைலபிளாக இல்லை, இப்போ நான் புதுக்கோட்டையில் இருக்கேன், எனக்கு சம்மன் புதுக்கோட்டைக்கு வந்திருக்கு, பட் நான் ட்ரான்ஸ்ஃபர் ஆகி ஒரு வேறு ஊருக்கு போயிட்டேன், சம்மனை ரிசீவ் பண்ணுறதுக்கு நான் இங்கே இல்லை, அல்லது நான் புதுக்கோட்டையில் இருக்கேன் பட் அவுட் ஆஃப் ஸ்டேஷனாக இருக்கேன்.
சரிங்க சார்.
அப்போ என்ன மேடம் பண்ணணும்?
இப்போது அரசாங்க மருத்துவர்களுக்கு இப்போ அரசாங்க வக்கீல் இருக்கிறாங்க, பிபி இருக்காங்க ஒவ்வொரு கோர்ட்டுக்கும், அவங்களுக்கு நீங்கள் இன்ஃபார்ம் பண்ணலாம். இல்லை இப்போல்லாம் இமெயில் சிஸ்டம் வந்தாச்சு. கோர்ட் இமெயில் ஐடியை வாங்கி இந்த மாதிரி ஐ ரிசீவ்டு சம்மன், இல்லை நான் இல்லை அன்னைய தேதிக்கு இல்லை. இப்போ சாதாரணமாக நம்ம வீட்டுக்கு ஒரு லெட்ரு வந்தால் என்ன பண்ணுவோம்? ஒன்று நாம் வாங்குவோம், நாம் வாங்கலைன்னா நம்ம அப்பா அம்மா இல்லை அக்கா யாரோ வாங்குறாங்க, இல்லைன்னா போஸ்ட்மேன் என்ன செய்கிறாரு, திருப்பி எடுத்துகிட்டு போகிற இன்டிமேஷன் கிவன் ரெஃப்யூஸ்டுன்னு ஒரு எண்ணி கொடுக்குறாரு. அந்த மாதிரி கோர்ட்டுக்கு வந்துடுது. ஆனால் அதுக்குண்டான காரணத்தை சொல்லணும். உங்களுக்கு எப்படி நாலேஜுக்கு வந்திருக்கும் ஒரு சம்மன் வந்திருக்குன்றது? ஒரு ஹாஸ்பிட்டலில் இருக்கிறீங்கன்னா ஒரு டாக்டருக்கு சம்மன் வருது, அந்த டாக்டரு அந்த இன்ஸ்டியூஷனுக்காக அதை வாங்கலாம், உரிய நபருக்கு இன்ஃபார்ம் பண்ணலாம். ஆனால் வாங்கலை, இன்ஃபார்ம் பண்ணலாம், ஜஸ்ட் சொல்லவாது செய்யலாம். ஆக ஏதோ ஒரு தரப்பில் நாலேஜுக்கு வந்திருக்கும். நீங்கள் அரசாங்க வக்கீல் மூலமாக இன்ஃபார்ம் பண்ணலாம், போலீஸ் மூலமாக இன்ஃபார்ம் பண்ணலாம். நாலேஜை வாங்கிக்கிட்டு டைரெக்டாக இமெயில் ப்ராசஸை வச்சு நீங்கள் ரிப்ளை பண்ணலாம், இல்லையா நேரில் ஆஜராகலாம். ஆக மொத்தம் ஒபே பண்ணணும்.
எஸ் மேம், தேங்க்யூ மேம். இந்த சம்மனுக்கு அப்பியர் ஆகிற எக்ஸ்பர்ட் டாக்டராக அப்பியர் ஆகும் பொழுது இந்த மருத்துவர்களுக்கு இருக்கக்கூடிய உரிமைகள், ப்ரிவிலேஜஸ், அதை பற்றி கொஞ்சம் விளக்குங்க மேடம். ஏன்னா இப்போ கோர்ட்டுக்கெலாம் வந்தால் ஃபஸ்ட்டு ப்ரிஃபரன்ஸ் கொடுத்துட்றாங்க, அது மாதிரி எனக்கு தெரியாத உரிமைகள் அந்த மாதிரி.
இல்லை, இப்போ நம்ம அந்த ஆக்ட்லேயே சொல்லியிருக்காங்க, மருத்துவர்கள் வந்து அத்தியாவசிய பணியில் இருக்கிறதுனால அவங்க வந்தால் உடனடியாக விசாரித்து அவங்க அனுப்பி வைக்கணும்னு சொல்லப்பட்டிருக்கு. அதெல்லாம் எங்கள் கோர்ட்டில் நாங்கள் ஃபாலோ பண்ணுறோம். அதே மாதிரி ஜட்ஜிக்குமே வந்து நான் ஏற்கனவே சொன்ன மாதிரி எக்ஸ்பர்ட் இல்லை, மெடிக்கல் டேர்ம்ஸ் தெரியாது. அதே மாதிரி அக்யூஸ்டு கவுன்சிலுக்கு தெரிய வாய்ப்பு இல்லை. அதனால் மருத்துவர்கள்ட்ட அவங்க வந்து எப்படியாவது வேகமாக கேட்டால் ஆன்சரை வாங்கலாமான்னு தான் மருத்துவர்கிட்ட கேட்பாங்க. தனிப்பட்ட விரோதம் மருத்துவருக்கு அவங்களுக்கு இருக்க போகிறது இல்லை. அதனால் நீங்கள் தான் கொஞ்சம் அதை தெரிஞ்சுக்கிட்டு கொஞ்சம் பதிலை கொடுக்கணும். கோர்ட்டுக்கு தான் நீங்கள் அசிஸ்ட் பண்ணுறீங்க, அந்த அக்யூஸ்டு கவுன்சிலுக்கோ இல்லை. சட்டத்தில் என்ன சொல்கிறாங்கன்னா, அவங்க அக்யூஸ்டுக்கு இருந்தாலும் அரசு தரப்புக்கு இருந்தாலும், அதாவது அந்த உண்மையை கொண்டு வர்றதுக்கு தான் மருத்துவர்களுடைய உதவி இருக்கணும் அப்படின்ற மாதிரி தான் சொல்லப்பட்டிருக்கு.
தேங்க்யூ. ஸோ டியர் டெலிகேட்ஸ், ஃபார் த நான் தமிழ் ஸ்பீக்கிங் ஃப்ரெண்ட்ஸ், மேடம் ஹேஸ் given in nutshell about the duties of a psychiatrist regarding Mental Health Care Act, and also about what is summon, what is, how to receive it, how not, if what you have to do if you can't receive. In a nutshell, we can conclude this as whatever that is திரும்ப சொன்னாங்க, whatever that is done in good faith. You have asked, சொன்னீங்க இல்லையா, அட்டெண்டர் இல்லைன்னா என்ன பண்ணுறதுன்னு. whatever that is done in good faith will be taken in a positive way. So it is the duty of the doctor to treat the patient. அதுதான் ஃபஸ்ட்டு மேடம் சொன்னாங்க. ரெண்டாவது, சம்மன் ரிசீவ் பண்ண முடியலனா you need not panic, you can send an email or inform the police person who is giving the summon to you or the pleader, அரசு வக்கீல், அவங்கள்ட்ட இன்ஃபார்ம் பண்ணி தகவல் கொடுத்தணும் நம்மளால் வர முடியல அப்படிங்கிற விஷயங்களை. ஸோ உங்களுடைய டவுட்ஸ் எல்லாம் கொஞ்சம் கிளாரிஃபை ஆகிருக்கும்னு நினைக்கிறேன். தேங்க்யூ. ஐ ரிக்வெஸ்ட் அவர் சேர்பர்சன்ஸ் டு கன்க்ளூட் த செஷன் அண்ட் ஃபெலிசிட்டேட் அவர்.
சார், நான் சொன்னது முழுமையான தகவலானு ப்ரொஃபஸர்லாம் உறுதிப்படுத்திக்கோங்க. தேங்க்யூ.
ரொம்ப நன்றி மேடம். தேங்க்யூ வெரி மச். ஸோ மேடம் வந்து நம்மளுடைய டைம் எல்லாம் ஒதுக்கி நமக்காக இந்த சண்டே வந்து அவங்களுடைய எக்ஸ்பீரியன்ஸு அந்த லா பற்றிலாம் ரொம்ப சொன்னாங்க. கட்டாயம் இது வந்து நம்மளுடைய மனநல மருத்துவர்களுக்கும் இல்லை பயிற்சி பட்ட மேற்படிப்பு மாணவர்களுக்கும் கட்டாயம் இது உபயோகமாக இருக்கும் அப்படிங்கிற நம்புகிறேன். ரொம்ப தேங்க்ஸு மேடம். தேங்க்யூ ஆல். தேங்க்யூ வெரி மச்.
Thank you, madam, for your eye-opening speech. I request Senior Consultant Psychiatrist, Mercy Hospital, Dr. Annadurai sir, to honor the esteemed speaker.
Thankful to our honorable judge for the august presence as well as our deputy elected election. Thank you.
Thank you, sir. Thank you, madam. I request Honorable Additional District and Sessions Judge Tirumadi G.M. Vasanthi madam to honor the chairpersons. Thank you, madam. We'll have a short break, tea break now for about 10 minutes. Kindly sign for the second day attendance. PGs, kindly sign in the second day attendance. It is kept in the first floor registration counter.
Attention, PGs, postgraduates, please stay back for a minute. It's time to announce the results of poster presentation. So, please stay back. So, the first prize goes to Deepika Devi, a rare case of hallucinogen persisting perception disorder in a patient with dimethyltryptamine, Stanley Medical College. Second prize goes to M. Venkatesh, Government Chengalpattu Medical College, case of self-inflicted cutthroat injury and alcohol withdrawal delirium, case series. Third prize goes to Dr. A. Kirtana, Trichy SRM Medical College, a case of clindamycin-induced psychosis during post-operative period. Others who have presented posters will get poster presentation certificates. Okay. Congrats to all.
Poster and questing winners will be given our cash prize. Okay, stay back for the valedictory.
So stay back for valedictory function.
Presentation gracefully. Do's and don'ts in liaison psychiatry by Dr. Mohan Raj. Mohan Raj sir, consultant psychiatrist, Chennai. Welcome to the dais, sir. PGs, please enter the hall.
பிஜிஸ் இங்கே இருக்கிறவங்க வெளியில் போயிட்டு கொஞ்சம் சீக்கிரமாக அசம்பிளாக சொல்லுங்கள். ரிக்வெஸ்ட் யர் ஃப்ரெண்ட்ஸ் டு கம் இன்சைட். அவர் ப்ரொஃபஸர்ஸ் ஆர் வெயிட்டிங். கொஞ்சம் போய் வர சொல்லுங்கப்பா. வந்து இங்கேயே காஃபி குடிக்கட்டும். வர சொல்லுங்கள் ப்ளீஸ். உங்கள் ஃப்ரெண்ட்ஸ் எல்லாம் வர சொல்லுங்கப்பா.
Navigating Collaboration Gracefully, Do's and Don'ts in Licensed Psychiatry by Dr. Mohan Raj Sir, Consultant Psychiatrist, Chennai. Welcome to the dais, sir. We request Dr. Sendilvelan Sir, Founder cum Director of Vidial Hospital, Karur, and Dr. Palanivel Rajan Sir, Consultant Psychiatrist, PVR Hospital, and Secretary, API Pudukkottai, to the stage to say a word about our speaker and chair the session. Welcome to the stage, sirs.
So at the outset, I thank the organizing team and Karthik for inviting me as the senior physician in psychiatric CME. So the topic looks convincing to chair the licensed psychiatry. So psychiatry in a way is almost every branch of medicine has to deal with the psychiatric patients, right from pediatrics to geriatrics, and especially with general medicine, we see a chronic, all these diabetic, hypertension, CKD cases, all these cases, they will be having some sort of psychiatric illness or mild depression at some stage or later. So we have a licensed psychiatry, especially to deal with psychiatric illnesses causing metabolic syndrome, or all these chronic medical conditions causing a psychiatric illness, and psychiatric disorders, and psychiatric illness presenting to us in manifestations of psychiatric illness presenting organic disease presenting in a psychiatric manner. So all these things can happen. So medicines and psychiatry go hand in hand. So I thank the organizing committee for inviting me this topic. I hand over to my senior and my friend Dr. Sendhirvel sir for introducing the speaker.
Good morning. I am Dr. Sendhilvelan. I am a consultant psychiatrist and running a 30-bedded psychiatric hospital in Karur. And I am the first postgraduate student of Stanley Medical College. I have been proud for that. And I am very happy and privileged to introduce our speaker, Dr. Mohan Raj. He is an eminent psychiatrist from Chennai. He has become a psychiatrist by choice and not by chance. He has been serving humankind for nearly 3 decades. He is an excellent psychiatrist, and as you all, we are also waiting for to listen his wonderful presentation on licensed psychiatry. So over to Dr. Mohan Raj.
Good morning. I'm delighted to be here in front of senior psychiatrists like Dr. Zaman, whom we have heard a lot during our student days from his colleagues in IMH and NIMHANS. And delighted to stand before senior psychiatrists like Dr. Professor Rajkumar, Professor Rajeshwari, and dear colleagues and dear students. I thank Pudukkottai District Psychiatric Association, Dr. Zaman and Dr. Karthik for this wonderful initiative of bringing an academic program to Pudukkottai and doing it so well that we know it's only a matter of time before our conferences come to Pudukkottai. Thank you, Dr. Karthik, and congrats for this wonderful program. Wish you many more conferences in Pudukkottai. Yes, sir, and it's excellent, excellently executed. And I also thank IPS Tamil Nadu, Dr. Paneer Selvam, and the whole team for giving me an opportunity to be here to talk about an important topic. It's licensed psychiatry, navigating collaboration gracefully, do's and do's. Normally, any program, any movie will end with a court scene. That will be the climax. But today the court scene was before the interval. That's probably why we lost some of the audience, because they thought the whole thing is over. And now that you have come back, let's start and discuss about something. What do we do while we are in licensed psychiatry? And some of you who are Tamil Nadu, mainly the psychiatrists are all trained in medical colleges. And you will ask, what is so great about licensed psychiatry? Because that's what you do regularly. Licensed psychiatry is a branch of psychiatry that deals with referrals from other specialties. So you might say, what is the big deal? That's what we are doing every day. Whereas some of us oldies are trained in mental hospital. Like I was trained in NIMHANS, which is a mental hospital which only above foramen magnum. Because we have only 2 clinical units apart from psychiatry, neurosurgery and neurology, from where we get referrals. So our even Ofthal ENT was not there. We can't even say we were dealing with a head. We were dealing with only above foramen magnum. Whereas you have opportunities to be posted in general hospitals, or you are actually part of a general hospital where this is routine. You don't even call it licensed psychiatry, but we are talking about early days when they had to make a distinction that apart from mental hospital training, you have to get training in a general hospital to have interface. Because if you are trained in a mental hospital, you come out and you suddenly get referrals and you have never seen anything like that. That's the reason. Now, mind and body. How many of you think mind and body are interlinked, strongly interlinked? Put your hands up. Okay. How many of you, what is the location of the mind? It's a very stupid question to ask a group of psychiatry postgraduates. Let me just ask. How many of you think mind's location is in the brain? Put your hands up. I said it's a stupid question, but how many of you think it's in the brain? I see only few hands up. Did you all hear the question? How many of you think mind is located in the brain? Okay. How many of you think mind is located in the heart? No one. But why do you put heart emojis when you like something on social media? We'll find out the reason. How many of you think mind is outside the body? It's not inside the body, mind is outside the body. Nobody. Okay. So I presume all of you said mind is in the brain because only half the crowd. Okay. Have you heard doctors telling patients, hey, you have nothing wrong with your body. Go to a psychiatrist. You must have heard this. Now, our chief guest yesterday was gracious enough to talk about family, and he said his mother had a abdominal problem. She had burning abdomen, and the doctors gave medicines and said, in addition, can you meet Professor Zaman? So he didn't say nothing wrong with you. He said, in addition, can you meet Dr. Zaman? He will help you. And the mother immediately said, am I mad to go there? But then convinced, tipped them, and she became all right. He was very gracious to talk about it. We all know that the mind and body are completely interconnected. Your mind can affect your body based on your brain has hypothalamus. Hypothalamus through the endocrine system can change your body. So there are so many psychosomatic disorders where you have a worry which is bothering you, but it can come out as gastric ulcer or hypertension or a cardiac arrest, and vice versa. There can be a lot of bodily symptoms, like common example is hypothyroidism presenting as depression, or hypothyroidism presenting as any hormonal problem can present. So actually it's both ways. But where did this mind-body dichotomy take place? Let's just go back in history, look at why this dichotomy took place and come back. So early days, when there was this thing about where is the mind located, people didn't know, because mind is a functional unit. It's not a structural unit. That's why all godmen talk about mind. You go to YouTube, everybody other than psychiatrists are talking about mind. Godmen talk about mind, religious leaders talk about mind, because it's a functional unit. So early days, they didn't know where. They were curious, opened up the body, they saw the brain. And you know what they thought for a long time, even the medical community thought brain is a cooling unit, because it was very soft, watery, and it was going, tubes were going all over the body, the neurons. So they thought the brain was there to cool the body. But Hippocrates, as early as this time, said that brain is the seat of intelligence. So we think, okay, from that time it was all well established. No. Plato also agreed with his teacher. But then came a person called Aristotle, who is the culprit, who is responsible for us putting emojis in social media, because he was vehemently saying heart is where the mental processes take place. He was so persuasive. Even in our day-to-day language, we say heartache, brave heart. And Tamil, you have idayam vedichu pochu, idayam kanakkudu, idayatha nee odachita. So it's come into all languages primarily because of this man Hippocrates. Because subsequent to Hippocrates, something else also happened. There was this mind and body. At least he said it's inside the body. Now there is somebody who told mind is outside the body. Any postgraduate wants to venture? Who said this? Okay, there is this person called René Descartes. Please go back, read his original paper. Nowadays internet is there. All of you go back and read history also, because René Descartes said that mind is outside the body. He said the body is like a mission and mind is like a ghost. So his model was called, later people said, ghost in the mission. So the mission will work only when the ghost operates it. Once the ghost goes, the mission is gone. So once the person dies, the mind is gone, the body is there. And this was so, he published this paper at this time. This was so influential. Like, let's not make him a villain, because he has also written a lot of good things which we still follow. One of the major works of René Descartes is, he said, be skeptical. You know, when COVID happened, we kept saying, trust science, trust science. I said, no, you should not say trust religion. Yes, trust religion. Science, René Descartes said, please question, be skeptical. If somebody says, this medicine is effective, be skeptical, ask how. So that's the only way science can grow. So during COVID, we made a major mistake saying trust science. No, question science, and we are willing to answer, and we are willing to say, okay, we know only this much, we don't know this much. So that's one of his contribution. He had a lot of other contribution. Please read about his life. And he also operated at a time when Galileo was prosecuted. So he had actually withheld many of his publications because he didn't want to fight with the church and end up in gallows. So he published some of his studies later. So, but for us, one of the major disadvantage he did was this mind-body dichotomy. And people were for us it was very nice to believe it, because How many of you believe that your grandfather, grandmother are watching over you and blessing you from above? How many of you? We all believe, no? It's so nice to believe that after my death, actually, I will survive my body. I can be there looking after my children and grandchildren. That inner thing, science tells us mind is gone when the body is gone, but there is some nice desire that, okay, I will outlive my body. So we embrace this idea of mind-body dichotomy. That's why people say about, they use mind in so many different ways. They call about Atma or whatever. And each religion talks about experiences after life. I'm not going to each of the religion explanation. So put together, we all believe mind is outside. None of you put your hands up, but most of us would like to believe our mind will survive our death. Now, then came 1848, Phineas Gage. For psychiatry students, I shouldn't talk in detail. Is there anybody who has not heard about Phineas Gage here in this audience? I'll briefly tell you, he was a railroad worker. He was in charge of putting gunpowder into the rocks. And while putting it, the gunpowder exploded and the rock went through his back, came out through his frontal lobe, and he had lot of behavioral changes. And that is the first time they were demonstrating, yes, brain injury can change behavior, so mind is probably in the brain. So this is the first, and they took him to the rod was removed, but he continued to he had a damage to his brain, his behavior changed, so he was taken to many of the conferences of physicians, neurologists, psychiatrists, and shown that brain damage can cause behavioral change, so brain is somehow involved in behavior. Now I'll skip a lot of history in between, but go to major landmarks. Based on that, Paul Broca extensively studied and talked about localization, and subsequently 1818 Johann Heinworth coined the term psychosomatic to mention if there is a mental process that can affect your body. And Felix in 1922 proposed the name psychosomatic medicine, and 1902 saw the first General Hospital psychiatry unit in Albany in US. Till then, it was all in mental hospitals. In India, it was started in 1933 in Calcutta by Dr. Gireendra Shekhar. That's a little bit of history for you. And then what happened was, this was all before the introduction of chlorpromazine, 1954. Briefly, chlorpromazine was brought in as an anesthetic. It was like an oral anesthetic which you can take and the patient goes into a deep sleep. It was supposed to be a very promising anesthetic, but whenever they tried surgery, the patient got up, so it was a failed anesthetic. They said we can't use, but Delay and Denneker in two different hospitals saw this and said, why don't we use it in our mental hospital where patients are agitated? Like, we can't do anything. When they become all right, we send them home. When they become asymptomatic, they are brought back. So at least let them give us some sleep. And they gave chlorpromazine, and sure enough, people went to sleep and they thought, okay, we have already found, we at last found a sedative which can make people calmer. But 2-3 weeks later, without they having any plan, suddenly patients said, why am I here? Why did I talk like that? I was saying I was hearing voices, now I don't hear any voices. And suddenly they realized chlorpromazine was not just a sedative, it was doing much more than that. And that was a turning point in psychiatry, that there was a medicine which can change hallucinations and delusions, and that led to closure of many mental hospitals, and that necessitated people to go back into the community, and who is going to take care? That is when much more general hospital psychiatry units were set up. So this was one pivotal point where the numbers increased. And 2003, American Association of Psychiatry, not the board, decided to have a subspecialty called consultation liaison. Recently, and it was called psychosomatic medicine. Association was also psychosomatic medicine. 2017, they changed the name to consultation liaison psychiatry, because that's what the world over they were using that name. Psychosomatic can mean a lot of different things. So that's briefly history. There are a lot of milestones in between, but as today's talk is not about history, I love history, but today's talk is not about history, let's go further. Now, there is consultation licensed psychiatry can be broadly divided theoretically into many, but I am just talking about only one division called reactive and proactive. Reactive is when a referral comes, we go and attend. Proactive is a psychiatrist is part of the unit. Like if there is a casualty, you could either go only when there is a call. Proactive is you are part of the casualty team, so you get to see everyone. Do you remember our gynecologist telling us that there are people who are depressed, we don't even realize they are. But if you had a psychiatrist or at least a psychiatric postgraduate posted in OG, you're not going to miss that. So the proactive is, you say there is an ICU team, there should be a psychiatrist who goes, or even if the psychiatrist has other responsibilities, goes to the ICU, does a round, even with when they go for a round, psychiatrist goes along with them. That's proactive. So depending on resource, sometimes in less resource, we will use reactive where we go for consultation. So let me talk about the topic today is some of the do's and don'ts. So I was wondering how to plan this. So I have talked about arbitrarily, talked about conditions where we are called and where I will talk about some of the do's and don'ts rather than just rattle off some list of do's and don'ts. So let's now go to the emergency, casualty. What are the kind of referrals we get? There are many types of referral, but let me focus on 2-3 important ones like suicidal attempt, self-harm or delirium. There are much more you can imagine, but let me just limit to these 3. So when you talk about suicidal attempt, okay, before that. Now, have you heard any casualty medical officer saying, oh my God, suicidal attempt, so big headache, why are they even coming? Have you heard this? Anybody telling you? In ICU, like you would have all been to your house agency in ICU, when you get a suicidal attempt patient, are you happy or are you like saying, oh my God, why not? Because you're already overworked, you're on 12-hour shifts, there's a lot of work, there are people who are dying, and when you think you got a 1-hour break, somebody comes with a suicidal attempt, so everybody says it's a headache. Now, one more reason why they say headache is some of the patients make lot of noise, bring the whole world down. They'll say, attend to me, I've attempted suicide. They want attention. That's primarily because now you know that suicides, multiple reasons are there, social reasons, but according to psychiatrists, the most important reasons are due to severe depression or impulsive attempt. They have no depression, but suddenly a news like they have failed in their exam. Fail meaning what? They got 98 badal, they got 95. So, or he proposes, the girl says no, immediately suicide attempt. So that is the impulsive. First one is severe depression, and the third one is the one who makes all of them think suicide patients are headache, because these are the manipulative ones who propose to a girl, girl says no, they take 2 paracetamol and call everybody and said, Macha, I have committed suicide, get admitted, make a big noise, have abdominal pain, attend to me. They say there's a head injury patient, we are attending, no, I have head. So these guys are the ones who make a lot of noise, whereas a severe depressed patient is either in deep coma because they have taken a huge amount, or they are already in the mortuary. So the doctors see only the manipulative ones and they remember the most loudest ones and say suicide patients are a pain for us. So we have an opportunity when we go there, assess, and if there is a relatively less time, to teach the junior doctors there. Suicide can be due to these 3 major reasons. I'm not going to a lot of other social reasons. These 3 major reasons. So please assess anybody with suicidal attempt as due to severe depression. Because suicidal depression patient already has guilt, already has hopelessness. If a nurse tells him, we have not slept for 12 hours and morning 3 o'clock, why did you have to take this and come? He will feel, oh my God, I am troubling them. He already thinks he is a burden to his parents and he has taken an overdose. Now he thinks, oh my God, I am troubling this nurse and the medical team, and he might attempt again if somebody says something like that, any harsh word. So my appeal is to teach all the medical officers, nurses and others that treat every attempt like it could be a genuine severe depression until otherwise, because the way you handle will all be different. Severe depression, we need to be very, very careful. Suicidal risk precautions have to be taken. Impulsive attempt is more of how to teach them coping skills over a period. and manipulative, it's to not reinforce the family. So that will differ, but tell everybody that it could be severe depression. Another thing we'll be called to do is, after a suicidal attempt, risk assessment. Is the patient risky? So unless otherwise proved, consider everybody as severe depression. Make sure that there is no sharp objects. Many times I see in hospitals where whatever injections are given, the syringe is left near the patient. So make sure that things are free, and risk assessment to give them, yes, he needs continuous monitoring, or risk is less. Like a impulsive attempt, they regret immediately, and you can say the risk is less. And intervention, as I told you, depression needs a different kind of intervention. Sudden attempt, impulsive attempt needs more of reassurance, coping skills subsequently, and the manipulators need a completely different approach. When to shift to the ward? Is the patient safe enough to be shifted to a ward? If at all shifted, should he go to an ICU where at least somebody is watching him all the time? Even if medically he doesn't need, should he go there? Is there a psychiatric ICU, or is he physically good enough? Because sometimes the type of tablets they have used can be very high. If it's a well-planned suicide, they might have to be in a medical ICU for a long time, so you cannot shift. So you help them in the medical ICU, but on the other hand, if the medical problem is solved, then you can shift them to psychiatric. All those decisions have to be taken when to shift to psychiatric ward. And as I said, it's an opportunity for us to sensitize doctors, nurses, and other staff which are there, which I've already spoken about. The second group in casualty, the referrals can come as repetitive self-harm. Somebody cutting their arm and coming again, the staff will respond with irritability. Why do you have to cut on my duty day? Many of them say that, like, you came last Thursday, I've sutured, why did you come on a Thursday? You could have come on another day. So what happens here is we need to teach them about personality disorders. Most usually cut is by histrionic for manipulation, or borderline. If you ask them why are you cutting, they say the physical pain is better than the mental pain, at which you need to explain. And sometimes in borderline you might feel we are helpless, what can I do? But I would say one thing you can offer in the casualty is kindness. And you don't have to teach kindness to others, but you being kind to the patient, others will also start learning. Because there are many times patients come back much later and say, I know I drove you all up the wall. 10 years later they come and say, but every time I came to the casualty with a cut, I know you people treated me kindly and I thank you for that. It has happened because some of them become friends. They are like cutting regularly. They know all the surgeons. They know all the nurses in the casualty, and after some time they treat them very well and say, what happened this time? Don't worry, we are all there. So they remember this kindness. Even if they are not doing any psychotherapy, they are thanked by the patient. Then we have delirium, and to this audience, I think I won't go into the detail. It could be metabolic causes. Dr. Karthi was telling yesterday about when he goes into renal unit. Any unit, I think, look for electrolyte disturbance. Most common cause for delirium. Toxicity due to infection or side effects of medicine. One of the common referrals we get from neurology is an old man having delirium. They will say abnormal behavior, but he's a Parkinson patient on high dose of triaxphenidil. Definitely he will go into delirium. So all you need to do is please stop triaxphenidil. So any medicine which can cause delirium. Then we need to treat delirium. Just because delirium is due to electrolyte disturbance, we can't say manage electrolyte disturbance and go off. You need to give them something to bring down the agitation. So usually we use low dose quetiapine because it doesn't cause extrapyramidal symptoms, and then help them to find the cause. Don't use the word organic because many of them don't understand. Don't say this is not ours, this is organic. You can say this is delirium. Delirium also sometimes they may not understand. They will want to be told encephalopathy. It's the same as delirium. We are using different language, that's all. And if in the notes you can, if the investigations, if you can find out, tell them what is the most likely cause and they can treat accordingly. Now let us shift from casualty to the wards and OPD. I will include the OPD also there. So you have, I'll go a little faster the time, patients with comorbid psychiatric, and one of the common call is patient has a known physical illness plus a psychiatric illness, like for example, depression in patients with diabetes, heart disease, stroke, cancer. Now, all of them can have depression for different reasons. It could be because of the disability, in HIV because of stigma, back pain because of the pain, cancer because of the prognosis. So many things can cause depression, and we need to treat accordingly. Now, there are a lot of papers which say treatment of depression in a comorbid condition helps, like backache with depression. If you treat the depression, backache has better prognosis than treated alone. And there is one study in NHS which says if there was a consultation psychiatrist as part of the unit, the length of stay comes down. That administrators like that length of stay comes down, cost comes down. So they take that kind of thing. So it improves the physical program. Any illness, for diabetes, one of the common reason diabetes is uncontrolled is because people are not motivated to exercise regularly, not motivated to take the medicine regularly because of the depression. So once you treat depression, they do their exercise regularly, they take their medicines regularly, and improvement in depression happens. Then you have depression in patients with hypertension. Why I excluded this is atenolol is one of the common medicines given in CGHS dispensaries, and many people develop depression after they are on atenolol. If you read history, you will know that reserpine was a treatment for hypertension. People develop depression. That is how the amine hypothesis comes. So if you deplete amine, BP comes down, but people become depressed. So maybe increasing amine will help people with depression. That is how your amine hypothesis, serotonin, noradrenaline all came. So atenolol still is in the market. It's a very good drug, but in certain old people, if they are on atenolol and develop depression, you need to be cautious. Now, depression in people with hypothyroidism, as I said, hypothyroidism itself can cause depression. Mania in patients with head injury and steroid, that another common referral we get. Patient develop with mania, and we can't just say stop steroids, because steroids is needed for bringing down the ICT. So you have to talk to the neurosurgeon, say, can it be stopped? If can be stopped, stop. Or if you cannot stop, fine, you continue to give, but we will give antipsychotics to counteract. Like for example, there are patients who are on Parkinson plus psychotic symptom because of L-DOPA. They have explored every other option, finally come to L-DOPA. They cannot stop. We can't just say L-DOPA is causing psychotic symptoms, stop L-DOPA. No. We talk to them and say, if there's no other go, okay, continue L-DOPA, but we'll also give some antipsychotic. It's like we have to both do a tightrope walking to make sure patient doesn't have Parkinson as well as psychotic symptoms. Now, psychiatric symptom as part of a physical illness. Because of time, let me not go into what kind of psychiatric symptoms come in each of this. Most of you will know. Psychotic symptoms in patients with unrelated physical. Here it is completely different. It's not either one causing, but both are there. So here the psychiatrist has to make a decision. Should we treat him in the medical unit or should we treat in the psychiatric unit? That depends on what is the medical problem, how severe, what is the psychiatric problem, how severe, and or both, like who comes here. If he's in the psychiatric unit, the physician has to come. That's a decision you have to make between yourself. Now let's shift to the next reason why they are referred. Medically unexplained physical symptoms. Many times they are referred that we have checked everything and we can't see what the cause is. So here it's a broad range. When there is a medically unexplained symptom coming to you, it could be something like a factitious illness like Munchausen, where they are malingering from one end, to a rare genuine illness, which you don't think about a rare illness with the symptoms. You try to say and you say you can't explain, must be psychiatry. Many times patient is told, oh, you don't have anything wrong. No, the best thing is to say, acknowledge, and the common symptoms are pain. Common symptoms are pain, lethargy, and it can be anything, like some patients, blindness due to functional reasons like dissociative blindness. Football player came to us one day before a big match, he was paralyzed on one side. That's the leg he uses to kick. Singers cannot sing suddenly before a big performance, dissociative, but they will reach ENT, they will reach neurology and come to you. So pain and lethargy are the most common symptoms where you can't explain, like you can't explain any physical thing, but pain is there. There, the physician should not tell the patient there's nothing wrong with you, go to a psychiatrist. They should acknowledge the pain. Even when you see, you should acknowledge the pain and say pain can be due to multiple reasons, and psychological distress can also cause pain. Can we explore that? So I will just briefly give you, there's not much time, but this I wanted to be interactive. History of 50-year-old female with fracture of radius, abdominal pain, excessive urination, thirst and fatigue. Anybody wants to take a guess on, I'll give information in pellets. Anybody wants to take a guess on what could be the diagnosis? I'll say osteoporosis also was there, fracture of radius, abdominal pain, excessive urination. He says parathyroid, diabetes. Okay, now I'll give you one more pellet of information. She had a history of 3 manic episodes in the past, was on lithium, hyperparathyroid, no, I have too many sounds. I'll take a little more time because of that. Yeah? No, too many people said, one person at a time. Lithium-induced diabetes insipidus. Okay, I'll give you one more pellet of information. She had thyroidectomy 5 years back due to a totally different reason, not lithium. Okay, anybody wants to revise? He said hyperparathyroid. Hypoparathyroid. Okay. Investigations. This is actual case. Me, orthopedician, endocrinologist, physicians went on a long struggle to find out. Calcium was high, parathyroid hormone was very high, vitamin D normal. Who said that? Okay. Because thyroid was removed and we said where can there be parathyroid? Because until we got the parathyroid hormone, in fact parathyroid was not checked. Calcium was high and phosphorus was normal, and we said what then? Anyway parathyroid is not there, thyroid is gone. Anyway do the test. We found parathyroid hormone. Okay. Yeah. Parathyroid was high. And post-thyroidectomy, so we were a lot of stumped, and finally we found ectopic parathyroid disease. When the head and neck surgeon went and like true Indians, we didn't publish it. Because very rare, we should have published, but we didn't. Okay, one more aspect. Have you heard this saying, if hammer is the only tool you have, every problem will look like a nail? Because we are psychiatrists, person with hyperthyroidism come, we will say panic attack and treat him and send. Patient with hypothyroid comes, has depression, we say depression. We have done all these mistakes. I'll probably for you tell you the story from the other side. Like we have done a lot of mistakes. There was a patient who had severe arrhythmia or heart beating faster. So he got a diagnosis of arrhythmia from the cardiologist. Went to a cardiologist, they did everything and said arrhythmia, they gave antiarrhythmic drug, it was not coming down. He went to another cardiologist, we kept on shifting cardiologists because they said it's not coming down. Third, fourth cardiologist started saying, why don't you see a psychiatrist? But he was refusing. Then he found a cardiologist who said it's arrhythmia. We have to do ablation of we have to give you a pacemaker. For that, we need to first inject alcohol, disable your node, and then give you a pacemaker. Our man had the date fixed, became very anxious, postponed it 2 times, very anxious about the procedure. Then he went to another cardiologist to say, is there any way I can avoid pacemaker? So he said, why don't you see a psychiatrist once? And then the psychiatrist, he was a teacher to me, sent to me, and he had panic disorder and treated and he became all right. So this is the story from the other side. He was about to be put a pacemaker, whereas we do that mistake many times. We mistake hyperthyroidism and whole lot of other conditions because there is a presenting psychiatric symptoms also. Then another common reason we are called is psychiatric fitness. This was discussed a lot yesterday. Let me skip because of time. So let me quickly go through some of, sir, I'll be finishing very fast. Quickly go through some of the do's and don'ts. make sure the patient is informed. Do you remember the gynecologist saying that when we say go to a psychiatrist, they say, no, we won't go because of stigma? So many times they refer, they don't tell the patient. You land up and you say, I'm a psychiatrist, and they say, who asked you to come? So make sure, ask the referring team, have you informed the patient, consent taken, because you don't want to land up and waste your time there. Then once you go there, introduce yourself. Sometimes they will say, can you say you are a friend? Can you say your father's friend? No. You will have to say, I'm a psychiatrist. If patient is not willing, doesn't matter. Let the patient be willing 10 days later. But don't go and say, I'm a friend of the doctor. No, you need to introduce yourself and say, I was given this referral, I've come to evaluate, because it sets the context. Once my friend's friend wanted to evaluate his mother, and he said, please, please don't tell psychiatrist, I will say you are a friend. And I went to her house, this was long back, and the context is not there. How can I even ask any question? So when this is supposed to be my friend's mother, and I ask her, how is your sleep? And she's saying, why are you asking me about sleep? So very awkward it is. So you need to clearly say I'm a psychiatrist, because you can't ask about how did you sleep, or do you get thoughts of this, thoughts of that to some stranger where you meet a friend's mother. So you say, I cannot do that. I need to say I'm a psychiatrist. Read the case sheet carefully, because most of the information will be there. Look through the investigation, because that will give you a clue as to what the diagnosis is. And look for hepatic renal impairment, because if you're starting drugs, don't start the usual drugs. You need to start much less drug, because if they have a renal impairment, you have to avoid certain drugs if there is hepatic impairment. That's something which you need to take into account by looking at LFT and RFT. Consider drug interactions, and I have found one thing, you don't have to even remember drug interactions. Nowadays, patients appreciate you if you say, I will just look up whether you are on these drugs, ask them about what, even if it's OP or IP, ask them what drugs they are taking when you see them on OP. And when you are about to give a new drug, you say, I'll just check whether there's any interaction. They appreciate. They don't say, why don't you remember? No. They are very glad when you do it right there in front of them about interaction. So nowadays, you don't have to put all the interaction thing in your head. You can just look up Medline and tell them that there is a very less chance. You can tell them exactly what the Medline tells you with regard to interaction, because that's another question patients will ask. If you don't tell them, they will ask. So please refer and tell them. Don't go by memory and say, no, there are no, when they say, can this and this go well? No, don't flippantly say. You say, I remember, no, there is nothing, but I will check today whether anything new has come, and they appreciate that you are up to date and you check. Detailed history and physical examination, this goes without saying, because physical examination, even if they are referred, I had a very embarrassing situation once. Patient referred for ED by a center which trains in infertility. Husband is a physician, wife is a gynecologist. They had referred saying ED, and the husband's note clearly says examination of penis normal, everything, all the subsections normal. So I thought he has examined, and I didn't examine the patient. I sent to a urologist, and urologist called and said, Mohan, nee physical examination panliya? So I said, enna sir, illa, he has phimosis. I said, oh God. The infertility center did not even look that he had phimosis. They referred to me. I said, no psychiatric problem. I sent to urologist, and he says, did you look at? So physical examination, even if you have a detailed note saying no phimosis, because that doctor has clearly written phimosis, no, everything he has filled up. Don't go by that. Please examine yourself. So this is not just for this, even heart, stomach and all that, even if there are notes, please examine yourself. Inquire about substance abuse. That's something which we forget when we go to a ward. Please find out, because some of the symptoms may be a substance withdrawal symptoms. Detail MSc without saying it goes. All of you know that you need to do a detailed MSc. And write clear note, well-written notes about symptoms, diagnosis, management. And if a professor is going with PG students, professor should make sure it's written properly, because the PG doesn't write what he or she has understood. So make sure it's well written, and better still than a written communication would be talk to them, discuss with the treating team as to this is actually, I do this because it's like a teaching session for them, because most of our colleagues may have attended, may not have attended their 15 days of posting. So their knowledge will be very low. In fact, psychiatry posting should happen in final year and house agency for them to have some hands-on experience. So take this as an opportunity to say patient has this, consider this, and this is what I have started. So that each consultation, OP, same thing, you can call and talk to them or send a message and then follow it up with a talk about that. So this is something you please go talk to them. And you're all colleagues in a hospital across specialties. Go a little beyond and foster relationship among all the colleagues. It need not be only at a professional level. Have games, tournaments like IPS. We have this IPS fitness club which most of us exercise from various parts of Tamil Nadu and post. If you're not aware of IPS fitness clubs, please ask somebody and we will make you join that. So similarly in a hospital, if they have a fitness program where all of them are together, they are all part of a running team, they are all part of a cycling team, then your relationship is a lot more. When you go to their ward, you are like, I have a cyclist friend who's a nephrologist who refers, and the way we talk when I give a feedback is very different from somebody whom I know purely as a nephrologist, like he's my cycling buddy. So similarly, in a hospital, have cultural programs, have sports programs, so that you all get together once in a while, talk to each other, so that ultimately the patient benefits. So in that count, let me tell you one thing. When we say patient so far, who is this patient? Sometimes we say patient is like this, patient is like that. Patient is nobody. Patient comes from us. The patient is from the society, from us only. So patient is like anybody. Like tomorrow, I can be a patient with head injury. I can be a patient on steroid with mania.
Sorry to interrupt. Okay, sir.
So patient is part of us. Like we are patient. That's something I want to have. And thanks for the tolerance to give me some more time. And I'll stop here, and if there are questions, I'll take questions. Thank you.
Very nice presentation, sir. Extremely good. And the last 15 minutes was really good. So, as we are running short of time, we should conclude the session very fast. இப்போ சார் சொன்னதில் I would like to stress upon a few things from my life. So when I entered as a medical postgraduate student to Stanley Medical College in 2000, so whenever as a PG student of psychiatry, you develop goosebumps when you enter into the department of psychiatry. So you think you are a magician. So first Bono Nime, my assistant, Dr. V.S. Krishnan asked me, where is your stethoscope? Don't you think that you are a doctor? You are not a magician. So stethoscope எடுத்துட்டு வா, ophthalmoscope எடுத்துட்டு வா, knee hammer எல்லாம் எடுத்துக்கணும். First you are a doctor. So wherever the referrals coming from, don't hesitate to examine and make your own diagnosis. Whoever may be the referring physician, even if he is a top-notch specialist in the city, you play the ball, don't play the bowler. You make your own diagnosis. So நாங்கள் ஸ்டாலியில் இருக்கும்போது we get lot of referrals from other departments and we make our own diagnosis and we refer the patient back to the departments making a medical diagnosis. ஏகப்பட்ட தகராறு நடக்கும். பட் என்னுடைய ப்ரொஃபஸர் சொல்லுவார், என்னுடைய அசிஸ்டன்ட் சொல்லுவார், விஎஸ் கிருஷ்ணன், அவனும் மனுஷன்தான், நீயும் மனுஷன்தான், பேர் இஸ் ஹியூமன், எல்லோரும் தப்பு பண்ணுவாங்க. தட்ஸ் வாட் ஹி செட். ஸோ இப்போ பார்த்தீங்க அப்படின்னு கேட்டிங்கன்னா, when I completed my PG and entered into Pudukkottai Medical College, Pudukkottai GH, then it was a GH, fantastic GH to work with. சார் அதில் எல்லா பாயிண்ட்டும் சொல்லிட்டார். ஸோ உங்களுடைய கலீக்ஸோட எப்படி நீங்கள் இருக்கணும் அப்படின்னு சொல்லிட்டு, I would like to remember some of the stalwarts of Pudukkottai GH. Dr. Zaman, Dr. Kalyan Kumar is sitting there, Pudukkottai MGR, and Dr. Ravinathan, Ravi Kumar, Dr. PLS, Kannan, Rajaram, fantastic team. So, பார்த்தீங்க அப்படின்னா சார், psychiatrist, they have given me a separate ward, separate OP. So, it was a very difficult thing at that time. If you are working in a GH, they say, நீ ஒரு assistant surgeon, போய் general OP பாரு. But in Pudukkottai only, you go and look after your psychiatric OP. You do your ward duties. Daily calls இருந்துக்கிட்டே இருக்கும். Surgical ICU, medical ICU, post-operative ward, Rani's OG's ward, skin department, pediatrics, எல்லா பக்கமும் கால்ஸ். டாக்டர் ராஜா இருக்கார், ஒரு சர்ஜன், இப்போ நீ காலையில் கூட வந்தார். ஒன் டே பார்த்தீங்க அப்படின்னு கேட்டிங்கன்னா இங்கே ஃப்ரீக்வெண்ட்டாக வந்து புல்கோர் இன்ஜுரிஸ் இருக்கும். த்ரூ அவுட் த இயர் பார்த்தீங்கன்னா புதுக்கோட்டையில் பார்த்தீங்கன்னா ஜல்லிக்கட்டு நடக்கும். ஸோ ஒன் டியூட்டியில் பார்த்தீங்கன்னா நான் தான் கேஷுவல் டியூட்டி மெடிக்கல் ஆஃபீஸர். There are 4 புல்கோர் injuries, 4 went for hemicolectomy with colostomy. 4 பேர் ஆல்கஹால் டிபெண்டன்ட்டு. On the day admission was the last drink. So second PODயில் all of them developed delirium. ஸோ எனக்கு பார்த்தீங்க அப்படின்னு கேட்டால் I was with them for 3 nights. ஸோ அவங்க சொல்லிவிடுவாங்க, சார் as a surgeon you have done our things, you are the psychiatrist, patient is in delirium tremens. அவன் எல்லாம் இங்கே ஸ்டோமாவோடு இருப்பான், நம்ம தான் சுற்றிக்கிட்டே இருக்கணும் வார்டுக்குள்ளே. அதே மாதிரி பார்த்தீங்கன்னா ராணிஸ்லாம் பார்க்க கூப்பிடுவாங்க, கால்ஸ் கூப்பிடுவாங்க. பேஷண்ட் பயங்கர வயலண்ட்டாக இருக்கும், சைக்காட்ரிஸ்ட்டை கூப்பிட அப்படிம்பாங்க. பேஷண்ட் டெலிவரி போர்டில் இருக்கும், டான்ஸ் ஆடிக்கிட்டு இருக்கும், ஹெட் க்ரௌனிங்கில் இருக்கும். நம்ம வந்தோடனே சைக்காட்ரிஸ்ட் வந்துட்டாங்களே நவருங்க அப்படிம்பாங்க. நம்ம என்ன பண்ண முடியும்? கட்டி போடியான் இதை சொல்லத்தான் அங்கேருந்து வந்தீங்களே, வேற என்ன பண்ண முடியும்? ஸோ லைசன்ஸ் சைக்காட்ரியில் இஃப் யூ வாண்ட் டு டூ திங்ஸ் பெட்டர் யூ ஷுட் ஒர்க் இன் அ கவர்மெண்ட் ஹாஸ்பிட்டல். தட்ஸ் த ஒன்லி திங். தென் you should do proper examination and proper case sheet writing. Thank you. So any questions from the floor?
Hope there are.
Sir, mic.
Sir, mic.
Regarding the location of mind, I want you to throw more light on gut-brain's connection influencing the mind and symptoms of mental illness. Number 2, comment, by way of comment, when you said that when you have a hammer as your tool, you see everything as nail. In villages, there is a Tamil saying, சரங்கு பிடிச்சவங்க கையும் இரும்பு பிடிச்சவங்க கையும் சும்மா இருக்காது, சொரிஞ்சுக்கிட்டே தான் இருப்பான். Like I was reminded of that one. Please proceed to throw light on gut-brain syndrome.
Yeah, sir, recently there is a lot of thing on gut-brain, especially with regard to probiotics, which they are already available. Probiotics are already there. So they have found probiotics have an effect on depression, anxiety, and in autism. So these are the 3 places where there are a lot of published studies. So then there are theories. Once you find some improvement, there are theories that how the gut can affect your brain. So, for example, you must have all had personal experience when you are hungry, you want a specific food, depending on the state you are in. You would want a fruit or you would want a protein. That somehow the brain sort of decides. That's one. Then there are this endocrine explanation. There is one, this thing, vagus nerve explanation. Then there is an immunological explanation. There are 3-4 explanations. They are all theoretical, but in practice there are studies which show that there is actually a feedback. Now I have been giving lactobacillus to some patients who are resistant to antidepressants and they do well. So there seems to be one connection is well established, that if you have a psychological problem, you can have irritable bowel syndrome, you can have a whole lot of gastrointestinal from GERD. That is well established. Now the reverse is being established, that if you take care of your gut very well, because the amount of RNA in the microorganisms in the body is much more than our central nervous system cells. So those RNAs can cause some changes. So reverse is also being looked at, that by changing your gut you can change your mind.
Yes, sir, rightly said. As a physician, I wonder how this licensed psychiatry, a special branch, can play a role in bridging the gaps. As you said, there is gynecologists, even I face most of my chronic patients, they won't accept at all. They have come to me for diabetic hypertension, CKD. How can I ask them to go and consult a psychiatrist? So they don't accept at all. At the same time, if it is reluctant to start the treatment for diabetes itself, if I start the tablet, I have to take lifelong. That will be the first question. So this licensed psychiatry, how far, I think I asked the senior professors here, to bridge the gap between the general practitioners. For example, suicide. All the suicide cases are being taken care by the general practitioners. I don't think they go to the psychiatrist directly for the treatment. So except for the de-addiction. So these suicide cases, they need a psychiatrist. Definitely they need a psychiatric follow-up, counseling and treatment for the at least for the next 3 to 6 months. So nobody is accepting it. So this licensed psychiatry, how far you can take it to the periphery to reach and so that to bridge the gap. And as sir told, most of the neuropsychiatric, especially SLE patients and all, they land with psychiatric symptoms in psychiatric ward only. After that only they can find out this medical diagnosis and they refer to us later as a medical. The neuropsychiatry is a entirely different section where the patients usually land up with psychiatry and later come to the neurology department. So I take this opportunity to request or ask the senior psychiatrist to bridge the gap in the periphery in the form of licensed psychiatry, so that the patient, we don't find it difficult to tell the patients to go and see the psychiatrist. To be frank, I think the PHFI is doing a job in conducting some courses. I actually finished, I was so much interested, and I was so interested in psychiatry during my UG days itself. So interested in doing, I finished that course itself. But even then, I think even though we did the courses, it's very difficult for us to titrate the courses. For small treatment dosage, amitriptyline or alprazolam, okay. For treatment and continuing it for a long duration, prolonged duration, and to titrate it up and stop, it's very difficult for us. So how to bridge the gap without, as you said, see, you cannot, without disclosing you as a psychiatrist, you cannot treat the patient or treat the problem lies there. The problem lies in disclosing yourself as a psychiatrist and making the patient know that he is getting treatment from a psychiatrist.
Yeah, good question, sir. Thank you. This depends on how the physician puts it forward. There are physicians, general practitioners who are afraid to even tell the patient go to a psychiatrist because they think patient will become angry and stop coming to see them. So it depends on how you say. So if you explain, if the physician explains or the general practitioner explains as some of these symptoms, first is acknowledging, saying you don't have anything wrong with your stomach, go to a doctor, psychiatrist, they will say no. But stomach problems can, like that's what the chief guest was telling yesterday, stomach problems can be due to psychological stress also. So why don't you go and see the psychiatrist in addition to that? That's one way of putting it. And also telling them, immediately they'll say, am I mad? So we need to also explain that psychiatry does not deal with only psychotic symptoms. Psychiatry has a whole spectrum, from psychotic spectrum to anxiety, depression, OCDs, to academic difficulties, shyness, to now nowadays I see a lot of sportsmen who have no psychiatric problem but who say that I can play very well in practice, but when a tournament comes I don't do well. So we do that kind of work also. So you need to say that we do from illness to wellness, like preventive and wellness.
Problem is with only a reactive licensed psychiatry. There is no problem with the proactive licensed psychiatry. The problem comes with the reactive licensed psychiatry, where we need to refer.
The way the people explain. So that is one way that you explain, convince the patient. That is one. Second thing is, we always tell family physicians and general practitioner is, second thing is, you are also like, see, MBBS is master of, like Bachelor of Medicine, Bachelor of Surgery, similarly Bachelor of Psychiatry also. So I tell general practitioners, please learn enough psychiatry. So you tell them, this is depression according to me, but if you are reluctant, let me start an antidepressant. But in case you are not improving or you have side effects which I cannot manage, I want you to see my colleague who's a psychiatrist. So sort of prepare them, but start on antidepressants, because sometimes people are afraid to even prescribe. But there are many good general practitioners who tell them it is depression, I'm starting, but sooner or later you need to go see my colleague, and they start, and patients see some reason there and patients come. Now, general physician and other specialists, attitude to psychiatry matters. Now, this can be two diametrically opposite, and that is invariably based on family history. If they have a family member whose expectations are not met by their psychiatrist, they have a very negative opinion. Even schizophrenia, they'll say, why are you giving medicine? Stop. Whereas if they had a family member who was well treated, then they go out of the way to convince the patient. So their attitude towards psychiatry also matters. Sadly, our 15 days of training in third year does not, because in third year you are very raw, you don't form opinion. So they are ignorant. So their attitude is found by, like, my uncle was treated by a psychiatrist and uncle had a lot of problems, so tell everybody don't take psychiatric medicine. Or my uncle was treated well, then become an evangelist for psychiatrists. So we see that in other specialists, both ways. So as I said, one is the way you explain. Second is you can start treatment. One group which I see is oncologists who say you have depression, I'm starting antidepressants, but because They don't wait. Some physicians will take it for granted if he has a scopy, like if he has a complex procedure, what will he be? He'll be depressed. Whereas they recognize and start. So I would always say, please start, then keep persuading them to. So don't, if they're unwilling, don't leave them. Start off, like, or sometimes what doctors do is, they are unwilling, but can you tell me what to be given? And they give us a history. And we say, fine, start this. That's at least a partial thing. Where I tell the physician, you can give this based on the history you give, and they start.
Well said, sir.
They want clarification on dosage, what to look for as side effects. That
Thank you,
works.
sir. Thank you, sir.
Well said, sir. As we are running short of time, we are winding the session. Do you want a question? Yeah, last question.
Short.
Last question.
It's not a question. So it was an excellent session.
Thank you.
And I think PGs here should pick up from how your slides were presented with very less matter, and so that's how you will focus on the speaker. And one thing which I was saying is, as you said, we should work as a team, being reactive and being proactive. Being part of the team helps. And within the 15 days or 1 month of training itself, we can identify undergrads and how they see improvements when they see psychiatric patients goes a long way. And being in medical college, we are able to at least motivate some students every year pick up psychiatry by choice. So I feel it's on the longer run it will help. Yeah. Another point, the suicidal thing which I've seen in corporate hospitals, even in corporate hospitals, we go as a team, we're able to make it better. Many times the poison which they took is kept beside them. ரெண்டு மூணு தூரம் என்ன இருக்குன்னா, என்ன பாய்சன் சாப்பிட்டோன்னா மற்றவங்களுக்கு தெரியல, பேஷண்ட் தாங்க சார் எடுத்து கொடுப்போம். ஸோ கேட்டால் இல்லை சார் உங்களுக்காக தான் வச்சுருந்தேன். ஸோ வி ஹேவ் டு மேக் ஷுர் தட் டேக் அ ஃபோட்டோ ஆர் டேக் அ லேபிள் அண்ட் ஸ்டிக் இன் த சார்ட். வி டோன்ட் நீட் தி பாய்சன் தேர். ஸோ தோஸ் கைண்ட் ஆஃப் திங்ஸ் ஹேப்பன் வென் யூ be as a team, and very good session again.
Thank you, sir. Just a response to that. Sir, if the psychiatry 15 days comes after medicine surgery, then their awareness is better. But some places it's the first posting before medicine surgery. They don't know anything because they have just finished anatomy physio.
Currently NMC has made it as 2 1-week programs, sir. So we might have it better.
In final year. AIMS has in third year, final year and house agency. So they are much more exposed.
Okay,
and,
sir.
I thank the organizers, Tamil Nadu IPS once again, and Professor Zaman and Dr. Karthik for this opportunity to interact with a lot of young minds. And thank you for being a gracious audience.
Thank you very much, sir. I request chairpersons to honor the speaker. I request Dr. Nirmal sir, HOD Dhanalakshmi Srinivasan Medical College, to honor the chairpersons. We have a few special guests to honor. I request Dr. Sivasailam sir, Tamil Nadu IPS Treasurer, to honor the guest of honor, Dr. Palanivel Rajan sir, Secretary Associations of Physicians India. I request Dr. Sendil Velan sir to honor guest of honor, Dr. K.H. Salim sir, Coordinator IMA Nursing Home Board.
I request our President sir to honor Dr. Salim sir. Salim sir, irunga. Dr. Salim sir, our IMA Nursing Home Board Chairman. IPS President sir, please. நம்ம ப்ரோக்ராம்க்கு வந்து நம்ம டாக்டர் சலீம் சார் வந்து ஐஎம்ஏ பாஸ்ட் ஐஎம்ஏ பிரசிடென்ட், இப்போ நர்சிங் போர்டு சேர்மனாக இருக்காங்க. ப்ரோக்ராம் அரேஞ்ச் பண்ணப்போ லாஸ்ட் மினிட்ல தான் நான் லோக்கலில் தகவலாக சொல்ல முடிஞ்சது, நேரில் கூட போக முடியல. சார் வந்து இந்த ப்ரோக்ராமுக்கு தேவையான பிரிண்டர் 2 வெஹிக்கிள் வேறு கொடுத்துருக்காங்க. தேங்க்யூ சார்.
Thank you, sir. I am honored to invite our next speaker, Dr. Suhas Satish sir, Assistant Professor of Psychiatry, NIMHANS, Bangalore, to enlighten us on the topic Deconstructing Somatic Symptom Disorders. Welcome to the stage, sir. The session will be chaired by Dr. Shivabalan Ilangovan, sir, Professor and HOD, Department of Psychiatry, Sri Lalitambikai Medical College and Hospital, Chennai, and Dr. Abhirami Vishwanathan, ma'am, Senior Assistant Professor, Government Mohan Kumaramangalam Medical College, Salem. Welcome to the stage, sir and ma'am.
இந்த மாதிரி இல்லையா பின் ஓகே ஓகே ஸ்லைட் சேஞ்சர் கொடுங்க.
We request the chairperson to introduce our speaker.
First of all, I congratulate all the postgraduate who participated on poster presentation. Really, all the posters were very good in the quality wise, content wise, and the discussion wise. They did very well. It's very difficult to choose only a 3, but everyone did their best. I congratulate them. So regarding the topic, in academic psychiatry, we are focusing only on the major mental illness, delusion, hallucination, phenomenology and other things. But in our routine clinical practice, we are often encountered with this kind of persistent somatic problem. Even the management wise, it's very difficult to treat the somatic symptoms. Even more than the treatment, the convincing the patient for take a psychiatric treatment, it itself is very much challenging. So in that aspect, this particular topic is very, very important one, I guess. Now I invite my other chairperson, Abhirami, to introduce about the speaker.
Good afternoon, everyone. It's an honor to introduce our speaker, sir. Dr. Sukash Satish, MBBS MD. Sir did MBBS from MS Ramaya Medical College, Bangalore, and MD in NIMANS. He did postdoctoral fellowship in clinical neurosciences and therapeutics in schizophrenia from NIMANS. Currently, he is the assistant professor of psychiatry, NIMANS. Awards and honors: World Psychiatric Association 19th World Congress Psychiatry, Early Career Fellowship Award, and NIMANS Silver Jubilee Award, Best Student MD Psychiatry in 2018. Dr. Frank Noronha Award for the Best Outgoing Resident, Department of Psychiatry, NIMANS 2018. Sir has 75 plus BUMMED indexed publications. Now,
thank you to both the chairpersons and thank you to the audience. So I'm the villain who is holding you between you and your lunch. And of course, an exciting session is also there in between on the long case, which I'm sure all of you are very, very enthusiastically looking forward to. Just before I started, Dr. Karthik Devanayagam sir came and asked me, sir, உங்களோட செஷன் எவ்வளோ மினிட் இருக்கு? So I think he was gently nudging me towards making this fast, making this important, making this concise so that all of you can actually benefit from this particular session. Firstly, I want to actually express my gratitude towards the Indian Psychiatric Society Tamil Nadu chapter, the organizing team, especially Dr. Karthik Devanagam sir and then Dr. Jeevita, who have been constantly in touch and facilitating all these excellent sessions and all the speakers. Dr. C. Paneerselvan sir, because sir has been the one who has actually invited me first time for the Evolve PG lecture series. I presented on schizoaffective disorder, which was well received. Then last year in Kanyakumari, presented on the art of excellence in postgraduate examinations, which was again well received. And sir has thought that, and the organizing team has thought that I could also do justice to this particular topic, and I'm very grateful for that. In addition to this, last and most importantly, I want to reserve my thanks to my students, because they are the ones who are actually making me a better teacher. So, 40 minutes. These 40 minutes, you're going to actually cover 3 main outlines in this presentation. Number 1, what is the concept of a somatic symptom disorder? How did it evolve? Next, 10 fundamental concepts, which if you understand, nobody can shake you in your examinations and thereafter as well. And lastly, what should be the approach? Suppose you have a bad luck of getting a somatic symptom disorder as your long case or short case in your examination. Okay? 40 minutes, concentrate, because this is an orphan topic. Nobody teaches. So this 40 minutes will actually make you strong in this area. So starting off, an evolution of a somatic symptom disorder, a brief history. Very, very long time ago in ancient Egypt, it was seen that many women were actually having multiple somatic problems. They were having fits, they were having stomach ache, they were having fainting spells. So people thought that, okay, it is happening more in women, so it has to do with something related to the uterus. And the uterus, the origin of the term uterus was hysterus. And the hysterus actually gave rise to the term hysteria. So therefore, from a very ancient time, this particular somatic symptom disorder as a concept was actually known, but it was known by a different name. So the term hysteria came across because, again, Hippocrates, the previous speaker, sir, also actually spoke about all the important eminent scholars in the bygone era who actually spoke a lot about psychiatry. So he was the one who coined that particular term. Then came the era wherein two parallel philosophies emerged in psychiatry with respect to the somatic syndrome. Number one, Thomas Willis. You all know the circle of Willis, right? It's the same Thomas Willis. So Thomas Willis was more of a neuroanatomist. What he did was, he said, you know what? There is a lot of development going on in the field of neuroanatomy, and also everybody, the field of medical science is expanding. He said, I am 100% sure that all of these so-called somatic symptom disorders, back then known by the name of hysteria, has some organic basis. It has to lie in the brain. Something is happening in the brain. He was absolutely convinced about it. Thomas Sydenham is a person who said, hey, come on, you cannot just keep on saying that it's happening only in females, because we see quite a lot of males who also have these kind of syndromes. So he was for the very first time convinced that we should not use this word hysteria any longer, because hysteria means a very pejorative term. It's almost as if, you're blaming the female for having a uterus, and the uterus is wandering, and therefore she's expressing these somatic symptoms. And he coined the term that the modern day, he kind of gave the impetus for the modern day somatoform disorders by explaining that it happens both in males and females. Subsequently, perhaps the first pioneer who conceptualized modern somatic syndrome disorder in the way we understand it now, at least slightly, was Brickway. That's therefore, in fact, it's one of the famous MCQs for psychiatry, isn't it? What is Brickway syndrome? Multiple somatic syndromes is also known as what? So Brickway actually, he was for the very first time a person who believed in science, and he expanded upon about 430 cases, wherein he built upon Sydenham's conceptualization, used a syndromal approach to describe these somatic constructs for the very, very first time. So he said it's a chronic condition, and later on it laid the impetus for us to understand this better. In 1800s, there was a lot of other developments that were going on. Multiple sclerosis, as we all know, presents with what? Commonly presents with what? What are the commonest presenting complaints of multiple sclerosis? Apart from the optic nerve involvement. Tingling sensations or fainting spells. And so therefore, it resembled to a large extent some of the somatic symptom disorder kind of a profile. Later on, when they actually were doing postmortem studies, they found out that there were actually a lot of plaques that they could identify. And when the preliminary evidence for organic basis of multiple sclerosis was established, people started thinking, hey, come on now. If this could be caused by white matter changes or by plaques that are there, then perhaps somatic symptom disorder also is happening because something is happening in the brain. So therefore, the neurobiological hypothesis was in a flight. So the first fundamental concept I want you to understand is, perhaps the earliest possible conceptual understanding of a somatic symptom disorder was that there is a perceived physical illness without an corresponding biomedical abnormality. So basically the diagnosis was kind of grounded on the basis that there is no medical explanation. This is what we understand it now. In fact, for a very long time, this is how we have understood it. Medically unexplained symptoms. But more on this later. Now we move to a different era and time. We can call it as the birthplace of modern psychiatry. Lot of the brightest minds in modern psychiatry were there in this place called as the Salpêtrière Hospital, Paris and France, wherein one of the guru, that is Jean-Martin Charcot, was actually demonstrating to a wonderful class of students like this, wherein all of you are so much interested in this topic. The people sitting in that particular hall in Salpêtrière were also very interested. They wanted to know, okay, tell us, sir, more about this. So he actually demonstrated on Adrienne, who subconsciously became Lucille, And he demonstrated that she was having what is called as hysteria, but Jean-Martin Charcot was convinced, although through hypnosis I am able to establish this particular change in personality between Adrienne and Lucille, he was convinced about the organic etiology of the hysteria. Now, he is not so much important for us as much as the Shishyas who were sitting in that particular room. Among the Shishyas, among the pupils, there were two of them who become very, very important to us. Number one, Peri Jane, and number two, a kind of an unknown intern who was just traversing that part of the world, sitting at the back of the auditorium in Salpetriere, called as Sigmund Schlommer Freud. Now, one reason why these two become very, very important is, Jane sitting behind and looking at all of these things said, hey, come on, this is just dissociation. There is a mind, the mind is supposed to be integrated, the mind is not integrated, the mind is splitting, and therefore an integrated mind is becoming Adrienne, is becoming Lucille. And he said this is the dissociation theory. And he said in dissociative states, physical problems can actually sort of exist only in one particular restricted domain of personality, and therefore one of the personalities could feel the pinch, the other one said I felt no pinch at all once the other personality was exhibited. So this was what Jane actually explained. Now what did Freud explain? Freud said, all that is okay, you're talking about the mind, the integrity, I also agree, I'm also a believer in dissociation, but what about the positive somatic symptoms that are happening in the individual? How do you explain that? If, for example, there is a loss of function in the body, how do you explain that? And so therefore, he said, hysteria is not just a matter of dissociation, but the origin of the hysteria is because there is something deep-rooted in the childhood that has been repressed to such an extent that for years together until they become adults, it is not expressed. And as they become adults, it is expressed on the body and not on the conscious mind. And therefore, they are the ones who are exhibiting somatic symptom disorder. So now, concept number two, very, very important. Somebody asks you, what is the difference between dissociation and conversion? Some of the old timers, you know, the expert senior faculty members, some of whom are there, can ask you to test your sort of knowledge based on that. Dissociation means there is a mental effect of a conflict, and it can be associated with domains of mental function, which means to say amnesia, fugue, personality, so on and so forth. Conversion means there are physical effects of a conflict, and it can be expressed in terms of either loss of voluntary function or loss of special senses. Got it? And with me so far, or am I going too fast? Very good. Excellent. Next, to simplify, hysteria included, actually in its original term, hysteria included the modern day dissociative disorders, somatization disorders, conversion disorders, borderline personality disorders, and even post-traumatic stress disorder, because trauma as we knew then is not the trauma as we know now. Because until then something hadn't happened. What hadn't happened? World War I and II. Because World War I and II essentially set the stage for what is called as an acute severe stress that can actually impact an adult life. Until then, trauma, everybody understood it as childhood trauma. Something bad has happened in childhood, it is expressing in adulthood. So when this particular shell shock and war neurosis was actually expressed, in especially in the World War I, then people actually started talking about classificatory systems living up to these models of illnesses, and therefore from the DSM-1, which resonated with the Jane Freud kind of a model, wherein it spoke about somatoform disorders that included everything else and it included a psychoanalytical model, DSM-2 moved towards conversion disorder and dissociative disorders as two separate kind of terms, and then it retained a psychophysiological disorders which is leading to psychosomatic conditions as one more specifier. Subsequently, you have to understand one thing. This special senses or voluntary function loss, it was very, very critical for the conversion type of hysteria, right? It had to be either voluntary function loss or a special function deficit. Whereas for the dissociative type, it had to do with either some component of a mental functions, consciousness or identity, okay? This is DSM-2. Now DSM-3 actually was an era wherein Spitzer came about and said, all that is fine. Insurance company is not paying psychiatric hospitalization bills. We need to come up with something very discrete and concrete, because transatlantic study is saying that somewhere people are called schizophrenia, somewhere people are called as bipolar disorder. So they came up with what is called as an operationalized approach, wherein they came up with a tick box for the very first time. And Spitzer, what he actually did was, based on Brickway's description, he came up for the very first time about the conceptualization of a somatization disorder, wherein there are multiple somatic complaints and people have to just fulfill that criteria. It is there in these systems, it is there for these duration. Yes, this particular person has somatization disorder. Okay? So now, the next concept I want you guys to understand is, what is the difference between somatoform and conversion? Somatoform means there is production of a symptom. In essence, it is a positive expression and it is usually polysymptomatic, whereas conversion means usually a loss of function and it is essentially a negative expression and it is usually monosymptomatic in nature. So in your emergency duties and other referrals, when you say, what is the case that you are seeing? If you say conversion, your seniors and your teachers will automatically think it is loss of function. But if it is a positive kind of an expression, then you go out with a somatoform diagnosis. Okay. Similarly, ICD always follows, due to the harmonization standards, it follows the DSM. It came up with this concept of somatoform disorders in ICD-10. It had multiple kind of separate diagnostic discrete categories under them, which went on to talk about how these criteria must be fulfilled for the diagnosis of these disorders. But conversion disorders, for the very first time, were put under a new identity of a dissociative disorders. So DSM-4 did one minor change. It said, okay, I have called everything very discreetly, but some people, for example, if I have said 4 systems must be involved for 6 months duration, some people have 3 system involvement, or some people have 5 system involvement for 5 months duration. So what do I do with these kind of patients? So DSM-4 introduced this concept of a wastebasket diagnosis of an undifferentiated somatoform disorder, wherein they are not fulfilling criteria for anything else. You come up and say it is due to the undifferentiated. This led to a problem. Almost everybody and each and everybody were not using any of the other categories at all. They were only saying undifferentiated somatoform, undifferentiated somatoform, undifferentiated somatoform. Subsequently, they realized that there are a lot of problems with this conceptualization of a somatic symptom disorder. Number one, central premise was medically unexplained symptoms, correct? So it kind of reinforced a mind-body dualism, almost as if to say that if the body physically has no problems, the mind cannot have a problem and the mind cannot influence anything on the body. Second thing is, the word somatoform itself was very difficult to be translated to other languages. If I want to explain somebody has depression, in the local language there will be some equivalent for it. But if you are to explain to a person who is suffering from somatoform disorder, you really can't, isn't it? It becomes very difficult. So then there were whole lot of overlapping categories with loosely defined criteria. Therefore, there was some change needed. And this change came for the very first time. A sort of a reconceptualization happened in DSM-5, wherein they introduced this family of disorders called as somatic symptom disorder, wherein they said, okay, you know what, something can be medically explained, but still it is a bit problematic. I'll give you an example. Let's say that somebody is having cancer and somebody is having pain because of the treatment processes that they are undergoing or because of the inherent cancer diagnosis itself. The person, the oncologist treating says, I have given maximum amount of opioids, still the pain is not coming through. At that point of time, a lot of psychiatrists for whom referrals were given were wondering, what should I actually diagnose them? Until DSM-4 it said, medical explainability was very key, isn't it? But this is medically explainable. His back pain is medically explainable. Metastasis is there. But then the oncologists are telling, no, I'm giving opioids at this range. They shouldn't be having any pain at this particular dose. Therefore, there came a very important sort of a reconceptualization in DSM-5, wherein they said it is not the medical explainability that is important, but it is the understandability that became important, very important. Therefore, we don't use the word medical unexplained symptoms anymore. They say, can I understand, given this patient profile, the diagnosis that the treatment that they're receiving is actually, they are able to still have a conscious production or an unconscious production of these symptoms lying from a somatic cause. If yes, then I might still err towards that diagnosis. If not, I can still make an additional diagnosis of a somatic symptom disorder. Very clear, very important concept. understandability. That is what DSM-5 moved towards. Then ICD-11 came up with this good family of disorders again called as bodily distress disorders. ICD-11 also did one thing because they found out that hypochondriasis is somewhat related to OC and RD. They moved it into OC and RD related disorders. So are we saying that DSM-5 is brilliant because it has done everything? No, because it is too heterogeneous, the current definition that is there, and there is a small inherent risk of mislabeling people who are actually having medical problems as having somatic symptom disorders, and that the rare chance that Sir was talking about in the last session, wherein we miss out on genuine medical causes of the patient's distress is there. And it has poor construct and predictive validity. But still, given the amount of knowledge that we have, this seems to be the best conceptualization so far. Now, these slides I'm not going to actually sort of explain in detail. This is just an examination slide. I encourage all the postgraduates to make these tables and paragraphs for all disorders, not just somatic symptom disorders, but all disorders wherein you compare each disorder, how it evolved, what is the difference between, say, DSM-5 and what is the difference between ICD, what is the difference between the earlier iterations, ICD-10 and ICD-11. All of these things are going to be very, very useful. Now, okay? Don't worry, we will pass on the slides. So the concept 5, which is very, very important, is that in somatization and dissociation, there is an inherent problem that disproving the alternate cause becomes a central premise, right? So disproving the alternate cause means if the person presents with this symptom, I need to prove that there is an organic cause for the symptom, else by default it is understood that the person is having a somatic symptom disorder. Therefore, because this particular problem is so difficult, understandability becomes the primary premise. Because you can't keep on investigating everybody. You can't keep doing all the tests that are there in the world. Maybe in a few select cases, rare cases wherein we do find evidence, yes. But otherwise you can't keep doing it. So the bodily distress syndrome in ICD-11 largely resonates well with what is the DSM-5 construct as well. It also, for the very first time, gives an option for all of these general medical disorder of somatoform group of disorders like irritable bowel syndromes, fibromyalgia, chronic fatigue syndromes, also to come under the rubric of psychiatry, rightly so, by explaining in the what are the diagnostic criteria that it is inclusive of all of these particular syndromes as well. Okay? Right. So how do you differentiate somatization or somatoform disorder or somatic symptom disorder from hypochondriasis? This is again one more very important thing. In somatic symptom disorder, often the focus of the individuals, persons who are suffering is on the symptoms. They say, I'm having headache, I'm having back pain, I'm having a lot of fatigue, do something about it. Whereas in hypochondriasis, they are concerned about the disease process. Frequently in somatic symptom disorders, they come with multiple problems. Right? Whereas in hypochondriasis, usually it's kind of an isolated problems. Somatoform disorders or the somatic symptom disorder family usually has some certain female preponderance, but actually speaking, hypochondriasis can be equally distributed in both. Very, very conceptually important point is, in somatic symptom disorders, their focus is on a wonderful cure. Right? The doctor is going to give me a wonderful cure, treat me and make my symptoms go away. Whereas in hypochondriasis, the focus is on the kind of identifying the dreadful disease. Now, there is a dreadful disease that needs to be identified. I've gone to 10 different doctors, they have not identified it. You are the 11th doctor, please identify it. So that becomes the focus. Here there is excessive healthcare utilization in somatic symptom disorder with respect to prescriptions. Whereas in hypochondriasis, it is more with respect to the investigations and less with respect to the prescriptions. Okay, so ICD-11 essentially combined all of the earlier categories because people were rarely using it. There was no particular use of having so many categories into bodily distress disorder and put body dysmorphic disorder and hypochondriasis into OC and RD related disorders. Okay, now concept number 7. When it comes to the legality, this became very, very important. We had a session on the legal process, isn't it? Until DSM-5 and ICD-11, because medically unexplained was very, very important, if you as a psychiatrist put that label, this is somatoform disorder, undifferentiated somatoform disorder, and that kind of, stuck to the patient's file, other specialities would say, no, psychiatrist has seen, seems like they don't have any organic problems and stuff like that. and that would possibly prevent them from being worked up in the detail that they have to. But now you know that it is about understandability, and now you know that in addition to that organic whatever condition that they have, they can still have a bodily distress disorder or a somatic symptom disorder. It is actually making you legally a bit immune as well, and you can freely try to help the individual. Okay? Prevalence, you all know, it is actually reported literature is between 5 to 7%, but with the caveat that in the post-COVID era, it is possibly reaching as high as around 20%, and it is 2 to 10 times more common in women, and it often has a chronic kind of a course. Indian data is generally less, but what has been found is certain parts of the society, if there is for example, there are very restrictive practices, and sometimes it tends to express in families wherein women are not given a lot of privileges to go out and have healthcare seeking kind of a behavior, then they might exhibit more of somatic symptom disorder rather than depression and anxiety. So you should always look for underlying depression and anxiety when you get this profile of patients who come with a lot of somatic symptom disorder. So tension is one of the local indigenous kind of a somatic symptom disorder that has been explained and written about in Indian literature as well. Etiopathogenesis is unknown. Like most of the things in psychiatry, etiopathogenesis is actually unknown. And there are a lot of theories that have been actually explained, and the theories range from somatosensory amplification theory, sensitization theory, autonomic dysfunction theory, so on and so forth. But this is for theoretical reasons only. There is no one conclusively established theory that works. But if you have to actually know about the underlying biology, then you should possibly learn about all of these things. This is an independent session in itself, therefore I've just barely mentioned it. So, what have been talking so far? That if in organic disorder, what happens? Like in some of the examples that Sir was talking about, there is a body that expresses an illness or a medical disorder, and that has its effect on the mind. In that case, it was a fatigue. The paraneoplastic syndrome produced the fatigue. Now, in organic disorders exacerbated by stress, there is a bidirectional kind of a relationship in which both the body and the mind are having problems. In conversion disorders, the mind is actually sort of producing symptoms in the body, and in dissociative disorders, it's not here, but in dissociative disorders, the mind is producing problems on the mind. The mind is producing problems on the mind. Whereas in somatic symptom disorders, what is called as a low threshold syndromes, you have a complex interconnectedness wherein there is a somatic symptom and there is an underlying kind of cognitive biases and experience of anxiety that leads to arousal, muscle tension, sensitization, and a chronic kind of a dysfunction that results. Okay? Now, for the last 5 minutes, wherein I'll be talking about the examiner or grand rounds approach. Suppose you get this case, what should you need to do? In the history, generally what you have to do is cover all the major systems of the human body and ask about all the symptoms that the person is having. Some of the common symptoms in each kind of in a system like pain, belching, vomiting, nausea, in the skin about itching, burning, tingling, numbness, etc., so on and so forth. Then you should ask in specific details about the somatic syndromes. For example, what was the description of the problem according to the patient? What is the frequency of the symptoms? What is the number of symptoms? What are the exacerbating factors? What are the relieving factors? How much is it impacting on the person's quality of life? What is the patient's own cognition about these particular symptoms? And then what are the cultural and other factors that are playing a role? What is the models of illness in their community? All of these things becomes important. Then you have to understand what is the patient's felt need. It is not about you cracking the case open. That is hardly the problem over here. The thing is, you have to understand where is the patient coming from. What are the number of referrals that they have taken? What are all the treatments that are tried? What are the patient's fears about the treatment and the illness? And coming to me, what is it that they are expecting? Most importantly, I think the art of helping these patients actually comes with respect to how you communicate with them. That perhaps is the bottom line when it comes to helping these individuals. You will have to, specifically if you get such patients for your examination or in your clinical rounds, elicit vulnerable personality factors and temperamental factors such as neurotic traits in childhood, alexithymia, type A personality types, or there is any susceptibility in them to become demoralized very, very soon, or having an irritable kind of a mood state, which can all predispose to the development of a somatic symptom disorder in kind of later life. Very, very important. You have to always rule out the comorbid axis 1 conditions. And it's very easy in anxiety disorder and a panic disorder. Generally, it is kind of periodic. The concern about the body is limited or circumscribed to that particular episode. In depression, you get the core symptoms of depression. You need to look for it. In psychotic disorders, where they're convinced at a delusional level about a problem with any particular body or body part and so on and so forth. And conversion disorder, we have already discussed. This is perhaps the most important slide. I will request all of you to take a photo of it, because again, you will be asked about this in the examination. In somatic symptom disorder, the subject's insight about their problem is absent, right? They are unaware of that particular problem. But the type of deception for them is again conscious, and the motivation is care or dependency. In factitious disorder, they have insight, so they are aware of the fact that they are actually producing the symptoms, but the type of deception is other deception. But here, again, the motivation is actually care or dependency, again in factitious disorder. Whereas in case of malingering, although they are aware that they are producing the symptoms, their type of deception again is other. Here there is some amount of personal benefit. Now you know the difference between these three. So if somebody asks you, okay, what is the motivation? What is the insight? What is the gain? Where is the gain? Then this particular table will help you. Okay? So concept number 9 is, there is a behaviorist school of psychological approach which says that the gains are the primary for the development and the maintenance of a somatic symptom disorder. And there is a psychoanalyst or a psychodynamic model school which says that the gains are just a byproduct. Actually, what is the underlying problem is the repressed trauma that is there from the childhood. Okay? If somebody asks you, what are the CBT models that you will take? If you say CBT, what are the psychotherapeutic models that you will take? If you say CBT, you will have to talk about the behavioral model. If you take psychodynamic, then you will have to talk about the trauma from the childhood and the repressed model. Assessments, there are a whole lot of assessments. Again, it's all there in published literature. At least remember 3 or 4 of them, and preferably one Indian kind of an assessment which is there. You can mention that in the examination. And when it comes to treatment, this is the 10th and the final concept. When it comes to treatment, very, very important. Keep in mind that there are 3 goals and there are 3 strategies. First goal is, you should prevent the person from adopting a sick role, and you have to minimize the unnecessary healthcare costs and expenses, and you should effectively treat comorbid psychiatric illnesses. And how are you going to do that? You're going to give consistent treatment, preferably help them to establish a relationship with their physician and a psychiatrist. And then you have supportive visits whenever required with the physicians, and you shift the focus from the symptoms to interpersonal problems so that you can help the individual. I said there are various therapies that are available. Some of the earliest ones were the psychiatric consultation intervention model by Smith et al. For historical interest, where he used to write referral letters, what Sir was talking about, talking to other specialities, talking to the physicians. That actually helps a lot, and these sort of practices actually helped for the patients to get better. Common cognitive errors and distortions, again it can be asked in the examination, what do you expect when you want to do CBT for such individuals? These are some of the common cognitive errors that needs to be corrected. How do you manage? Effective communication skills is essential. I will just take 2 more minutes with the chair's permission. And you have to give judicious information. Doesn't mean that when the patient comes, oh, Vango, please sit. I'll explain everything. See, Freud, Jane, okay, there is dissociation, there is all of these things, conscious, motivation, somatosensory amplification. No. You have to be very careful in how much information you share. I'm not saying withhold information, but limited to the context, extent, scope, and the rapport that you have with the patient, you should share that particular information. Overloading with information is very, very dangerous too. Okay? You have to use medicines judiciously. Lifestyle and behavioral changes are also essential. What are some of the common other techniques used for the treatment? Relaxation training and problem-solving therapy and mindfulness therapy is very, very important. But perhaps the most established form of psychotherapy is Goldberg's reattribution therapy. It all sounds very, very complicated. It really is not. Essentially, Goldberg's therapy is about first making the patient feel understood. Patient is not coming to you for, again, it's not hypochondriasis, right? So the patient is not coming to you for, tell me what's the diagnosis. They're coming to you for care. So help them feel understood. Once you make them feel understood, you broaden the agenda. Okay, let's talk about your life. How is your functioning? How is your relationships? And so on and so forth. And then you help them make the link between some of their stressors and some of the bodily symptoms through which you can then work with them in making their life better. Okay, so symptom clinic interventions, problem solving therapy, and pharmacotherapy, there is no level 1 evidence. It has to be based on what is the patient's presenting main problems, what is the nature of the problems. Although it has advantages that it is cost effective, simpler in high volume settings, sometimes you might not have the privilege of actually having a lot of psychotherapeutic sessions, but always attempt and use pharmacotherapy sparingly and depending upon what the symptoms of the individual are. It has to be pragmatic, it has to be patient centered, and the focus should be on the care rather than the treatment of symptoms alone. And please give adequate trials, start low and go slow, right? Don't be very, very aggressive like in cases of major psychiatric disorders. The options includes, first, if it is a pain syndrome, then you will judiciously use NSAIDs or paracetamol. And if you're using antidepressants, please remember that SSRIs can sometimes worsen pain syndromes. So you possibly if there is a pain syndrome associated, go for SNRIs or TCAs. And if there is sleep-related problems, you can consider mirtazapine. GI disturbances gives you a clue of using molecules like amisulpride and levosulpride, which have gut specificity. Most of your gastroenterology colleagues are using the same thing. You will find someprazole being given left, right, and center. In one of the consultation lives on call, I found a patient with end-stage renal disease being given omeprazole plus levosulpride, which has a renal metabolism. So sometimes, they might not be aware of it, but once you are aware of it, you can actually utilize it in a better way. You can use anticonvulsants and other alpha-2 delta ligands such as pregabalin or GABAergic drugs like gabapentin and anti-anxiety medications as well in a judicious manner. So through this past 40 minutes, what I have taken through is a crash course on the evolution of somatic symptom disorders, 10 concepts that should linger in your brain, and once you go back and read about it, it should become simpler. And suppose you get a case in the exam. Now you will be fairly confident that, okay, I know what to do, I know what to say, and now once you read and build upon it, your clinical practice will also become simpler. On that note, I once again thank the organizers, and I hand over the mic to the chairman.
Thank you, sir. Thank you for your excellent and comprehensive presentation. Somatic symptom disorder is a challenging area for us to learn, teach, even treat the patients. Many of the times we see the patients with functional overlay, organic with functional overlay. So thorough examination, assessment is a must, sir. And OTP is given, psychiatry is becoming less brainless, physical illness, that is medical illness, becoming less mindless. That's how our approach should be, sir. Now over to sir.
Thank you, sir. It's an excellent session. Since the chief guest has arrived, no question taken for this session. But anyway, sir will be around. You can catch in break.
Sure.
Herewith, I conclude my the session.
Thank you, sir. I request the chairperson to honor the speaker.
So, I thank the organizing committee for having me as chairperson, and I thank the organizing committee for a successful and well-organized CME.
Thank you, ma'am. Thank you. I request
you, sir.
senior
Thank you,
neurologist of Pudukkottai, Dr. Kalyan Kumar, sir, to honor the chairpersons.
Thank you, sir. Thank you so much. Thank you, sir. Thank you so much. Thank you, sir. Thank you so much.
I request
That's for the chairpersons, I think, sir.
thank you, sir. I request Professor Dr. Sivabala Nilangovan, sir, to honor senior neurologist Dr. Kalyan Kumar, sir. Thank you, sir.
Yes. Thank you.
We are going to start the final program.
I request Dr. P.P. Kannan sir, Professor of Psychiatry, Madras Medical College, Chennai, Dr. Sivaraman sir, Professor of Psychiatry, SRM Medical College, Trichy, and Dr. Nirmal sir, Professor of Psychiatry, Dhanlakshan Srinivasan Medical College, Perambalur. We welcome you, sir, to the stage. And we request Dr. Keerthana, second year PG, SRM Medical College, Trichy, for the presentation.
Good afternoon, everybody. I think we are in the last session. This sort of rich program usually overshoots time, so we have to accept that we are overshooting the time. And for the past 2 days, we have been through very good lectures, and I think definitely you would have got benefited. The last session is about mock exam. In mock exam, usually it is well prepared and verified by the department HOD and assistant professors, and here she is presenting a case scenario. So the findings and all, we have to accept it at face value. So this is a bit different from small group discussion that is happening in the ward or in your OP setting. So the verification of symptoms cannot be done, but still we can work on the line in which usually the examination is held, the university examination. Usually we focus upon 4 or 5 components. That is case presentation, that is elaborate history in a long case, short history in a short case, MSc findings, diagnostic formulation, treatment plan, and the procedures involved if you select a person for admission. So usually focus on the diagnostic formulation, individualized treatment plan, procedures. Among these, the examiners will be focusing on verification of symptoms. Especially they prefer to select catatonia because the examiners from other states, they can easily verify, for example, the derailment, formal thought disorder and all, they cannot focus on, they cannot interpret. So they prefer to go for catatonia. So that particular aspect, which is essential aspect, we cannot do here, but still the discussion sake, the presentation, the focus of discussion, all these things you can see. I just pass the mic to the co-chairpersons to say a few words.
We'll start the session, we'll have discussion. Go ahead.
Good afternoon, everybody. A 38-year-old female who's Hindu, widowed, studied BA Tamil Pandit training, who's not working currently with upper-lower socioeconomic status, referred by family members, coming from Trichy, whose mother tongue is Tamil, whose informant is mother, who's in touch with the patient for 38 years, whose information provided is adequate and reliable, and younger brother, 34 years, whose information provided is adequate and reliable. So the total duration of illness is 16 years, course episodic, mode of onset of current episode subacute, duration of the current episode 10 days. Chief complaints, patient denying complaints and reports she's very fine. Informant complaints of sleep disturbances for 10 days, complaints of excessive talking for 1 week, complaints of increased energy for 1 week. History of presenting illness. The patient, who was a known case of psychiatric illness, was apparently maintaining well with medications until 10 days ago. She was able to sleep and eat better at the correct time each day. She was able to maintain a cordial relationship with family members. Despite not very active and feeling lethargic in doing household chores, on prompting by her mother, she would do small chores at home. She used to take her tablets around 9 p.m., sleep by 10 p.m., and wake up by 7 to 8 a.m. usually. About 10 days ago, family members started noticing that she was up the entire night and barely slept for 2 or 3 hours in the early morning. The whole night she was noticed to be washing all the clothes of the family members, cleaning the house, taking hair bath, drinking coffee, and even starting to cook breakfast. She stated to the family members that she feels energetic enough to do all the tasks and not feel tired. She would then go to the bed at 3 or 4 in the morning and wake up at 7. Even though she had been up all night, she did not appear tired in the morning. It was noted that she spoke more than usual. She would discuss her past events with the family members, and she disliked having someone interrupting her. In contrast to her usual behavior of remaining silent and well-behaved, she was constantly cracking sarcastic comments about silly things that angered others around her. With an air of ambition, she would speak of her plans to launch a new business, build a luxurious home. Despite her family telling her that all such things are not possible because that requires a lot of money and difficulty in her state of health, she contradicted the fact, saying that she is much more capable. She would say that she would acquire money by resuming her teaching school children after 20 years and would become a millionaire in just a day. Despite her family telling that she doesn't have much opportunities after all these years of no experience, she would deny them and boast her skills. She would stroll around the house and invite conversation with the neighbors whom she would barely speak to otherwise. She would have long conversation with them as though she was very close to them. This was not her usual self, as she would not speak much with strangers. Even when few were hesitant to speak, she would force them to talk. She also started going to their places at odd hours of the night just to talk with them. Despite family members warning her not to speak with strangers as their household area was more prone to threat, she continued to talk with random people. Most of the times she was noticed to be happy irrespective of the given situation and told everyone that life is to be lived one and has to be lived happily. She even replied cheerfully to their questions by singing and making dance moves. Sometimes her mother would be humiliated by her behavior and would pull her home, scolding her all the way. Due to this, the patient would be enraged and behave aggressively towards her. Whenever her mother was near her, she started getting much concern over her looks. She began changing clothes almost 3 times in a day. She used to spend more time in front of the mirror trying out different hairstyles on herself. Every time she left the house, she dressed in vibrant colors. Without considering her financial status, she would even nag her mother to buy her more saris. She also occasionally began donning kurta shirts, which was completely unlikely of her. Family members assert that her excessive grooming was contrast to her usual self, as she who preferred to wear light-colored simple saris and doesn't give her appearance much thought. She had been starting but not finishing domestic duties for the past 3 days when her family members made her accomplish them. Family members noted that rapidly she shifted from one task to another without completely finishing, and also would start talking about random things in between. She was observed going to temples more frequently than normal. She would go to temple by herself, do the ceremonial of encircling it, and then head back to her house. Even more frequently than a 3 times a day, the same pattern occurred. She says that by frequently attending the temples, God will fix all of her issues, in contrast to her usual self who preferred to visit temples only once a month. She started refusing to take food and became unmanageable at home, so she was brought to the hospital. No history of increased sexual behavior, no history of increased spending of money, no history of persistent sadness of mood, decreased self-esteem, trying spells, feeling helpless, hopeless, and worthless, no history of hearing of voices and seeing images without an external stimuli, no history of thoughts being introduced into or taken away from mind against the will by external agency, no history of own thoughts being heard aloud or being known to others, no history of belief that someone is trying to harm her or talking about her, no history of recurrent intrusive own thought associated with repeated acts, no history of persistent or episodic uneasiness, worries, muscle tension, tremor, palpitation, sweating, either generalized or restricted to a particular situation, no history of suicidal attempts, no history of head injury, seizure, and fever. Treatment history. During the first episode, 1 week after the arrival of the symptoms, she was first taken to the faith healers. With no improvement in the symptoms, she was admitted in hospital and treated. Since then, she's on medications and most of the episodes are hospitalized. Last episode was on December 2023, lasted for 1 month, hospitalized and was on regular medications. She missed medications for 1 week, after which her symptoms resurfaced. Medical history. She's a known case of hypothyroidism for past 3 months under medication tablet thyroxine 100 microgram. She was not a known case of type 2 DM, systemic hypertension, CAD, epilepsy and TB. Past psychiatric history. In 2008 was the first episode, which occurred 3 months after the first childbirth, with complaints of irritability, suspiciousness, increased energy, increased talking and sleep disturbances. She was first taken to faith healers and 1 week later hospitalized and treated, which lasted for about 2 months. Similar presentation in 2009, who missed medication, restarted and not hospitalized. In 2010, there was a history of low mood, loss of interest, guilt, decreased energy, history of suicidal attempt and treatment was given. History of in 2011, sleep disturbances, increased energy, increased talking, excessive grooming, who missed medications and was again hospitalized with 1 month duration of the episode. From 2012 to 2022, the family members report that yearly she had 2 episodes and most of them were hospitalized, most of the reason being poor drug complaints. Duration of each episode lasted averagely around 2 to 3 months. No history of ECTs were given with complete inter-episodic recovery. Family history. She was born out of non-consanguineous marriage. Father, who's 60-year-old, educated up to BSc Maths, who's an esophageal cancer survivor, not working currently. Mother, who's 55 years, homemaker, who's diagnosed with bipolar affective disorder, on regular treatment. Frequent interpersonal relationship issues with her. Without much consideration of her illness, she expects the patient to do chores at home and sometimes believes she's acting. Patient is the eldest of the siblings. Younger brother, who's 34 years old, who's social worker and married with two children. He lives separately with his wife and children. He supports the patient financially. He helps the patient in taking her to the hospital and acquiring medications. Current living arrangement: patient lives with her father, mother and 2 children in the same house. Family members' attitude towards her is supportive. History of completed suicide and alcohol usage in maternal uncle. No history of seizures in any of the family members. Personal history: uneventful antenatal, full-term normal vaginal delivery, who cried immediately after birth, was immunized till date and appropriate for age milestones, with easy temperament, studied till 12 standard, 10 standard got 70%, 12 standard 60%, and studied B.Ed Tamil and did Tamil Pandit training. Occupation: after completing Tamil Pandit training, she was working as Tamil teacher in primary school before marriage for 1 year. There is no substance use history. There's nil legal history. Menstrual history: attained menarche at the age of 14 years. Regular cycle lasting for 3 to 4 days in a 30-day cycle. Sexual history: heterosexual in orientation. Attained sexual knowledge from her husband. No history of any sexual contact before marriage. No history of any high-risk sexual exposure. Marital history: married, non-consanguineous arranged marriage. Husband died 4 years back due to completed episode with history of alcohol usage. Obstetric history: obstetric score of P2L2, full-term normal vaginal delivery, has 2 female children. Elder daughter 16 years, studying 11th standard. The patient's drug intake is supervised by her and also helps her grandmother in majority of the household chores. Younger daughter, who's studying 7th standard. After death of husband, no support from husband's side, either financially or in also taking care of the children. Pre-morbid personality: predominant mood happy, attitude towards self optimistic and confident, attitude about what others relate towards her responsible and helpful, attitude towards family members cordial, whose specific hobbies or interests is cooking and singing. She was able to take decisions on her own and took up responsibilities at home. She was resilient and handled difficult situations, was religious, who had good social relations, and held fantasy life with well-adjusted pre-morbid personality. General physical examination: no pallor, clubbing, jaundice, cyanosis and lymphadenopathy.
Excuse me,
Pedal
doctor, wait a minute. So it is up to the examiner to interrupt and start raising questions in the history, or sometimes they will allow you to complete the examination. Subsequently, they will be raising questions. For audience sake, let us interrupt here so that we can raise few questions which will be very helpful to you, because this is a demonstration session. So you said about past history, multiple number of episodes. How many episodes, doctor, would you be able to tell approximately?
On an average, 16 episodes of mania and 1 episode of depression.
Okay. What was the characteristic feature of that episode of depression? What was the severity of depression involved?
From the history, since it was long back, then history I could elicit it was she was low mood, which lasted for around 1 month. She did not do any activities with decreased energy, and she even had attempted suicide of tablet overdosage, and then she was hospitalized and she was treated accordingly.
Okay. You said she had attempted once at her life, right?
Yes, sir.
Again, this brings up lot of questions attached with it.
Okay.
How many tablets she had taken, whether she had revealed or other people identified as she is found to be drowsy or sleeping extended hours, how it was noticed and how she was taken to hospital.
According to the history given by a mother, actually the patient was feeling very drowsy and she did not reveal anything. So then she was taken to the hospital. Regarding the number of medications, she did not remember.
So, how many hours after pills intake she was noticed that she was suspected to have taken medicines?
That was not very clearly given by the mother.
Okay. Any other high risk behavior she had exhibited during her manic episodes?
In this history, like she goes on and talks with strangers at house, even at the odd hours of the night. So that may be a very harmful behavior of that is noticed.
Have she ever uttered about committing suicide during manic episode?
No, history-wise, there was no. She prefers to live very happily. She expresses that she prefers to live happily.
My question was, have she?
Sir, have she? No,
that
no.
is a very closed-ended question posted to you. So you can say yes or no.
Okay.
Right. Okay. So whether any impulsive behavior did you elicit during history?
Impulsivity towards mother only, sir. She she feels that mother is restricting her freedom. So whenever she sees mother, she just goes and beat her. She talks ferociously with her. That was the impulsivity.
You said she was strolling around the house, right?
Yes.
Can you explain that in 2-3 sentences? Because sometimes most of the people, they wander out and they after 3-4 hours someone of the relative or friend will go out and bring the patient. So
This was not her usual behavior. So during the episode, she would go around her neighbor's home just to talk with them by randomly going from one house to another house. So I was meaning that she would just go to the neighbor's home at.
Okay, she visited.
Yes, visited unfamiliar persons.
Strolling is something different from what you had said.
Okay.
Any incident of she had been brought from some say 5 kilometer away or 10 kilometer away, she had moved out of house?
No, so within that itself, the family members will go and be search of her and they'll identify her.
Okay. You said 2 episodes per year.
Yes, sir.
Right. Which month this is happening?
Mostly around they say like around the December 1 episode and March 1 episode. Like they.
So mother usually school dropout, or what's the education level of mother?
Mother, sir? Mother is a school dropout. She was not formally educated.
And brother is
social
worker.
Social.
So he should be able to provide a good amount of history.
Yes.
So How will you elicit? Usually people will not be able to recollect incidents because it is spanning around, what is the duration of illness?
16 years.
16 years. Naturally, even ourselves will not be able to bring out the information. So how will you elicit a history in the past? What kind of questions you will pose to the patient to elicit a particular life event?
We can give some important occasional events like during festival
good.
times.
Right. So, yes, connecting with the children's
Children,
studies. Yes.
yeah, birthdays, anniversaries.
This is very important. So, this is all about interview techniques you adapt to elicit history. The focus of the examiner is whether you had elicited the history on your own or you collected the information from the skilled assistant. Most of the time, the skilled assistant, what do? They give the all seats. In fact, in a few institutions, they will allow you to see the cases. But anyhow, a very skilled examiner can trap you in all questions. Whatever answers you say, they can easily narrow down whether you had seen the case, effectively elicited history and all can be, they can identify. You said she was unmanageable and brought to hospital, right?
Yes.
That was a very diffuse term.
Okay.
How will you precisely say that she was unmanageable because of this behavior, which warranted bringing her to the hospital, which warranted for her to get admitted?
She started going to odd hours, talking with strangers. So that was a harm, and refusal for food intake. So and that was the
Food intake is a good indicator for it.
So, like sir, what saying is when you mean by unmanageable, whether it was because of manic symptoms, maybe disinhibition, because of food intake, you have to, it better gives an idea, and that makes our decision to decide whether we admit or not.
Okay.
We mentioned about sexual history for families. Your husband died. I didn't, probably would have missed. Did you talk about contraception?
Sir,
Contraception, family planning.
I
Was it
didn't
mentioned?
No, sir, I didn't mention.
Is it important?
Yes, sir, it is.
Why?
Because before starting on drugs, we have to rule out with UPT pregnancies.
Okay. In generally other cases, here you're right. So drugs in the reproductive age group, you have to be careful. But why else is contraception important? Any other issues?
In mania, there will be increased hypersexuality. So, sexual
Even in neurotics, people with anxiety, people with depression, we had a lot of discussion about somatoform disorders.
Yes.
The wandering uterus, stress. So that got anything to do with this?
In case of depression, there will be decreased loss of libido.
No, my concern is, then we don't talk about contraception, we talk about sexuality. So sex is fine, but contraception, yes or no?
Yes, contraceptive pills inducing.
That's there, and even not having contraception can be a stress.
Okay.
Fear of getting pregnant.
Yes.
And probably in the olden times when women didn't have a say in sexuality, whether to refuse or to accept. So even that could be in multiple abortions, female feticides. Probably that is all lesser now with the PNDT. So that is one area where the female has to bear the entire grunt of going through an abortion or so that thing is better. So family planning ensures us 2-3 problems. So you can be safe with the drugs and probably these issues can be solved.
Okay.
So in the current episode, whatever the presentation you have done in history of prosthetic illness, can you list the phenomenologies what you could elicit?
Yes. Persistently elevated cheerful mood and occasional irritability lasting for about 2 weeks. And then over familiarity, over religiosity, increased energy, and a decreased need for sleep. That's also.
What are all the usual manic symptoms which you see in other people's you could not able to elicit in this patient?
Hypersexuality, increased spending, that's also.
So you are saying there is one depressive episode you could able to elicit, the others are manic episode. If it is a first depressive episode, let us assume it is a first depressive episode. Okay. So we could not know whether this patient is going for bipolar or not. Is there any indicator that it says the presentation of depressive episode is a indicator for bipolar, something like that?
Soft signs of bipolar, like there should be a family history of mania, previous history of hypomania or manic episode, postpartum onset of depression, and increased response to antidepressants. And in bipolarity suggestively, like the patient will be having hypersomnia rather than insomnia. That's all.
So how many of those switches were there in this patient?
Peripartum, postpartum onset, family history.
Family history of people. Yeah. Yeah.
Just a sec. So, although he didn't go into details about treatment history, sir was asking earlier, maybe multiple episodes, and in an exam time, you may think when you get admitted, you have days to get the history.
Yes.
But in exam, it's only 30-40 minutes by which you have to write. But as a practicing psychiatrist, you get even lesser time.
Yes.
So, only as a PG, if you get the skills to review the records, see through it, it will be easier for you to apply when you practice. So ideally here, what all, if you had given the time, if you had the records, what all would you want to know in treatment?
Treatment history wise, like previously on what all drugs she was responding to, what the dose she was responding to, was the compliance better, and were there any side effects noted? So the treatment history has to be revised.
Most important point in treatment history?
ECTs they're
No,
given.
most important point to be elicited. ECT, of course, yes.
Yes.
Other than that, why she is relapsing?
Non-compliance was not
Yes.
compliance.
What question would you ask?
Why was the medications missed? The reason for non-drug compliance. What was the difficulty in not taking the drugs?
Okay. What symptoms is, or side effects he had experienced, that and all you can ask.
Yes.
You said the characteristics of illness, that is subacute, right, episodic, and 10 days duration. Okay. Why do you say it is subacute?
Within days, 2 weeks it started, because initially the patient had sleep disturbances. Then in a week she had the manic episode. So
When will you call it acute?
within hours to day,
Okay. When will you say abrupt?
within minutes to hours.
Okay. How it is important to know whether it is abrupt or acute or subacute or insidious? How this helps you to conceptualize the illness?
The organicity part, whether it is in case of organicity, there will be more abrupt or more sudden onset of the illness.
Like which illness?
Like substance,
Okay.
delirium.
Okay. Any organ, you said it can be a stroke, it can be a
and
complex
seizure.
partial seizure, right?
Yes.
Okay. After telling the reason for consultation, we should be able to arrive at 3-4 points. Differential diagnosis. We should have some idea before proceeding to history of present illness. In the history of presenting illness, what you focus on is the points to support each diagnosis, points against each diagnosis. So, immediately after understanding the presenting complaints, the students should be able to focus on the various differential diagnosis. Still you can keep a differential diagnosis at the end of the presentation, but still you should be able to justify why you are considering, on what priority basis you keep the first diagnosis as first. All this you should be able to explain. Okay. You can move on, doctor.
Yes. General physical examination. There was no pallor, clubbing, jaundice, cyanosis, and lymphadenopathy. Pedal edema, bilateral non-pitting pedal edema extending till calf bilaterally. No skin changes, no ulcers, no hyperpigmentation, no dilated veins were noted. BMI of 33 kg per meter square. Obesity class 1 with vitals of pulse rate 82 beats per minute, BP 110/70 mmHg, respiratory rate 20 cycles per minute, temperature afebrile, SpO2 99%. Systemic examination, CVS S1 S2 heard, no murmur, no raised JVP. RS bilateral air entry, no added sounds, abdomen soft, bowel sounds heard, examination of thyroid, no obvious swelling. CNS examination, cranial nerves were normal, motor system bulk equal on both sides of upper and lower limbs, tone normal, power 5/5 on both sides of both upper limb and lower limb, reflexes normal, sensory system normal, cerebellar system normal, and gait normal. Mental status examination, general appearance and behavior, a female who's alert, appearing to be of stated age, well built, obese, wearing sari, hair knotted, pleated well, entered the interview room and sat on the chair before requesting her so in comfortable manner. She greeted the examiner very cheerfully and started speaking even before even questioned. In between the interview itself, she requested the examiner that she is going to sing, and even before access to her permission, she started singing Kannana Kanne. She did not bother to stop singing, and even after requesting her to stop, she pursued to sing further and stopped only after the song was over. She was also noticed to be clapping during singing and also requested the examiner to do so. Despite demanding her to sit right at her place, she constantly moved around the room. She cried unstoppably in between when asked her about her husband, and returned to a cheerful mood when spoken about her singing skills. No abnormal postures or movements were noted, no hallucinatory behavior. Eye contact was made and not maintained, rapport established with difficulty, speech spontaneous, relevant, coherent, reaction time decreased, rate tone loud and volume increased, affect subjectively I'm very good, objectively elated, full range, labile and reactivity present. Thought flow, the sample for thought flow. எனக்கு டிகாக்ஷன் காஃபி நைட்டில் குடிக்க ரொம்ப பிடிக்கும். கல்யாணம் ஆன புதுசில் நானும் என் வீட்டுக்காரும் நைட் ஷோ போனோம் அலைப்பாயுதே படத்துக்கு. அலைனா கடல் தான், ரொம்ப அழகாக இருக்கும். கடலில் சாப்பிட்டேன் சுண்டல், ஆனால் கிண்டலுக்கு கவுண்டமணி செந்தில் மாதிரி வராது. செந்தில் முருகரை பழனி மலைக்கு போய் கும்பிட்டு வரணும். நான் என் தம்பி மேலே மலை போல் நம்பிக்கை வச்சுருக்கேன். யானையோட நம்பிக்கை தும்பிக்கை தான். ஸோ ஃப்ளைட் ஆஃப் ஐடியாஸ் இஸ் டிபிக்டட் ஹியர். ஃபார்ம் நோ அப்நார்மாலிட்டி டிடெக்டட். கண்டென்ட், நான் திரும்பியும் ஸ்டூடெண்ட்ஸ்க்கு பாடம் நடத்தலான்னு இருக்கேன். எங்கள் அம்மா சொல்கிறாங்க இப்போல்லாம் யார் போய் எனக்கு வருவான்னு, ஆனால் நான் ஒரு போர்டு போட்டால் போதும், வந்துட்டேன் சொல்லு, திரும்பி வந்துட்டேன்னு சொல்லுன்னு. ஒரே நாளில் 100 பேர் என் கோச்சிங் சென்டரில் சேர்ந்துருவாங்க. ஒரு ஸ்டூடெண்ட்டை இருந்து 5 லட்சம் வாங்குவேன். ஒரே நாளில் 2 கோடி சம்பாதிச்சிடுவேன். மலைக்கோட்டை பக்கத்தில் ஒரு பெரிய பங்களா வீடு பார்த்து வச்சுட்டேன். உடனே போய் குடியேறது தான். அதுக்கு பக்கத்தில் ஒரு இடம் பேசிகிட்டு இருக்கேன். அங்கே சாரதாஸ் மாதிரி ஒரு பெரிய துணிக்கடை ஆரம்பிக்க போகிறேன். இதெல்லாம் எனக்கு சர்வசாதாரணம் டாக்டர். நான் ஒரு பிஸ்னஸ் மேக்னெட்டுன்னு தெரியாமல் வீட்டில் என்னை தப்பாக பேசுகிறாங்க. கடை ஓப்பனிங்க்கு அடுத்த வாரம் வைக்க போகிறேன். கண்டிப்பாக நீங்கள் வந்து ஓப்பன் பண்ணி வைக்கணும். ஸோ கிராண்டியஸ் ஐடியாஸ், நோ பொசஷன், நோ perceptual abnormality. Higher mental functions, attention and concentration. She was when asked to do digit subtraction test, 100 minus 7, 943 minus 3 and 20 minus 1, she was unable to continue. She was able to elicit only weekdays forward. Digit forward was only be able to done and digit backward could not be done. So aroused and ill sustained. She was oriented to time, place and person. Memory, she was able to register and recall only one of the 3 objects given after 5 minutes. Recent memory, she was able to recall the 24-hour recall. And remote, she was able to tell about a school which she studied. General fund of knowledge, when asked about CM, she was able to tell Stalin, and Prime Minister, she was able to tell Modi. She was able to tell 5 states in India. Her general fund of knowledge was adequate. Arithmetic skills, she was able to do subtraction of 20 minus 3 and addition of 10 plus 15. Comprehension, she was comprehended. Abstract thinking, when asked about similarities and dissimilarities for orange and apple, she said for orange apple புளிப்பா இருக்கும் and apple இனிக்கும், and for similarities she said ரெண்டுமே எனக்கு பிடிக்கும். For dissimilarities between rose and jasmine, color வேற வேற இருக்கும். For similarities ரெண்டுமே தலையில் வைக்கணும். ப்ராவர்ப் டெஸ்டிங், when asked தான் பிடிச்ச முயலுக்கு 3 கால், அந்த முயலுக்கு 3 கால் தான் இருக்கும் போல். ஆஸ்ட் அபவுட் மின்னுவதெல்லாம் பொண்ணல்ல, இப்போ பாருங்கள் நான் வளையல் போட்டிருக்கேன், அது மின்னுறது, ஆனால் அது தங்கம் இல்லை, கவரிங் தான். அதனால கடையில் வாங்கும்போது பார்த்து வாங்குங்க, இல்லைன்னா ஏமாந்துருவீங்க. ஸோ கான்க்ரீட் திங்கிங். ஜட்ஜ்மெண்ட், பர்சனல், டிஸ்சார்ஜ் ஆகி போனக்கப்புறம் என்ன பண்ணுவீங்க, ஒரே மாதத்தில் கோடீஸ்வரியாக ஆக போகிறேன். சோஷியல் இம்பேக்ட் டெஸ்ட், வீட்டில் தீப்பத்தி எரிஞ்சால் என்ன பண்ணுவீங்க, ஃபயர் சர்வீஸ்க்கு கால் பண்ணுவேன். ஸோ டயக்னோஸ்டிக் ஃபார்முலேஷன், 38-year-old.
Wait a minute, doctor. Let us again discuss on examination findings. Based on your examination of higher mental functions, I say this individual is suffering from intellectually disabled. Would you agree with me?
Intellectual disability should not be assessed during the episode time, during the illness time.
No. How will you? Because you said digit backwards he is not able to do. She was not able to tell the meaning of proverbs.
Yes, sir. Since she was having easy distractibility, she might during the illness time, so she was not able to do the attention and concentration adequately. So
No, my question was,
yes, sir.
why not she suffering from intellectual disability? You tell the points to refute that this diagnosis cannot be considered.
Yes, sir. Her general fund of knowledge was
Usually we elicit these kind of questions at the end of the thing. As a person, it would be monotonous. I need to sustain your attention. That is why I am interrupting and asking few questions, right? So that I need to keep your attention here. Yes.
Her general fund of knowledge was normal, and simple calculations she was able to do. She was comprehended. And so on that basis, only on attention and concentration she had deficits. So
Okay, doctor, I keep the question for the last part of discussion, right? Okay, go on for diagnostic formulas.
Okay. A 38-year-old widow, graduated, not working currently, belonging to low socioeconomic status, known case of hypothyroidism with family history of bipolar affective disorder in mother, alcohol usage and completed suicide in paternal aunt, completed suicide in husband with well-adjusted premorbid personality, presented with illness duration of 16 years, episodic course with history of approximately 27 episodes of mania and 1 episode of depression with complete inter-episodic recovery, current episode with duration of about 10 days, who had missed medications for 1 week before 10 days, presented with decreased needful sleep for 10 days, elevated mood, increased psychomotor activity, talkativeness, over familiarity, over religiosity, excessive grooming and distractibility for past 7 days with significant socio-occupational dysfunction, and general physical examination revealing pedal edema, mental status examination, general appearance and behavior obese, psychomotor activity increased, affect elated, thought flow flight of ideas, content grandiose ideas, poor judgment and insight of 1/6, with biopsychosocial model, predisposing factors in biologically, her genetic vulnerability since her mother was suffering from BPAD, psychological, interpersonal relationship issues with mother, social, she belonging to upper lower socioeconomic status, in precipitating factors, she had a poor, in biologically she had poor medical adherence, psychological, death of husband and stress intolerance, in social, again interpersonal relationship issues with mother. In perpetuating factors, biological, she had a known case of hypothyroidism, psychologically poor insight, and in social, high expressed emotions in the family. Diagnosis, according to ICD-10, bipolar affective disorder, current episode mania without psychotic symptoms and hypothyroidism. ICD-11, bipolar 1, current episode manic without psychotic symptoms and hypothyroidism. DSM-5-TR, bipolar 1 disorder, current episode manic without psychotic symptoms and hypothyroidism.
a few questions. When you discussed about a lot of thought pathology and speech, but you didn't comment on them. You just described in. So what were all there?
Flight of ideas I mentioned, sir.
And then?
And grandiose ideas I
No,
mentioned.
before grandiose, from the content, what were speech and thought abnormalities which you had? Some abnormalities of speech was there.
Speech rate was increased, tone was increased, and in affect, elated affect, labile, and in
Thambi, Tumbikai, some 2-3 things which, what
yes.
would you say there?
Clang association.
So you should bring that out, no?
Yes, sure.
And there was another clang also other
Yes,
than that.
yes.
And some flight of ideas was there.
Yes, sure.
And so other than commenting, giving the, you have to describe patient's words, you have to give, stress on the psychopathology also.
Okay, sir.
And did she have grandiose ideas or delusions? How did you confirm that it's not? Because you're saying it is without psychosis.
Yes, it was grandiose ideas only. So the vectors of delusions were not fulfilled. So I labeled it as grandiose ideas.
But she was planning to start a shop. She was feeling she was going to Shri. She was so confident she will earn a crore in a day, and she asked you to open it. So probably you gave some credit to her and didn't make. So what dimension didn't she qualify there?
Sir?
No,
sir,
among the vectors of
yes, sir.
delusion,
Yes,
what
sir.
all should, you say it is a overvalued idea,
Yes, sir.
not a delusion.
Yes, sir.
So what all did she didn't qualify?
Acting out behavior was not there. She did not either acquire money and go purchase it or just talk about it to anybody. It was just there was no acting out behavior, and there was that
No,
the
in fact,
extension.
sorry to
And,
interrupt.
yes,
In fact, not doing anything and just expecting the building to come up is more appears like a delusion to me rather than it.
okay.
Okay, and then?
And the extension and pressure that it was not completely extending all throughout her life. Only at the time of the.
So we are talking about the episode alone. So we're
Yes.
not
Yes.
contradicting your diagnosis, saying it's other psychotic disorder. In MSc, what you brought out, it
Yes.
seemed like a grandiose ideas or delusions.
Okay.
Did you try confronting her? Was it fixed?
Yes, sir. Tried confronting her, sir. When she has பண்ணலாம் என்னால் பண்ண முடியுங்கிற மாதிரி தான் இருக்குது அப்படிங்கிற மாதிரி சொல்கிறாங்க.
Okay. And I might have missed. Did you mention about fundus examination?
Fundus I didn't mention, sir.
Which it is important.
Yes, sir.
In all cases.
Okay, sir.
Although she had cleared 16-year-old illness, and as a PG, you should start practicing seeing the fundus, basically the disc alone, papilledema.
Okay,
Only when
sir.
you practice, you will be able to follow it up.
Okay,
So in every
sure,
case,
Okay,
you don't need to tell it in CNS. You can even tell it in general examination.
Okay, sir.
So fundoscopy should be done.
Okay, sir.
You consider only one diagnosis, doctor.
Yes, sir.
It is good to practice to consider one more diagnosis. If I ask you to consider one more diagnosis, what other diagnosis would you consider?
Differential diagnosis.
Yeah, differential diagnosis.
Um,
It's always good to think of possibilities.
Possibilities.
In psychiatry, it is all about collecting information. Some other guy would come and add one more information that will take us to another diagnostic category.
Yes.
We should anticipate that other possibilities are existing.
Okay.
So we cannot be categorical about one diagnosis.
Okay.
So if I ask you to consider one more diagnosis,
So other differential diagnosis like anxiety disorder, since in anxiety also there can be racing of thoughts, increased activity levels. So anxiety disorder can be considered, and anxiety.
now with this presentation,
No, sir.
Right. You can-
Other,
you just
considering
try.
the
Nothing
differential
wrong.
diagnosis. And the personality disorder, borderline personality disorder can be considered. And schizoaffective, there was no psychotic symptoms, so schizoaffective can be ruled out.
Diagnosis which you said?
So,
Something to do with the medical diagnosis. Which
organic mood
so
disorder.
hypothyroidism induced mood disorders.
Substance use disorder, but she doesn't have any substance use, so substance use disorder can be ruled out.
still you can consider substance use
Okay, sir.
in all people.
Okay, sir.
She may be taking some snuff and other things.
Yes.
We do not know. Did you elicit a history related to snuff? மூக்குப்பொடி போட்டாங்களான்னு கேட்டிங்களா?
மூக்கு பொடி கேட்கல சார். வெத்தலை பாக்கு.
Benzodiazepine use.
ஓகே சார்.
Or antidepressant use.
ஓகே சார்.
Right? We can seriously consider about substance induced or drug induced. You said about grandiose ideas, which the other examiner also asked about. What is the clinching point? Which differentiates a delusion and inflated, other overvalued ideas?
False, fixed, unshakable beliefs beyond the socio-cultural background, sir.
Most important point? Yes. The fixed.
Fixed.
What is the exact word you use it?
Conviction.
Conviction. How will you elicit conviction? What questions you posted and you finally come to the point that she is only having. So I ask you to, the questions you posted to the patient to elicit this point. She is less convicted. She is more convicted to the point that, yes, that is related to history. Sir said no, she can go and open a shop, she can sell, she will become rich.
We can ask about her plan. We can confront her by giving her education status and how much experience she is having. Is that possible? Have you ever tried?
Is it confrontation is a good interview technique?
No, sir.
Suppose a patient disengages you and move away. So it is not a, but we can gently disagree and confront, provided you have a good rapport.
Yes, sir.
So you are correct, but you have to present in such a way that I disagreed, I was pointing out the discrepancy after establishing good rapport. These are all very important.
Okay, sir.
It's simply saying that confronted the patient, still she is so adamant about her point.
Okay.
This is not the way to explain it.
Okay, sir.
Okay, again, I am asking you, what other questions you posted to elicit this conviction?
Whether she had any plans regarding it, what is the financial status right now? Previously, did she have any experience of being a billionaire or being active in her educating purposes? And how long will she be able to work?
No, about delusion.
Yes.
Sir said that she may be having grandiose delusions. You said it is grandiose ideas. Points to say that it is not grandiose delusion. It is only a grandiose ideas.
Her affective response, behavior towards the delusion, her conviction, her extension and
This is
pressure.
very difficult question, I understand.
Yes.
You usually ask postgraduates, that is candidates, to demonstrate with the patients. And whenever you just escaped saying that grandiose ideas, suppose if you had said grandiose delusions, I will ask you to narrate that delusional experiences in some 20 sentences. In fact, for my pieces, I will ask them to say in 40 sentences. So it's a inner experience of someone, the conviction. So we have to focus on that false belief and conviction and how they are perceiving a particular, somebody may say, I had sat in this chair, so I am the president of France. So we have to point out the incongruent aspects of her thinking and the conviction. This is a very simple word, but you have to demonstrate it by posting questions in a gentle manner without disturbing the patient. You should you have to travel with the patient as you are. It should not be like an interview, it should be like a conversation with the patient. So this is how you have to differentiate the grandiose ideas and grandiose delusions.
Okay, sir.
Yes.
First episode we were saying it's a postpartum onset, right?
Yes.
So that time whether the patient developed could be postpartum blues or postpartum depression, postpartum psychosis, or it's a first manic episode. How to differentiate those things? How will you differentiate those things?
Within a week, postpartum blues. Within a month, postpartum depression. duration wise.
If it is a, how will you differentiate postpartum blue, postpartum depression, postpartum psychosis?
The duration.
Yes, I am saying this could be a mania psychosis, or it
Yes.
could be a postpartum psychosis which you missed. Maybe. I'm just asking. So how will you usually differentiate clinically postpartum blues, depression?
Previous episodes and the duration, postpartum, the duration blues will be within days, for depression within a month. So,
Postpartum blues, postpartum depression, postpartum depression is that.
yes.
Do we have any such exact terminology in our diagnostic formulation or diagnostic manuals?
It is not specifically included in ICD-10.
How it is given in our manual? Finally, they also
Address.
come up with an answer.
It is included in, I think, in adjustment disorder, depression. Onset, okay. Yes. Postpartum psych. Okay, sir. Okay, sir.
Coming to the point on examination of higher mental functions, I posted a question about cognitive functionings are impaired. Why not she suffering from a mental retardation, that is an intellectual disability?
But previously she has studied till BA Tamil. She has been teaching children for 1 year.
Okay.
So,
That's a good point. But you have to say that
Yes,
the
sir.
deficit should have started during
the childhood.
developmental period.
Okay, sir.
And it has been there since birth, not the correct way of telling it,
Okay.
since from early childhood.
Okay, sir.
Scholastic backwardness should be there, there should be impairment in adaptive functions. So you have to say all these things to say that this is she is not having intellectual disability.
Okay, sir.
Right? And it's you are saying that she is suffering from mood disorder, right?
Yes, sir.
What is the core in mood disorder? Which is, among the all findings, which point need to be focused on?
Persistent and pervasive elevation of the mood.
Yes.
And bipolarity with complete interepisodic recovery.
Okay. Then what are the points you will elicit as you focus on mood? There are 4 or 5 points, no? You had also mentioned that.
Mood, okay. About whether it was labile, reactivity, mood congruent or incongruent, the quality of the affect,
You had to jumble the
communicability, sorry.
things. Right. Then appropriateness. That's said about whether it is infectious or
Communicability, yes.
lot of textbooks not mentioning about the infectiousness, but still you can add a point because
Okay.
they crack jokes and make you laugh, right? So whenever we present a mood disorder, the description of the mood should be very perfect. Most of the time PGs miss that. They are correct, but we want you to justify when we ask you questions.
Okay.
Right? You should be able to focus on all the points related to mood examination. How will you differentiate the speech and thought? Sometimes people mix the findings. During speech examination, speech components there, no? Thought components are there, no? How will you differentiate the components in thought and speech?
Speech sample can be by giving a random topic. We can elicit a speech sample and asking interviewing itself whether it was spontaneous. The questions are
It
asked.
is about physical determinants. That is, physical quality of speech is focused in examination of speech,
Okay.
right? Quantum, tone, rate, right? Relevant, coherent, reaction time. These are all related to that physical aspects of speech. Whereas when you go to thought, it is a thought, content,
Okay.
possession, right?
Yes.
Stream.
Yes.
Do you have any other
That's
slide?
That's all, sir.
That's the.
Yes.
So how will you manage the patient?
Yes, sir. First, acute management. Focus the inpatient or outpatient. So for this patient, I'll be considering inpatient admission, and modus of the treatment. The pharmacological and non-pharmacological aspects should be
Okay,
attained.
doctor. I
Yes.
will not be focusing on pharmacological or non-pharmacological.
Yes.
I will focus on here. You said the individual requires inpatient setting.
Yes.
So there should be indication for admitting the patient.
Yes.
Then comes whether it is
Uh,
voluntary or
involuntary.
that is supported admission or
Uh,
independent
independent
admission.
admission.
So you have to address these points
Okay.
because since morning we have been discussing about legal issues related to psychiatry practice. So what is the indication for admission here?
Patient had refusal to take food. He had high risk behavior.
What
So,
high risk behavior?
She was going at odd hours in the night,
Okay.
talking with strangers. Oh,
Whether she assaulted her mother?
assaultation of the mother.
These are all points we have to give emphasis as we present the case during history of person illness. Okay, so you decided to admit her. Whether she had given consent to you?
No, so her insight was 1/6.
Whether
She
insight
denied.
and consent has connections?
Yes, sir. No, sir.
Yes
When
sir
on.
or no sir? You have to come up with only one point.
No, sir.
No.
No.
Okay. So there need not be a connection between consent and insight. Sometimes patient may lack insight, but still they may give consent. Right. So the patient had not given consent. What would you do? What procedure would you use? Not many students may not be aware of it, but for discussion sake, I am talking all these things. Yes.
Involuntary admission under Section 89.
You invoke Section 89. See, you are suffering from illness, go into the ward. The police inspector சொல்லுவார்ல, go into the jail. So what you need to do? You arrived at a diagnosis.
What do you decide to invoke the session? That's what sir is asking.
No, even before invoking the session, there are some procedures. Being a psychiatrist, you talk to the patient,
Yes,
explain
explain
the
about
diagnosis,
the-
or you say we need more time to evaluate. Probably inpatient setting, we can do some investigation and other things. If you are all right with the blood investigation, we will send you tomorrow itself. You just give them hope. Explain that she need admission. Right? You need not say that you had assaulted your mother, so I am admitting you. That is not correct way of doing things.
Okay, sir.
Right?
Yes.
So what would you do? You want to invoke, that is called sectioning in UK.
Yes.
But it is not widely practiced in Tamil Nadu or even India. In India, even North India, the practicing psychiatrists talk about repealing the act. So the awareness about the act and going with the act are very less in our psychiatric community. We cannot repeal the act. This is a very challenging one. But how to handle the law, how to interpret, how to form consensus among ourselves, how to establish procedures and rules, regulations as per law. That is the question we need to address. Yes, in your case, before invoking that section 89, explain to the patient, ask for her consent. If she is not able to provide consent, you have to do?
Capacity.
Yes, exactly. Be louder, doctor. Capacity assessment, right. Even for voluntary admissions, it is expected that you should do capacity assessment and document it. Then only the consent provided by the patient was valid. But unfortunately, we don't do it. We are supposed to practice all these things. Okay. In capacity assessment, what are the points you need to focus? What are the points? Because she is a second year PG, we need to accept that she had come up, bravely she had presented to face 3 examiners, right? So this is for final year PGs sitting in the forum. Anyone can tell what are the points we will be focusing? Any one of you? PGs. See, this should be like a discussion, no? It is not that we speaking to you. Comprehension, very good. Next point. Understanding the consequences. Third. Yes? You want mic? Mic இருந்தாதான் பேச்சு வருமா? Decision making or judgment? Decision making. Is it correct? Comprehension, understanding, both are same point. Second, making decisions. Third, communicating either verbally or non-verbal cues. Right? Is it okay? Comprehension, making decision, communication. Then task specific. இந்த மாதிரி அட்மிஷன் பண்ணுறோம், உங்களுக்கு நோய் இருக்குன்னு சொன்னால் நோய்ங்கிற வார்த்தை கொஞ்சம் ஸ்டிக்மா இருக்கும். மேபி யூ கேன் சே உடம்பு சரியில்லை, we need to evaluate you. Time specific, எந்த டைம் you have to note. All of you had gone through that capacity assessment document of Niemann's. The fourth point gives discretion to the clinician, where you have to make your own judgment about patient's judgment. Let's go back to the slide where you discussed about judgment, no?
Yes.
In hypomania, we will not be having findings. Most of the time, the individual will be speaking to you in an inflated manner, expressing high self-esteem. We will not have any findings at all. Then how will you? The judgment component of higher mental functions helps you to invoke 89. Going to the judgment. Yes. This is very important point, especially in mania, hypomania. Now you pass on your judgment about patient's judgmental ability in accepting treatment, accepting admission. Second is accepting treatment. So admission is different, treatment is different. So these are all important points we need to be aware of before admitting this patient.
Okay, sir.
மெனி டைம்ஸ் சார் கொஞ்சம் பிபி கூட இருக்குது, ஒரு மாதிரி இருக்கீங்க, 2 நாளாக தூங்கலைங்கிறாங்க, வீட்டில் பண்ண பிரச்சனைனால உங்களுக்கு தூக்கம் வரல. ஸோ தீஸ் கைண்ட் ஆஃப் திங்ஸ் சம் பேஷண்ட்ஸ் I mean, even though they would lack capacity, but they still give consent. So அதில் வச்சு you can try those things. And okay. Generally, our country we are able to use coercive measures more freely. Our Mental Health Care Act gives more provisions. Whereas in Europe and all, most countries it's very difficult to even prescribe some medicines. If the patient says, okay, I've got mania, but fine doctor, I'll see you later. Fine doctors, but fine doc. வேறு இடத்துல யூஎஸில் அப்படி தான் சொல்லுவாங்க. ஸோ அது மாதிரி இருந்தால் we have to leave. So sometimes you can use least amount of coercive methods. Kind of நம்ம கெமிக்கல் ஒரு பேசி பண்ணுறது, verbal de-escalation. So all those kind of things can be attempted. And maybe you can give oral medications or something saying that you'll relax for a short while, and then if not, going for the capacity assessment and decision.
What are all the factors you feel in this patient important for before planning for a management? What are all the things you feel these are the things need to be addressed in the management?
Management, initially her drug compliance has been poor history wise, so the reason for the drug compliance, and that has to be addressed first. Then her physical comorbidity, hypothyroidism, and she is also noted to have pedal edema, so that has to be assessed. And social stresses regarding her family, her interpersonal relationship issues with mother has to be addressed.
With all these factors, what will be your management plan? Suppose you doesn't have any treatment history with the patient and you need to treat the patient. So what will be your line of management in this case?
After inpatient admission, then I'll have to do a baseline rating scales have to be put, and baseline investigations such as CBC, RFT, LFT, TFT, serum electrolytes, urine routine, ECG has to be done. Then after that, pharmacological in aspect, I'll ask the patient to bring the old records if she's having it. Then I have to revise the treatment history. And regarding her comorbid conditions, then I'll start on any antimanic drug.
So, will you, what medicine you will start?
Yeah, either an antipsychotic or a mood stabilizer I'll start.
What you will use, doctor?
So considering in this case, first I'll have to assess the old records if it is available.
It's not available.
If it is not available, then I'll have to wait for the investigations because she's already having pedal edema, and I have to check the hypothyroidism status. So after consideration, so for the initial acute
For
management.
that patient will be having irritability, violent, all these things will be there.
Yes, sir. For that acute management, I'll start on an atypical antipsychotic along with benzodiazepines.
Will you give lithium for this patient?
Lithium can be an option for this patient.
Anything goes against starting lithium in this patient?
It's a hypothyroidism and also pedal edema. So that the consideration should be done regarding it.
You are saying you will be using a baseline rating scale. What baseline rating scale you will use? Any name for it?
Young Mania rating scale.
I think sir was asking about lithium discontinuation syndrome. People with lithium,
yes,
there's a concept that when they discontinue, the chances of developing episodes are more. So sometimes if compliance is a doubt, you'll have to be a little bit cautious about using lithium.
Okay.
Will you consider any long-acting injections here?
Yes, sir.
Because so much of non-compliance. And acute management ECT is different, but probably that's why we were. You try to put these things in a biopsychosocial grid of protective and preventive factors. If you put in a grid, it helps you in identifying, and probably seems we used to call it as a problem list. Anybody comes even in medicine department, they'll have a list of symptoms. There may not be medical problems. Some angry with the sister. So something like that. So there will be a problem list, and for each problem list, they'll come up with the investigation plan, treatment plan, so which will be there till the end of the discharge. So even in medicine department, they used to do. So if you have a list of all these factors, put it in a grid, which probably we told in the last minute you couldn't do it. If you put it in the grid, it's easier for you to follow it up in therapy also.
Okay.
Would you, again, coming back to that admission procedure, right? We all need to be sensitized, no? Right. So, would you admit her on your own?
No, sir.
Then, what else you need? You invoked 89.
Yes.
Would you? Yes. One more psychiatrist or one more mental health professional's signature independently should have examined. It should be in a separate case sheet. See, it should not be a continuation of case sheets. It should be a different paper. Then what else? Two professionals, mental health professionals. One is psychiatrist. Another one can be a allied health professional like psychiatric nurse, clinical psychologist, or psychiatric social worker. Or it can be another psychiatrist too. So, you made a decision. Both of you concur that she needs inpatient service. You decided to invoke. 144 invoke பண்றாங்கல அது மாதிரி. These are all something which we are not very familiar with. So, it's not about invoking, sectioning-ங்கறாங்க. We have to use gentle words as we deal with the patients. Yes. You have to inform the district mental health review board that there is a mail ID. What you need to do is you need not make a call and inform them. There is a mail ID with each mental health review board. You send a mail, take the Xerox copy of that mail and keep it in the case sheet. Then every 3 days you continue to do assessment of capacity, the NIMS capacity assessment document. All of you should be knowing by this time capacity assessment document. You do it every 3 days. Once he attains capacity, you can transfer to, yes? Yes, doctor? Independent admission under? 86. Then she discussed about discharging the patient. Discharge comes under 88. And the responsibilities of the psychiatrist, she got discharged. Her responsibilities are dissolved immediately. She continued to care the patient till she meets another psychiatrist. That is section 98. 88, 98 are about discharge procedures. We need to be aware of all these things, intricacies involved. We are all working in a private institution or government institution where lower strata people are coming. As you go out, as you deal with rich people, educated people, you will go through a lot of difficulties. As you cannot simply say that you are detained. That's all. So you have to work meticulously considering the law provisions. About coming to the point, what are is it medicine alone, or would you have any other thing in your treatment ornament? To provide a comprehensive care.
Psychoeducation.
Psychoeducation, then?
Psychoeducation, family therapy, interpersonal therapy should be.
Family therapy, interpersonal therapy. Then I will be asking what is family therapy, what is interpersonal therapy. So we need to be aware of 2-3 sentences about these therapies when we utter it to examiner. Examiner would be more interested in knowing whether you know about all these things. Right? What is education? What is psychoeducation?
Psychoeducation is explaining the patient about the illness, about his relapse, how drug is necessary, how a drug helps in.
Okay, it is about well-being, ill-being, where well-being patient had moved from well-being to ill-being. That is about psychoeducation. That is psychological functioning. Educate the individual about psychological functioning. Right?
Yes.
Then what is the social therapy you will provide to this individual? If you stop with the medicines alone, then we are not a psychiatrist. We become a physician. Only when you talk about psychological therapy, social therapies, we get qualified as a psychiatrist. So what social therapy would you provide here?
Interpersonal social rhythm therapy, family
Interpersonal
social rhythm therapy.
Social rhythm therapy. Then again, this brings in complexity in our examination processes. Social therapy is placing the individual in various places, helping her to get a setting, shifting the house or getting employment or supporting her in employment. All these things need to be talked about. We need to talk about social recovery, occupational recovery and other aspects. She was previously working as a teacher,
yes,
right?
Yes.
We should talk about how she can get a job back. That is about social therapy. Social therapy is assisted living, assisted employment. It is more of a job of social worker. Even then, we should be having capacity to oversee how the social worker are functioning and how the psychologists are functioning. We should have that capacity to oversee. For that, we need to be aware of something about all these therapies. Especially the social recovery and occupational recovery need to be focused upon. Even though it is not our domain to execute all these things, psychiatry when practiced with a system, for example, she is from a medical college department where social worker is available, we have to assign a task to the social worker. This is social therapy and psychological therapy.
Okay, sir.
Then after that, most important point is relapse prevention. She had gone through so many relapses. You have to work out a strategy because she is refusing medicine after some point. You have to focus on her. What triggers? What makes her? You said pedal edema. What is the other reason? What is the possible reason for pedal edema in her? Is it hypothyroidism alone or something else can be?
Can be drug induced.
Like
divalproex or sodium valproate, lithium, olanzapine can cause pedal edema. Risperidone.
Yes, good. So the pedal edema may be a reason. So did you mention weight?
Yes, sir.
BMI. What is the weight?
31 BMI kg per meter square.
What is the weight?
Weight was around 90 kg, sir.
90 kg. did you discuss anything to address this obesity with her? Did you made a point about discussing about obesity, weight gain and treatment?
Regarding the treatment, I didn't mention.
We need to include that. Addressing the obesity also should be part of our treatment plan, or else again she will discontinue. How will you address her? Next question would be like, how will you address her? Sodium valproate, weight gaining, olanzapine, weight gaining. Every medicine in the psychiatry is lead to weight gain, right?
Weight gain, yes.
My statement is correct? If you agree with
No.
me, again the question would be like,
No.
all medicines would lead to weight gain?
No, sir.
No. What are the medicines will not lead to weight gain and help her to maintain remission?
Like risperidone.
Risperidone.
What's it called? Aripiprazole.
Aripiprazole, then? Mood stabilizer. All antiepileptics are related to mood stabilizing effect.
Lamotrigine,
Now I had given you carbamazepine, then so this is how the questions should be posted. Even if she say carbamazepine, then I will go to side effects of carbamazepine. What is the long-term side effects of carbamazepine? Steven-Johnson syndrome. Long-term administration, doctor. So she is going to be on mood stabilizer for few weeks or few years or many years with so many episodes. What would be your guide? Sir, நான் எவ்வளவு நாள் சாப்பிடணும்னு கேட்பாங்க. What would be your answer to the patient?
According to the guidelines, if there's one episode, at least for 1 year, it should be taken. If multiple episodes with severe hospitalization, then lifelong medications has to be taken.
No, it is not good to use lifelong. Yes. You say for some long term, for prolonged period. Never say lifelong. Right? That is not the good term to use. கொஞ்ச நாள்னா சில ஆண்டுகளுக்கு அப்புறம் கேட்பாங்க சில ஆண்டுகள் நீங்க அப்புறம் மறுபடியும் we have to extend it. ஆமா அது பண்ணிக்கிட்டே இருக்கணும். So we give you a positive projections to her. See, she is suffering from illness for a mistake she had not done. That is a nature's expression, right? We should be very supportive to her. திமிரா பண்றாங்க அப்படின்னு வெளியில சொல்லலாம், but we should be aware that she is suffering from an illness for which she had not done anything. So we should be very positive and help her to look at the treatment very positively. So the word you use and all very important. We will be focusing on how you are communicating with the patient. It is not the answer whether would you select lithium or yes, that is one component. The clinical examination is more about your skill sets. Usually I would be asking the individual to interview, discuss with the patient about treatment prognosis, or how will you address the side effects he had experienced in the past with the patient. I will ask the candidate to go and discuss with the patient for 2-3 minutes. So because the examination is meant for assessing your skill sets, not your knowledge. For knowledge we have theory paper. So hope you get benefited with this discussion, right? We can have a discussion. Those times when I was doing PG, the examiner went up to 11 PM onwards. There was an intense competition between the examiners to showcase their knowledge level. See, that and all not correct. We should ask very fundamental things related to admission and other things. We are not looking for nick of that knowledge in psychiatry. For that there is a medal exam. See, what is the what are the diagnoses you consider? What is the indication for admission? What is the indication for this particular medicine? How you select the medicines, right? How you prognosticate? What are the risk involved? I talked about the psychological intervention, social intervention. These aspects and all would be focused on. So I think you had some points to learn from this session. Probably there is no end to this, because any examiner can take any route. Somebody may be very focusing on suicide alone. I had sat as a co-examiner. The one examiner was discussing about suicide with that candidate for 1 hour. Then the time overshoot and we all had a lunch by 4 o'clock. Then we all left by 7 o'clock. Then they reduced the time spent for oral examination, viva. So these are all things that will happen usually in examinations. They will be very focusing during your long case presentation. Short case presentation, they will be focusing only on the examination findings. So wish you all the best. You do well in your examinations, right? Thank you for staying with us till 4:15, right? Thank you. Thanks for the organizers for giving us the opportunity to help you to understand psychiatry.
And good presentation, doctor.
Thank you, sir. Thank you.
Thank you, sir. Thank you for a thorough examination. I believe the postgraduates must have benefited a lot. I now request the examiners to give the memento to the case presenter.
We would like to thank the organizing team
Thank you,
for
sir.
giving us opportunity to
Thank
have
you,
this.
sir.
Thank you.
I request the. I request our organizing co-chairperson, Dr. Jaising sir, to honor the examiners. To honor the examiners, Dr. P.P. Kannan sir. And Dr. Nirmal sir. I request our organizing secretary, I request our organizing secretary to honor Dr. Sivaraman sir. Dr. Kirtana. Dr. Kirtana. We'll now felicitate our TNIPS members and the organizing team and the sponsors. I request the quiz masters.
ஒரு 10 minutes இருங்களேன். Few more minutes. ஆர்கனைசிங் டீம் அவங்க ஸ்டேட் ஆஃபீஸ் பேரஸ் ஒரு 10 நிமிஷம் தான். ஜஸ்ட் ஷீல்டு கொடுக்குறது தான். ப்ளீஸ் வெயிட். வாங்க.
On behalf of the PDPA, we are presenting a cash prize to the case presenter, Dr. Kirtana. I request our IPS president to present it to her. The prize is sponsored by our PDPA president and organizing chairman, Dr. Zaman sir. I request Dr. Aruna and Dr. Ramya Rachel, the quiz masters, to receive their honors. I request our organizing chairman,
On behalf of Indian Psychiatric Society Tamil Nadu chapter, we are honoring the organizing chairman, Dr. Jaman sir. On behalf of Indian Psychiatric Tamil Nadu chapter, we are honoring the organizing secretary, Dr. Karthik Devanayagam.
I request our organizing chairman to felicitate our TNIPS president, Paneer Selvam sir. I request our organizing co-chairperson, Jai Singh sir, to present a memento to the TNIPS Vice President, Sabrin sir, TNIPS Secretary, Siva Ilango sir, and TNIPS Treasurer, Siva Sailam sir.
I request our TNIPS President sir to honor our PDPA organizing co-chairman Dr. Jai Singh sir. I request our TNIPS President sir to honor our PDPA Secretary Dr. Karthik Devanayagam sir. Okay. Treasurer Dr. Sophia ma'am. I humbly request our President to honor our PDPA Joint Secretary Dr. Jeevitha ma'am.
Dr. Jeevitha, she has contributed a lot in coordinating with the postgraduates and all. My personal thanks to Dr. Jeevitha as an organizing secretary. Thank you.
Next, I am request our President sir to honor our PDPA Joint Treasurer Dr. V. Ahalya ma'am.
Dr. Ahalya, even though she is in a treasurer post, அவங்களும் PGs ஓட coordinate பண்ணதெல்லாம் பண்ணாங்க. Thank you, Dr. Ahalya.
I request our President sir to honor our PDPA Academic Coordinator Dr. A. Mala Selvarani ma'am.
Special thanks to Dr. Mala Selvarani. ஏன்னா செக்ரட்டரி பார்த்த வேலையில் பாதி வேலையை அவங்க தான் பார்ப்பாங்க. ஸோ ஓகே, தேங்க்யூ டாக்டர் மாலா. ஆமாம், பெட்டர் ஹாஃப். ஆமாம், எந்த வேலையை நான் கொடுத்தாலும் பார்த்து தான் ஆகணுங்க. ஸோ
I request,
yes, அடுத்து யாருப்பா?
I request the pharma members to come and Sun Pharma.
இதுப்பா எஸ், அது முடிச்சிடலாம். இந்த எஸ் முன்னாடி வாங்க, எல்லாரும் வாங்க முன்னாடி.
I request the following organizing team members to come and collect your awards. Mr. Balamurugan.
ஓகே டாக்டர், நான் கூப்பிட்றவங்க வாங்க. முருகானந்தம் ப்ளீஸ் வாங்க. முருகானந்தம் அவர் டிஎம்ஹெச்பி சோஷியல் ஒர்க்கர். இங்கே இருக்க டீம் எல்லாருமே இஃப் யூஆர் ஏபிள் டு ஒரு டிஎம்ஹெச்பி டீம் வந்து ஒரு பிஜிசிஎம்ஏ நடத்துறதுங்கிறது ரொம்ப டஃப் ஜாப். அதை வந்து மிக சிறப்பாக பண்ணது வந்து இந்த டீம்னால தான். நாங்கள்லாம் வெளியில் தெரிகிற ஃபேஸஸ். மை அப்ரிசியேஷன்ஸ் டு ப்ளீஸ் கிளாப். மை அப்ரிசியேஷன் டு முருகானந்தம் அவர் சோஷியல் ஒர்க்கர். தேங்க்யூ. நெக்ஸ்ட் ஐ ரிக்வெஸ்ட் Balamurugan, our senior psychologist here. He is with me for the past 5 years, including DMHP and ECRC. நேற்று குத்தாட்டம் போட்டிருப்பார், டான்ஸ் எல்லாம் பாட்டுக்கு தந்தாப்புல ஒரு டான்ஸ் ஆனது அவர் தான் நினைக்கிறேன். வாழ்த்துக்கள் பாலா. நெக்ஸ்ட் சதீஷ்குமார். மை அப்ரிசியேஷன் டு சதீஷ்குமார். அவர் இந்த மீடியாவிலெல்லாம் தொடர்பு நல்லா வச்சுருப்பார் சார். தேங்க்யூ சதீஷ். நெக்ஸ்ட் கனகராஜ். இசிஆர்சி பேஷண்ட்ஸ் ரீயூனியன் எல்லாம் அழகாக ஹேண்டில் பண்ணுவார். நாங்கள் யார் சொன்னாலும் கேட்காட்டியும் அவர் சொல்கிறத பேஷண்ட்ஸ் கேட்பாங்க. இந்த ப்ரோக்ராமுக்கு ஃபார் த பாஸ்ட் 1 month கம்ப்ளீட்டாக ஒர்க் பண்ணிட்டு இருந்தார். ட்ராவல் எல்லாம் அவர் தான் பார்த்துக்கிட்டாரு. தேங்க்யூ கனகராஜ். தமிம் வந்து ரொம்ப சைலண்ட் ஒர்க்கர். நம்ம ஷீல்டு ரெடி பண்ணுறது இந்த மாதிரி விஷயங்களெல்லாம் அவர் தான் கோஆப்ரேட் பண்ணார், ஹெல்ப் பண்ணார். தேங்க்யூ தமிம். கார்த்திகா வந்து நர்சிங் முடிச்சிருக்காங்க, நம்ம டிஎம்ஹெச்பி டீம் மெம்பர். இங்கே ஈவெண்ட் மேனேஜ்மெண்ட்டில் ஃபுல்லாக கோஆர்டினேட் பண்ணது 3 பேர், அதில் ஒருத்தவங்க இவங்க. தேங்க்யூ கார்த்திகா. ஜென்சி விமா, அவர் ஸ்டாஃப் நர்ஸ். அவங்க அவேர்னஸ் கொடுக்குறதுலாம் ஒரு டிவியில் பேட்டி கொடுக்குறதா இருக்கட்டும், ப்ரோக்ராம் அரேஞ்ச்மெண்ட்டாக இருக்கட்டும், எல்லாமே நல்லா பண்ணுவாங்க. தேங்க்யூ ஜென்சி. ஓகே. யாழிசை சைக்காலஜிஸ்ட், ஒரு இம்பார்ட்டன்ட் டீம் மெம்பர். இந்த ப்ரோக்ராம் கோஆர்டினேஷனில் ஜீவிதாவோட இருந்து, டாக்டர் ஜீவிதாவோட இருந்து ஷி ஒர்க் டே லாட். தேங்க்யூ. ஒரு கிளாப் பண்ணுங்கப்பா. எஸ். ஓகே. ஹரிஹரன் வந்து என்னுடைய செக்ரட்டரி, வெல்விஷர், எல்லாமே எதை சொன்னாலுமே செஞ்சுருவாப்பில். இந்த ப்ரோக்ராமுக்காக 1 month வேலை பார்த்துட்ருக்காரு. தேங்க்யூ ஹரி. Pharma. I request our pharma members please come forward.
Sun Pharma. Sun Pharma.
Okay. I thank
the members of Sun Pharma. We thank you.
நீங்க நேம் சொல்லுங்க.
Propel Pharma.
இல்ல ஒவ்வொருத்தர் ஒரு பேர் சொல்லுங்க, நான் அப்புறம்.
Sun Pharma members.
I thank our Sun Pharma for making this program a grand success from the beginning. I request our president to give the memento for our ஜோதி பஸ் சார், அப்புறம் இவர் எல்லாருமே இருந்து நல்லா பண்ணாங்க. தேங்க்யூ ஃபார் த கோஆர்டினேஷன், எஸ்பெஷலி டிரான்ஸ்போர்ட் அந்த விஷயங்கள்லாம் பார்த்துக்கிட்டாங்க, கிளிச்சஸ் இல்லாமல் பார்த்துக்கிட்டாங்க. தேங்க்யூ. நீ யார் வரணுமா?
ப்ரொபெல் ஹெல்த் கேர்.
வாங்க டீம் மெம்பர்ஸ் வாங்க. எஸ் பாலா வேலப்பன் சார் எங்க இருக்காங்களா? இப்போ முன்னாடி வந்துருங்க. வாங்க சார், வாங்க. பஷீர் இப்படி வாங்க, உட்காருங்க, டக்குன்னு பார்க்கலாம். ஓகே.
Members of the Propel Healthcare.
ஓகே. ப்ரொப்பல் நம்ம நேற்று உட்காருங்க, இப்படி உட்காந்துருங்க, ஃப்ரீ அப்படி உட்காந்துக்கோங்க. நேற்று வந்து டின்னர் அரேஞ்ச் பண்ணியிருந்தாங்க ப்ரொப்பல் ஃபார்மா. ஸோ தே ஹவ் ஹாஸ்பிட்டாலிட்டி அண்ட் அரேஞ்ச்மெண்ட்ஸ் ஆர் ஸோ குட். எல்லோரும் என்ஜாய் பண்ணியிருப்பீங்க. தேங்க்யூ.
Members of East West Pharma, I request you to come and collect your.
ஈஸ்ட் வெஸ்ட் வேறு யாரும் இருக்காங்களா? ஓகே. ஐ தேங்க் அவர் ஈஸ்ட் வெஸ்ட் ஃபார்மா. பன்னீர்செல்வம் சார் சொன்னோன்னே தே ஹவ் அரேஞ்ச்டு ஸோ மெனி திங்ஸ். தேங்க்யூ. தேங்க்யூ ஸோ மச்.
Members of Intas Pharma.
Our appreciations to Intas Pharma for the support.
I now request members of Torrent Pharma to come and collect their honors.
Torrent Pharma from the beginning the certification இது எல்லாத்துலேயும் they have coordinated well. Certificatesலாம் glitches இல்லாமல் பண்ணதுக்கு ரொம்ப தேங்க்யூ.
Members of Linux Laboratories, please come forward.
Thank you Linux.
Pills India.
Pills India அவங்க அந்த அவருடைய சிரிப்புக்காகவே நான் ஓகே சொன்னேன். வெரி நைஸ், தேங்க்யூ.
மிஸ்டர் ராமகிருஷ்ணன்.
ரொம்ப இது இல்லை, இது லயா ராமகிருஷ்ணன்.
லயா லைஃப் சயின்சஸ். Mr. Bashir from Star Creativity.
Hari. ஒரு நிமிஷம். ஓகே, ஃபார்மை முடிஞ்சிச்சா? அடுத்து ராமகிருஷ்ணனா, லிஸ்ட்டை கொடுங்க, நான் பேசுகிறேன்.
மிஸ்டர் ராமகிருஷ்ணன்.
பஷீர், ஸ்டார் கிரியேட்டிவிட்டி. நம்ம இந்த ஃப்ளெக்ஸ் ஒர்க்கு, இந்த டிஜிட்டல் இன்விடேஷன், இது எல்லாமே பண்ணது அவர் தான். கிளாப் ப்ளீஸ். வெளியில் இந்த ப்ரோக்ராம் வெளில போயிருக்குன்னா அதுக்காக பஷீரோட ஹார்ட் ஒர்க் உண்டு. என்னோட தேவையை ஒட்டி அவர் ரொம்ப வேலை வாங்கியிருக்கேன். ஹி ஹஸ் டன் இட் வெல். தேங்க்யூ.
மிஸ்டர் ராமகிருஷ்ணன்.
ராமகிருஷ்ணன் வந்து பர்சனல் ஃப்ரெண்டு. இந்த ப்ரோக்ராமை வந்து கம்ப்ளீட்டாக கோஆர்டினேட் பண்ணி கொடுத்தாரு. ராமகிருஷ்ணன் சார் சொல்கிற எல்லா ஒர்க்கையும் கோஆர்டினேட் பண்ணார். சாரி, நம்ம பிரசிடென்ட் சார் பன்னீர்செல்வம் சார். ஸோ ஐ தேங்க் ராமகிருஷ்ணன் ஃபார் ஹிஸ் எஃபர்ட். தேங்க்யூ. தேங்க்யூப்பா.
மேனேஜர் ஆஃப் ஹோட்டல் எம்ஏ
நம்ம என்னப்பா
எம்ஏ கிராண்ட் மெம்பர்ஸ்.
ஸோ இப்போ குறிப்பாக சொல்லணுன்னா, நம்ம இந்த ப்ரோக்ராமே ஒரு பெரிய சக்ஸஸாக இருந்தது அப்படின்னா அதில் முக்கியமாக நம்ம என்ன பண்ணுவோம், சாப்பாடு நல்லா இருக்கான்னு மட்டும்தான் பார்ப்போம். அதுவும் ஸ்டே வந்து ஓரளவுக்கு கம்ஃபர்டபுளாக இருந்ததுன்னா மற்ற எல்லாமே ஓரளவுக்கு சக்ஸஸ்ஃபுல் ஆகிடும். பாலா, நீங்களும் ஸோ சார் நான் சொல்லி முடிச்சோன்னே கொடுப்போம். ஸோ அதனால் இந்த சாப்பாடு அரேஞ்ச்மெண்ட்ஸு எல்லாமே இந்த வென்யூவில் ரொம்ப கம்ஃபர்டபுளாக, இந்த சம்மரில் ஒரு கம்ஃபர்டபுளாகவும், சாப்பாடு வந்து நல்லாவும் இருந்தது, டேஸ்ட்டாகவும் இருந்தது, அடிக்வேட்டாகவும் இருந்தது. வயிறு பிரச்சனை வராத அளவுக்கு நல்லா பண்ணியிருந்தாங்க. அதுக்காக ஸ்பெஷலாக செஃப்பெல்லாம் வெளியிலேருந்து அரேஞ்ச் பண்ணி பண்ணியிருந்ததாக கேள்விப்பட்டேன். ஃபார் தட் ஐ தேங்க் த எம்ஏ கிராண்ட் மேனேஜ்மெண்ட். நம்ம ரூம் அரேஞ்ச்மெண்ட்ஸ்லாம் ரொம்ப பக்காவாக இருந்தது. தேங்க் சார் வேலப்பன் சார் அண்ட் பாலா. தேங்க்யூ. அந்த 2 பேரும் சேர்ந்து வாங்கிக்கோங்க, அந்த சைட் போங்க. தேங்க்யூ. தேங்க்யூ. தேங்க்யூ ஸோ மச். நானும் வந்துடுறேன்.
அரவிந்த் டிஜிட்டல்.
இந்த லோக்கலில் இப்போ இந்த டிசைன் பண்ண எல்லாமே டக்குன்னு அரேஞ்ச் பண்ணி கொடுத்து, லேட் நைட் சொன்னாலும் பண்ணி கொடுத்தாங்க. ஆன் பிஹாஃப் ஆஃப் அரவிந்த் டிஜிட்டல், ஐ ரிக்வெஸ்ட் ஹரி டு கெட் த ஷீல்டு. தேங்க்யூ. அவ்வளோதாங்க சார்.
தேங்க்யூ சார். தேங்க்யூ. PGs, you can collect your CME certificate from Torrent stall in hall number 1. Have you all collected?